Thank you and welcome. Welcome to our second annual Trauma Symposium. For those that were with us last year, you remember what a great event it was, inspirational, educational, and this certainly promises to be the same and more. So thank you for your support and attending. Many of you, or some of you, may be aware that I spent most of my career as an emergency physician working in very busy inner-city trauma centers. And I was privileged to come to appreciate how unique the disease and the biology of trauma is. There are very few diseases that can take an individual from a completely normal, robust, active, healthy life to the precipice of death in seconds or minutes. And there are very few diseases as well that require the entire community and team to come together, where minutes can actually make the difference between regaining that life, or health, or function, or limb. What I will say, though, that's particularly unique in the treatment of trauma care is the incredibly huge team that's required to care for this patient, not just from the minute the accident happens and getting to the care facility and the minutes and sometimes hours in the acute phase of the injury, but over the course of months of recovery. I can't also think of another disease that touches almost every facet of our healthcare organization, every individual. And there's no disease process that requires such incredible teamwork to come up with the amazing outcomes that we experience every day. And you're going to see that today. This isn't a list of trauma surgeons or emergency physicians. This is a list of caregivers that participate in the entire care journey of these patients. We're going to hear from ENT, orthopedics, cardiology, anesthesia, geriatrics, palliative care, primary care. Last year, we were privileged to have some of the caregivers that took care of a patient's story, the patient that came here. The stage was filled. It was incredibly inspiring. So today we're here to learn, but also to honor and to be grateful for this amazing trauma program, and to also thank all of you for that support this amazing program. It makes our patients better, it makes our community safer, but I can honestly tell you that the teamwork they demonstrate makes our entire organization and the care we provide of every patient, trauma or not, better. So I thank you for that. I do have a few reminders to start with. One, just one reminder, is that please remember to sign in for CME. And it looks like there's a beanie, or as I would call as a Canadian, a toque, available to all of you as well. Wear it proudly. I also have the privilege of introducing our first speaker, Andrew Goldman, Dr. Goldman. Andrew Goldman is a double board certified facial plastic and reconstructive surgeon who trained in Brooklyn, New York, and did his facial plastics fellowship in Bern, Switzerland. He spent 3 years in academics as an assistant professor in facial plastic surgery before moving here to Boulder and joining his partners at Boulder Valley ENT almost 20 years ago. He's also the founder and medical director of his aesthetic practice, Boulder Valley Laser and Cosmetic. I know he's excited to be here this morning because facial trauma is clearly one of his passions. Dr. Goldman, please help me welcome him.
Well, thank you, Dr. Vissers. It is a pleasure to be here. I will say that trauma excites me. It was probably one of the first things that really drew me into the facial plastics world, and it's a pleasure to present this talk to you guys today. I titled it Working to Restore Function While Minimizing Cosmetic Impact. And I think that when it comes to facial trauma, that's the way I approach these patients. Because the face is a little different, and you have to think about your reconstruction and how you manage these patients with an eye on how they're going to look afterwards, because you can do everything to really get functional integrity back in place, But if someone's got a big scar across their face, that's what they're going to see, and they're going to be reminded of that trauma emotionally for the rest of their life. So we really want to take a hand-in-hand approach with these patients, and so that's sort of the way I approach these patients, and that's what we're going to go through with the talk today. Thank you all for being here. Do I have the ability to do the slides, or? Big green one? Great. All right. So first thing to highlight to you guys is that every face is unique. There are not two faces out there that are identical, and every trauma is unique. There are no two traumas that are exactly identical. There may be a lot of similarities, but every repair also has to be unique. So again, how we evaluate these patients has to be very single-minded when we approach these patients. So thought I'd start by just kind of highlighting that for you guys. And what drew me to this is the complexities of the things we're talking about here. So when I think about the face, you know, we've got the eyes, we've got the nose, we've got the mouth, we've got the ears, we've got all these areas that we have sensation and we have a need for vital functioning, breathing, chewing, eating, communicating. And so when we repair these things, we have to have an eye on functional integrity for these systems, and then we have to make sure that we support the bony foundations and framework that support those systems. So making sure that the orbital bones and the cheekbones are in the right place after a facial fracture. Otherwise, the eye's not going to be in the right position, and it's going to throw off vision. So these things are all, there's a lot of interplay between these different areas, and again, it's inherent on us to consider all these vital areas when we do the repairs for these patients. But the complexities of these things are very important. And again, when you think about the soft tissue trauma, I don't know if you can see, but a laceration on the cheek here is very different than a laceration that goes through this area, is very different than a laceration that goes through the eyelid area. And again, millimeters can make a big difference here in terms of how we approach these things. So again, even a slight change in position or a slight change in location of a trauma can make a very big difference in terms of the impact on the patients and how we approach the repair. It would not be, I wouldn't be doing my responsible thing if I didn't mention the true emergencies that we see, and a lot of people in this room could probably teach me a thing or two about a lot of the things listed here. But when we talk about facial trauma, I'm going to focus the talk mostly on soft tissue trauma and bony trauma, but these are things we obviously have to remember when patients walk in the door of the emergency room. Are they breathing? Do they have a significant bleeding event that we need to take control of immediately? Or do they have an acute change in vision that needs immediate attention? Once we kind of get past these things, then we worry about the more urgent things. Is there an open fracture that needs a repair sooner than later? Is there a nerve severed that we need to repair more quickly? And then what I like to look at are the penetrating neck issues. Again, an extensive workup that's required there to make sure we don't have any injuries to the deep vessels or some of the vital structures of the airway. And then, of course, unstable fractures. And I probably could have listed, there are some facial fractures that could be listed down here as well, and we'll go through those in a little bit. But I worry more about laryngeal trauma from a pragmatic standpoint in terms of airway instability. Those are the kinds of things that get my attention. So again, we go through this list before we do anything else. But once we go through this list and everything kind of checks off, then we can start to think about the soft tissue and facial bony structures of the face. So when I think about the face, and the way we're taught to think about the face is in mathematical ratios. And so the ideal mathematical ratios of the face divide the face into horizontal thirds. Here you go. So you see that from about the eyebrow up to the hairline is the upper third, and then the middle third from the root of the nose and eyebrows down to the base of the nose is the middle third, which includes the cheek and the eye and the nose, and then the lower third from the base of the nose to the chin. Now, not every face obviously lines up perfectly into thirds, and that's great because that's what makes us unique. But when we start to think about trauma, we want to think about these proportions, and we want to think about the symmetry that people have and trying to restore that. We also divide the face into fifths, so 1/5 being the width of the nose or the width of the eye across the whole face. There's 5 of them. And again, when we evaluate the face, we want to look at these ratios and we want to look at where this face started before the trauma, trying to restore it back to its natural state and to its natural harmony. And again, looking at the functions. We want to make sure that we preserve these functions with an eye on maintaining them and restoring them, making sure that we get good muscle integrity back to allow for good motion and expression, and then of course trying to get natural landmarks and contours into place. So we'll go through these in a little more detail in a second in terms of I'm going to hammer you guys with the themes of some of these approaches. When we talk about soft tissue stuff, we really want to try and hide scars into these dark lines wherever we can. These dark lines here along the borders of the nose or along the borders of the creases between the nose and the mouth or along the chin, where we can hide a scar into these locations, the scarring is going to be much more superior. A lot of times you can't, right? If you get lucky and there's a laceration in that location, you're great. But if not, then we want to look at the other picture here, the relaxed skin tension lines. And these are lines that are different angles across the face. And you'll see even like within the nose here, there's vertical lines here and there's horizontal lines down here. So again, millimeters can make a difference of how we want to orient some of these scars. And not every scar, not every laceration or soft tissue injury gives us the opportunity to hide within these lines. But when we can, we're using the muscles of the face to help us get a favorable scar. And when we have to be perpendicular or vertical to these lines or diagonal to these lines, that's where we worry about scars not healing as well. So again, this is the ideal, and this is what we're going to shoot for, and where we have the options to rotate tissues or change the direction or dynamic of a scar, we're shooting to try and be somewhere along these lines in different parts of the face. So this is the way I approach things, and I sent the slide in to Josh, and I realized that I should have put something at the top here. Before we repair anything and before we anesthetize and sedate patients, we really want to do an evaluation to make sure that they have their nerve function. And so that can be a very quick thing. You can have someone smile, you can have them raise their eyebrows. You just want to make sure that there's nerve integrity and that the nerves are intact before you actually get too far along. Because once you start anesthetizing the patient and sedating patients, if it comes to that, you really lose the ability to see if that nerve is functioning. So I apologize, this is on me, but I should have put here check nerve function before everything else, first and foremost. Once you establish nerve functioning is there or not there, either way, then I always say it's important to get these patients comfortable, because when you start cleaning these wounds, it's uncomfortable. I don't know if anyone here has been through a facial laceration or any laceration for that matter, but when you start irrigating it out and exploring it, it's really not the most comfortable situation. And the patients have already been through a trauma. So I always say the patients have already suffered enough. We try not to have them suffering more than that. So getting some good local anesthetic in there or sedation if we need it, and then doing a very good job of cleaning the wounds thoroughly. And I'm always very impressed with the team that I've seen at Boulder Community's emergency room in terms of their ability to get wounds clean. Really great stuff. And then exploring and making sure that we understand the exact nature of the wound. A lot of times skin can kind of be pulled one direction, and you might have an avulsion that goes deeper under the skin that you may not appreciate. So getting an instrument or a finger in there or get a Q-tip in there and really kind of seeing what's been traumatized or what tissues have been violated by the trauma. And again, having checked for nerve functioning beforehand, you'll get a sense for that as well. And then it's a very meticulous repair of each layer, one at a time. If there's a nerve injury, we start with the nerves. And nerves in the face often require microscopic repair if they're injured. Fortunately, we don't see them injured all that often. But when we do, we can get good recovery if we get to the repairs pretty quickly. And then it's reattaching muscle to make sure that we get good motion and restore the ability to make expressions and have functions around critical structures, and then meticulous closures of the soft tissue to make sure that we create as little obvious physical scarring as possible. Again, working within facial subunits and using those relaxed skin tension lines where we can, okay? Now, a lot of people walk into the ER with soft tissue injuries, and many of them are very straightforward, right? You get this kid here, he walks in with this. You just have to say, okay, kid, raise your eyebrow, make sure that it goes up. Once the eyebrow goes up, you feel pretty comfortable that the nerve is intact, and you can quickly gauge the depth of this with a Q-tip, a little local anesthetic, and you clean it up, and you're off to the races. This one over here, again, if you start to see something a little wider and you feel like you're seeing muscle in there, again, having this patient smile to make sure that the nerve to the zygomaticus muscles are intact, or having them close their eyes to make sure the nerve to the orbicularis muscle is intact. And then a thorough cleansing and layered closure. And again, this is going to likely sit right along that curve of the cheek, so this is going to be a more favorable scar to begin with. You're not going to have to do anything fancy here. And then, we'll hopefully see a pretty camouflage scar over time for this patient. Where we get into some more complicated things is when soft tissue trauma crosses a boundary, or crosses a border of a tissue, and certainly that's true around the lip and the mouth, or around the base of the nose, or around the eyelid. And in these types of approaches, you need to, again, do the same things, check for nerve integrity, and then do a thorough cleaning after you anesthetize the patient. But then you've got to get some good muscle closure here to reinforce this so that you're not going to get any muscle pulling this apart when you go to chew and talk. But then you have to do a very, very meticulous approximation of the vermilion border here, or of the eyelid here. I can't really see it as well, but right there, you have to get these structures closed in a way that there's no step off. The step off creates a shadow, and it's the shadow that's going to attract attention and remind the patient that they have a scar there and remind them of their trauma. So where you can get a nice smooth closure there and get things closed in a meticulous fashion that does not create a step off, then you will spare the patient a noticeable scar, and that's the goal here. And then, of course, we get complex soft tissue injuries, and these become a bigger issue. You get some things that are through and through defects that require closure on the inside of the mouth, and of course, you've got to worry about nerve integrity here. It looks like this nerve has been traumatized, with the lower part of the lip here looking like it's sagging a little bit. And these are where the creativity of the trauma surgeon come into play, because there's a couple different ways we can close this. Again, the key is, if we establish that there is a nerve injury, reestablish that nerve integrity. But then it's a question of really getting these muscles back into alignment, the muscles that are going to reestablish the ability to close the mouth and to chew and to talk appropriately and to get good functioning of the expressions of the face here in the lower part of the face. And so how we get those muscles closed and how we rotate them into place, and then trying our best to reapproximate boundaries and hide scars as much as possible. And again, I always tell people, when it comes to these types of more complicated traumas, these are often multi-staged events. You are not necessarily going to get a perfect closure on this and have it be done one time. And so I think it's an important thing to manage expectations and set that right out of the gate with the family of these patients and with the patients themselves, is that we're going to do everything we can to get this done as nicely as possible on the first go-around. But there's a distinct possibility that we're going to need to do a little revising of scars in here, whether it's defatting scars to make them less plump, whether it's revising the scar line itself to make it less noticeable. And again, sometimes that's non-surgical, sometimes it's surgical, but again, there's some work that may need to be done with these more complicated traumas, and setting that expectation up front can be very helpful to the patients and their families. I put this up here not to gross you out. I know it's first thing in the morning, and I know probably it's not the first thing you want to see in the morning, but I put this up here because I want to make sure that everyone understands that the face has an amazing propensity to heal. And no matter how bad it looks when someone rolls in the door, if we take our time and do things meticulously, the end outcome, the eventual outcome for these patients is often stunningly great. And so you just have to kind of catch your breath, as I put here, and really do a thorough job of assessing this wound, cleaning it up, and really start slowly. Start in one area, take it one step at a time. This is going to take hours. This is a 4, 5, 6 hour operation. But if you really take the time to do it right, knowing that, again, you might need to do some revision work over time, but you can get to an outcome where this patient's walking down the street every day and no one really knows what happened to him. And if you looked at his picture coming into the ER, you can't believe that he got to that place. But that's not uncommon with facial trauma. So again, give every one of these patients the time and the effort that you can, because there's going to be plenty of these patients that are going to come through this and look really pretty remarkable once it's all said and done. The kid was a dog bite. A lot of these are avulsion. The bigger ones are avulsion injuries. So riding a bike at high speeds and hitting the pavement. Pavement doesn't have a lot of give to it, and so the soft tissue does. And so a lot of the bigger injuries are more avulsions. We had a guy who, I think he was rock climbing a couple months back, and he avulsed the lower, half of his nose, by hitting a rock on the way down when he fell and missed a spot. Thankfully, he was roped in. But a lot of it's your face is hitting a structure that doesn't have a lot of give to it, and you're hitting it at a speed that creates more of this avulsion type of stuff. Dog bites are big, especially around the mouth. Dogs seem to really clamp down on the lower lip area and vermilion and corner of mouth, which are very complicated repairs. And some of those we'll send to university, frankly, because they're over the level of what we're going to do for them at BCH. We'll do plenty, but sometimes it's a little bit above our abilities, especially if there's flaps, bigger flaps, not just rotational regional flaps, but if we're pulling tissue from an arm to reconstruct a face, we're sending that out to university. And I always, again, I like something like this because I think this is the practical stuff that everyone should know. Scars can be managed across a long period of time, and there's no time limit into when you manage scars, how you manage scars. Immediately getting good cleaning, getting good closure, and doing the best job you can. In the first couple of weeks, reinforcing the scar, I like to use a lot of steri strips on the face after I take stitches out. We don't like stitches beyond 7 or 8 days. Steri strips really help kind of keep that scar in a good place while it's doing its initial healing. When you don't have steri strips, keeping it moist to allow the cells to do their job, but critically avoiding the sun. And one of the ways I tell people to avoid the sun is to use a silicone scar tape. The silicone scar tape looks like a Band-Aid, but it doesn't have a little gauze in the middle, but it actually helps reinforce the scars, but it covers the scars. So if I get someone who says that they're going to Mexico 3 weeks after they got a scar, I say get the silicone scar tape and cover that scar so that you don't even have to worry about sunscreen. And so you're getting the double benefit of reinforcement plus the coverage. We definitely can do some massage work after about a month, so you can massage scars with fingers and hands and little vibrational tools. The breaking up of that collagen can make a big difference. And then we certainly have plenty of laser opportunities in the first 6 months, and then surgical repairs, which we can do basically any time. So there's a lot of things we can do to manipulate scars and get improvement in these things over time. All right, let's transition to even more fun for me is the facial bones. And again, just a quick review. Today we're really going to talk about mid-face fractures, fractures of the cheeks and the maxilla and the area and the bones around the orbit. We deal with frontal bone fractures as well. We usually have the mandible fractures repaired by the oral surgeons at Boulder Community Hospital. But these are the main areas that we're talking about. And again, there's a lot of little bones. This is an oversimplified version of this. There's a lot of tiny little bones in between and behind all these structures. But again, from a facial trauma perspective, those aren't always necessarily need to be repaired, and we'll go through that right here. When we think about the facial architecture, if you fracture your arm or your leg, you need to set that bone to have normal functioning back restored of that arm or that leg. The face is not that way. The face is a scaffold of vertical and horizontal supports that we have to repair when the support itself is violated, when the thicker bone of that support is violated. But when the support is not violated, we don't necessarily have to fix it. So when you look at the vertical supports, we're looking at the green line here, which we call the nasomaxillary or medial buttress of the face. And this is supporting the anterior teeth when we chew. It's supporting the nose when we breathe and some of the eye up here. And when you have a fracture that violates that, we have to fix it. But if you have a fracture right behind that area, you don't necessarily need to fix it. Same is true with the blue line here. This vertical support here we call the lateral buttress. It extends from the superior aspect of the orbit through the frontozygomatic region here, and then through the malar region here, and then through the lateral maxillary region here. And again, there are going to be fractures between these two lines that don't need to be fixed, but when you violate the thicker bone of this, you need to have it fixed because it's an unstable fracture. Similarly, we have horizontal crosses that make the horizontal cross supports that make the scaffold work. The frontal bar across the top part of the eye and the forehead on both sides and the nose. The middle one here, the red one that goes basically from the arch of the cheek, the zygoma, across the cheek and orbit and across the nose, and this creates the middle support, and then the lower support here, which is really the upper teeth and the palate. So again, where these things are violated, we need to fix them. Where things are not, where these are intact but other bones are fractured, it may not be an operative need for repair, okay? So there was a guy in France in the, right after World War I named Lefort, and Lefort decided he was going to walk around the fields of Normandy, I believe it was Normandy, and drop stones and rocks onto facial skulls that were sitting on the ground already, and he noticed certain types of patterns would emerge from his experiment. I don't think he got IRB approval for that, by the way. I'm glad you're awake. But he noticed was a horizontal pattern in the lower part of the cheek here that went through the nose, and he named that Lefort 1. And then he noticed a second pattern here where it went up from the cheek up across the inside, the medial portion of the orbit and the orbital rim, and across the nose, and he called that triangular pattern Lefort 2. And then he noticed a third pattern where the trauma came across the frontozygomatic region, across the orbit, and across the nose in a horizontal way higher up in the face, and he termed this Lefort 3. So we see these types of fractures, and we do call many fractures these types of fractures. What changes, Lefort 1 really has to do with violation of that medial and lateral buttress like we talked about here in the lower portion. What separates these types of fractures, the Lefort 2 and Lefort 3, from a just basic zygomatico-maxillary complex fracture is the extension across the orbit. So we see a lot of fractures that we call zygomatico-maxillary complex fractures or trimalar fractures. And the reason we call them that is because the malar bone, which is where my pointer is there, is the thickest part of the cheek right there. The bone is very thick. So when you hit your cheek or someone hits your cheek, the fracture doesn't usually occur right across the cheek. It occurs up here, it occurs in front here, it occurs out here on the side, or occurs down here. And again, we'll see 2, 3, or 4 of those fractures at a time very commonly, whereas the cheekbone itself doesn't, the cheek itself doesn't fracture, but the areas that are sort of adjacent to the cheek fracture. And we'll see a lot of these fractures and not necessarily a lot of these. And again, the reason is because this is a higher level of impact that causes the trauma to go across the eye and across the nose, creating a more unstable situation. Okay? How do we repair these fractures? Well, again, my job is to minimize someone's emotional baggage that comes with the trauma as much as possible. Someone got traumatized, whether it's a car accident, whether it's getting hit by somebody else, whether it's falling off of a bike or snowboarding or whatever it is, they are already going to be suffering from the trauma emotionally anyways. My job is to try and make sure they don't see a scar that they're going to then notice for the rest of their lives and see in a daily fashion. So the way we do these cases is we start with thinking about approaching the cheek through a gingivobuccal incision, an incision that goes above the teeth under the upper lip. We use an incision in the upper eyelid up here to approach the upper part of the orbit, and we use an incision in the inside of the eyelid, the lower eyelid there, to really minimize the scarring so that we can approach the inferior orbital rim and orbital floor. So what does that look like? Here's a schematic that shows us making an incision in the area above the teeth underneath the lip. With the lip pulled away, you can see the nose here. And here's what we can do with that fracture. We can, through this approach, we can see all the way up to the eye, so we can get a good exposure of the entire cheek this way. And here you see a reestablishment of the lateral buttress and the medial buttress with titanium reduction plates through that approach. So a very novel way of doing that. And then we use this transconjunctival incision here, or this lateral blepharoplasty incision way out here to approach the orbit itself. And again, these are very well hidden incisions, and you can see the approach here. We're just going to make right in the inside of the eyelid there down to the orbital rim. And again, these are just tried and true and really work beautifully. And again, we can hide our incisions and our approaches so that patients aren't fully reminded about their trauma on a daily fashion. So I thought I'd do a quick case presentation for you guys. Someone who came into the hospital about 3 months ago, a woman who fell from a height and had some other multiple orthopedic issues that she was dealing with at the same time, and had a pneumothorax and some rib fracturing. She had really crushed her face. She landed and hit her face either first or within one of the first two places she hit, and had multiple fractures on both sides of her face. We characterized her right side as a hemi-Lefort 3 and Lefort 2, and her left side as a hemi-Lefort 1 and a zygomaticomalar complex fracture. So she touched all the bases for me for this talk because it got all of them in there. Which again, there's a little, you could characterize these a little differently and still be correct. But she really did a good job, especially on the right side where there was a little more intensity of trauma and really crushed the bones around her eye. And here's her initial axial CAT scans. Whoops, how do I go back? The red? Let's see, her axial CAT scans, you can see a lot of rotation here in the bone here with some comminution here of the bone on the right cheek, and you can see that propagates up a bit and really is rotated in quite a bit. The axial scans give us some view here, but the coronals we'll look at in a second give us even more view. You can see a fracture here just inside the malar bone where it hits the inferior orbital rim. You can see fracturing out here in the frontozygomatic region right there, and really she has that on both sides. I can't see it. There's there on the right and over here on the left. And so she really did a good number on herself. If we look at the coronals, again, not the cleanest reconstructions. You can see the Lefort 1 fracture through the medial buttress here on her left side. You can see a lot of crunching and rotation in this cheek. I'm trying to see here. You see the orbital floor really displaced quite a bit. And again, loss of integrity of that lateral buttress. Can't see so well. You guys hear me okay? Good. I'll be able to see better if I can stand here. But you can see displacement here at the orbital rim and floor, and then here at the lateral buttress. There was a good shot, I'm not seeing it here. Good fracturing right there on the left side. But she had a lot of displacement. She really did a good number. This is the floor of the orbit here that's just really crushed on that right side with no integrity left to it whatsoever. So she did a good job, and we had to go back in and fix her. And we did it through the approaches that I just described to you guys. And here's what she looked like on her 3D reconstructed CAT scans. And I like this view because it shows kind of where we put the plates. You can see on the right side we have a plate here on the frontozygomatic suture. We have a plate here underneath her eye that holds that bone together, the inferior orbital rim. We have an L-shaped plate right there that holds the lateral buttress on the right side together. And then if you look at her left side, we put a plate here on the orbital rim, again more laterally where that fracture was, as well as a plate, L-shaped plate right here to reconstruct the lateral buttress, and a small plate right here to reconstruct the medial buttress. You can actually see that fracture through the medial buttress right there, which is kind of cool. And she did very well. We got the bones back in good place. And here's her post-operative coronal CAT scans. You can see the plate here along the orbital rim here. You can kind of see some screws in the lateral buttress here, as well as the medial buttress over here. Again, the lateral buttress reattached and sitting in a good position here, as well as this one down here. And so this is what we're going for. We're going for a good reduction of these bones over time. You can see a good reduction of the frontozygomatic region up here. And we really, again, we want to get her to a place where she has good function and good cosmesis. And here she is 2 months later. And again, you'd look at her and you would say nothing happened to her. You would never look at her and realize that she had every bone in the front of her face crushed because we did this through hidden incisions. So she has a little bit of residual cheek swelling here at 2 months, which is very typical, a little asymmetric, which is fine. She's having a little bit of swelling, a little displacement of that orbital floor implant that we may need to trim back over time. But again, she's walking down the street. No one's noticing that she had significant facial trauma 2 months ago. She's looking in the mirror, and she's not constantly reminded that she had a facial trauma event a couple months ago. So that's the goal, is restoring function and getting to a place where people are cosmetically appropriate. So what I'd like to finish with is just to say, when you see these patients, again, a thorough assessment to make sure we know what functioning they have or do not have coming into the emergency room before we start any repair, and then doing a very thorough job of reestablishing that function and structure to the degree that we can while trying to minimize the cosmetic impact. I'm sure many of you have heard of the story of Phineas Gage from the 1840s, who had a railroad mishap drive a metal rod through his skull, and again, miraculously survived. And that's, again, my last take-home point, is that there's an amazing propensity to heal in these areas of the body. So our job is to be as thorough as possible and to give these patients every chance they can at a good healing event, because a lot of them will get to that place. And with that, I say thank you very much. And I'd love to entertain any questions you guys have. I know it's early. Yes? How much chronic pain?
Yeah.
Very little, honestly. These types of fractures and soft tissue injuries usually do not have a lot of pain. You get pain around some of the contractile nature of the soft tissue on the bone. But when you do the repairs, especially if there's bony fractures and you get the fractures realigned correctly, there's usually not a lot of pain at all. It can be in the first couple of months there's some achiness to it, but generally you don't hear a lot about it. And again, breaking up collagen with a little massage can make a big difference with that stuff. But pain is not usually our biggest threat with these, both when they come in as well as long-term in management. Not a common complaint. Yeah.
In terms of EMS, or first providers that arrive at the scene, is there anything that you would suggest that we do or don't do that would either hinder or help the healing process besides airway management?
Yeah, no, I love that question. I would tell you that the earliest that you can document nerve function is critical. Because again, when a patient comes in, if they are starting to get obtunded, or if they're starting to have some delirium or some other effects of the trauma, if you arrive at the scene and establish that someone's airway is okay and they're not in an unstable situation from an airway or bleeding standpoint, if you just have them, if you notice an injury on the face and you just have them smile, lift their eyebrow, close their eye real tight, check the integrity of the facial nerve, that is the most crucial thing. Someone can live with numbness for the rest of their life, but they really have struggles if they can't smile. And so again, if you can make that assessment early on and chart that assessment early on, I think that's the most critical help that I can imagine. I grew up in a day when we used peroxide and betadine on all the wounds to kind of get the cleansing going, and I know nowadays that's kind of taboo. So I don't know if that helps or hurts. Maybe it hurts to do that stuff, but again, the wounds will get washed in the ER. You don't have to worry about that. So I don't think you're going to do anything hurtful, because you guys are usually very on top of making sure you don't move things around too much anyways. My issue would be if you could get any assessment of nerve function ahead of time, that makes a big difference. Great question. Yeah. Yeah, when you just get an acute nasal fracture and just the nose bones kind of get popped over, you have about a 10-day, maybe up to 14-day window, depending on the age of the patient, to pop it back over. Theoretically, it could happen in the ER. It's really up to the person doing the treating if they're comfortable with that or not. I will tell you that when the nasal bones fracture, it's not just the two nasal bones coming off the cheek; it's the septum on the inside too. And so all three of those bones kind of fracture together. And you got that old hockey coach approach where you just kind of push the fracture back into place. And we have tools that we can do that in the office or in the emergency room. The problem is, and that's very uncomfortable, but it only takes a minute or two. The problem is that getting the septal part, that in-between part, back into alignment is even more uncomfortable. And I find that if the septum is fractured to any degree, I really like to give the patients the 5 minutes of anesthesia that it takes to do it with them sedated, because I think we get a better result. There are plenty of fractures where it's just a little bit of, the nasal bones at the top that are just, torqued over a little bit, and you can basically pop them back into place, and it takes a minute. And again, we can do that in the office, we can do it in the emergency room. You have about a 10 to 14 day window to do that. But a lot of the times when I see these patients, I opt for trying to get them in the operating room within that 10 to 14 days. So again, where we can see them faster, that helps. Sometimes swelling makes the exams a little hard, but it still makes it a little easier on the scheduling side if we can get in front of it a little bit. So that we don't, if we wait 2 weeks to see them, we might be beyond that window. So we do want to see them quickly. Yeah. Yeah. Well, she's still recovering. She's about 3 months out now. Again, that residual edema, that residual swelling that people get in the cheek is not uncommon for about 3 to 4 months. Patients will have some numbness in the cheek after these traumas and after these repairs that can last, again, about 3 to 4 months. But the further out you get, especially after that first 4 to 6 weeks after the trauma, the recovery is a very smooth process and usually a pretty linear process for most patients, where you're just kind of waiting for that residual swelling to go away and for the numbness to fade away. She's on the tail end of her recovery, though. She's pretty functional and feels pretty good. Again, we have a little bit of work to do around that right eye still with that orbital implant that's migrated a tiny bit because it was so big. But other than that, she's in really great shape. Great question. I tell people the minute we get those plates and screws in there, they are stable and they can eat and drink and have the normal functioning that they want with their facial bones. Again, a lot of the facial bones is structurally there to support structures of the nose and the eye and the mouth. And so the supportive nature is there immediately. Chewing is the one force that we're trying to work against, that the bones have to basically be able to resist the force of chewing, which can be strong, because when you bite down, it can be a lot of force. But when we put those plates and screws in there, there's a lot of stability immediately, and they can have normal functioning right away. So there's no delay from my perspective. Once we get those plates and screws in there, they can eat and drink normally and have normal functioning right out of the gate. Yeah.
For those those unstable fractures that come from soft tissue trauma, is there special considerations in wound care that we need to be concerned about here without making these fractures worse?
Not really. I mean, you're talking about the unstable Lefort 3s. A, they're very uncommon. And B, to get a bilateral Lefort 3, which is technically the dissociation of the facial skeleton from the skull, which is an unstable fracture, more from an anesthesia and I guess the nursing perspective of, you've seen that picture of someone putting an NG tube in the nose and it ends up in the brain. And you certainly want to be cognizant of that stuff. But the reality is that I've never seen anyone have an airway issue because of a Lefort 3, a bilateral Lefort 3, even though we talk about it. I just, or even, an extensive Lefort 1, where the palate and the lower half of the maxilla are theoretically disconnected from the rest of the skeleton, and theoretically that could fall back into the airway. I've never seen it, and so I don't want to minimize it for sure, because I think that would be irresponsible. But in 25 years of covering a lot of trauma over a lot of different places, I covered 7 trauma hospitals and 6 trauma hospitals in Brooklyn for 4 years. I did a fellowship where we did trauma every day. I never saw that issue come up. And so I don't know that I think it's an academic exercise. From a soft tissue management perspective, I wouldn't push real hard. I wouldn't try and make it an issue, that's for sure. But I think, again, if you're talking about cleaning wounds, just be gentle. I mean, the face, you just want to be gentle with it to begin with, so. Anybody else? Or we'll switch to a different part of the body? All right. Thank you, guys.
morning. I'm Laura Harmon. I don't know if I know all of you. I'm the Trauma Medical Director here at Boulder Community Health. Thank you so much for coming to our party. We have some really great speakers today, and really an opportunity for me to show you all of the amazing people here at Boulder Community Health. So thank you, Dr. Goldman. Next up is Dr. Gross. Dr. Gross is board certified in orthopedic surgery and orthopedic trauma. He joined Boulder Center for the Orthopedics in 2022 and very rapidly became our orthopedic trauma medical director for Boulder Community Health. Last night I was working on my bios for all of our speakers and Googled Dr. Gross. There's a Dr. Gross somewhere in the Northeast that likes to fish. Do you like to fish? Not this one. But I did find out that this Dr. Gross, besides being an amazing surgeon and just really an asset to our program and great leader, is also a musician. So maybe when he's done talking about bones, he'll tell you a little bit about music.
Good morning. Happy to see everybody. Thanks, Laura, for inviting me to talk today. I'm going to make sure I can get this thing figured out. Which one's the laser? This one? Okay. Cool. Great. I'm going to step a little bit off to the side so I can kind of keep an eye on what I'm doing over here, too. So thanks to Dr. Goldman for a fantastic talk. I think that he and I were talking before the conference started, and what I didn't get to tell him was I actually seriously considered going into ENT and medical school, and so this is a fun talk to have me listen to. And I think that the pelvis, much like the face, is a little bit of a black box. There's a lot of facets and nuances to it that aren't necessarily apparent, and so I think this is a good topic to cover, especially with us getting into summer trauma season. We're going to start seeing pelvic fractures a little bit more regularly as the energy of the injuries that people sustain starts to increase again. So I'm going to be talking primarily about what we do with pelvic fractures, how we identify them, and how we manage them in the initial phase, which is probably going to be relevant, I think, to most people in the audience. So let's see how we do here. So my goals for this presentation, I'm going to spend a little bit of time talking about anatomy, kind of open up that black box a bit and try to help everyone understand a little bit more about what's going on inside the pelvis, and also explaining a bit about fracture pathology. Of course, we want to talk about optimizing the early management of these injuries. And also, I want to, at the end, we'll provide a little bit of insight to talking about how we fix the patients. So we'll start simple. At its most basic form, the pelvis is made up of 3 bones. There's the sacrum, which is the base of the spine and lies posteriorly, and then there's 2 innominate bones, which form the 2 halves of the pelvis. And innominate literally means not named, and that's because the bone is kind of a weird shape. It doesn't necessarily have a name unto itself aside from just the bone that's not named. And then the other landmarks in the pelvis, we have the 2 sacroiliac joints, which join the sacrum to the iliums, which are the part of the innominate bones. There's the pubic symphysis, which is the midline in the front where the 2 innominate bones join. And then the acetabulum, which is the name for the hip socket, and we got 2 of those too. So this diagram kind of illustrates a bit of the different regions of the innominate bone. So we have the ilium, the ischium, and the pubis. Those are the 3 regions of the innominate bone. And the pubis is broken down into 3 different regions: the pubic root, which forms a little portion of the acetabulum and the very beginning of the ramus; pubic ramus, which is that bar of bone that runs in the middle of it; and then the pubic body, which is the midline portion of the pubis that forms the pubic symphysis with the opposite side. There's not going to be a test on this. The purpose of this slide is really just to kind of show, we can kind of look at the bones and look at an X-ray or even a CAT scan and say, okay, yeah, that's the pelvis right there. But there's so much going on the inside, right? This is a super complicated area with a lot of really high-priced real estate running through it. A lot of really important nerve structures, vascular structures, and visceral structures as well that run through the area. And so when pelvic trauma occurs, as nasty as an X-ray might look, what a lot of times the major concern is actually what's going on that can't be seen on the x-ray, and this is just an example of all the stuff that can run through there. I'm going to spend a little bit of time just kind of going through this. Though this is the venous anatomy, and we'll talk more later why this is so relevant, but there's a tremendous amount of vein activity that runs through the sacrum, around the sacrum and in the posterior part of the pelvis. We have the inferior vena cava that branches off to all the different vessels, and there's a super highly complex venous plexus that runs through this area. So pelvic fractures, as I think many people are aware, are dangerous. They can be dangerous. Not all are, but many are. And they can be life-threatening injuries. And as with many things in orthopedics, there's two general populations that get fractures, pelvic fractures. There's high-energy trauma, which can happen in any age group. And then low-energy fragility fractures, which we typically see in people who are in the elderly demographic, but could technically occur in anybody who has any kind of impaired bone density issues. And there's two overall categories of injury to the pelvis. There's the pelvic ring, and then there's the acetabulum. And so these are two x-rays that kind of show the difference between that. So a pelvic ring injury is when the general structure of the pelvis, the innominate bones and the sacrum become disrupted, and that general shape gets altered. And that's on the left, and the x-ray on the right, we see an injury of the acetabulum, right, which is an injury to the hip socket, a fracture of the hip socket itself. And so acetabulum fractures, which are near and dear to my heart, and while serious and complex injuries, are unlikely in isolation to result in any kind of major hemodynamic problems. There's a low risk of acute decompensation. They're often difficult, especially in the field, to distinguish clinically from other hip or proximal femur injuries. And there's nothing really that's quote-unquote special, right, that we need to worry about from an EMS perspective or even initially in the ER. The caveat there is that a lot of times a patient with an acetabulum fracture, before we even know they have an acetabulum fracture, they're going to meet criteria for thinking about a pelvic ring injury in the field. And then once x-rays are obtained, of course, we'll get some more clarity on what's going on. So pelvic ring injuries, though, by contrast, are among the most potentially lethal bony injuries that exist in the trauma domain. There's a propensity towards internal hemorrhage, and these patients can rapidly decompensate. And so the focus of this talk is going to be to kind of narrow in on pelvic ring injuries. That's going to really help us kind of distill what's really important for these people. So talking about the pelvic ring, so true to its name, the pelvis functions like a ring. It's mechanically very strong. For any engineers in the audience, a circle or a ring is a very mechanically strong structure. It resists force very well. And so the pelvis is very, very good at resisting force in general until, of course, it breaks. And so generally speaking, when we talk about a ring, rings typically have to break in two places if they're going to break. And so a pelvic ring injury is typically going to break in two or more distinct locations in the pelvis. If you want to imagine just taking like a circular pretzel type thing and you try to break it, you're going to have a really difficult time breaking it in just one spot if you try to break it. And the pelvis is the same way. So typically when we look at a pelvis x-ray, if someone looks at a pelvis x-ray and they see maybe an obvious injury in just one area of the pelvis, it would be very unusual for there to not be a second one somewhere else that maybe isn't seen quite as well on an x-ray. And a CAT scan will, of course, pick that up a bit more readily. So in the pelvis, injuries can be bony, purely bony, where just the bones break and the ligaments and the joints don't separate. They can be ligamentous, or a combination of the two. In this image on the left here, we have widening. The arrows are helpful here too. We have widening and disruption of the sacroiliac joint right there, and then widening of the symphysis pubis right there. And then for the injury on the right, we have a fracture cutting through the pubic body right here, and then some ligamentous disruption as well. And so all these structures can be in play when someone gets a pelvic ring injury. So this is the basis for how we describe pelvic ring trauma. This is a representation of what's called the Young and Burgess pelvic trauma classification system. And so there's these different categories that come about, and they're named by the kind of impact that happens to the pelvis when the trauma occurs. So what we typically call an open book pelvic injury is actually an anterior posterior compression injury. So typically this is going to be an impact from the front of the pelvis, kind of directly from front to back. And this causes the pelvis to open up. And so from types 1 to type 3, we see increasing amount of severity of the injury and increasing amount of displacement. There's also something called a lateral compression injury, which is where the force comes from the side. Typically, this is from an impact that hits first the upper part of the femur, and the femoral head becomes like a pile driver that pistons itself into the pelvis, and that causes the pelvis to compress itself inward. And then vertical shear, which is more typically from a fall from height, someone landing on their foot, and the force drives the limb force up into the pelvis and then shears the pelvis vertically. And then what's not listed here, but is also often in play, is the combined mechanism, where it's more than just one pure kind of vector of force. So I think from a practical perspective, when we look at these injuries in the ER, we get x-rays, we get CAT scans, there's two basic categories though. There's the volume expanding ones and the volume compressing ones. So things that tend to cause the pelvis to open up or create more volume are in a bit of a different category from the lateral compression ones that actually close the pelvic volume down. And there's different considerations, especially for the volume expanding ones we'll get into. So the volume expanding ones are typically much more life-threatening. Statistically speaking, there's a much higher incidence of vascular injury. There's way more room for blood to accumulate in the pelvis when it's opened up and there's more volume on the inside. And they're not necessarily higher energy though. It all has to do with how the energy is acting on the pelvis, right? So you can have a super high energy lateral compression injury that can be devastating to the patient, but it's maybe less likely to cause internal hemorrhage and rapid death, as opposed to maybe a slightly lower energy open book pelvic trauma. So high energy pelvic injuries, we're all pretty familiar with what can cause these, but MVAs, MCAs, pedestrians struck by motor vehicles, falls from height. Classically, as with many high energy injuries, these often occur in a younger patient population, but any age can sustain high energy trauma, and this is a really important point, right? So we often think about kind of little cracks in the pelvis being from an elderly person who fell, but someone who's in the older age group can also be in a car accident, and they can also have really significant pelvic trauma that can happen. And then, of course, the higher energy injuries often have associated injuries as well, such as, for example, a Lafort fracture, like with that one patient. We can anticipate that pelvic trauma may accompany any blunt high energy injury mechanism, and this is important, right? So in the field or when someone rolls into the trauma bay, if there's been a blunt high energy impact to a patient, we have to assume that there is the possibility of pelvic trauma. And distracting injuries may be present, so the patient may not necessarily localize pain to the pelvis. Associated injuries that we often see, we see chest trauma, hemothorax, pneumothorax, that type of thing. Head injury is super common, especially with the lateral compression injuries. Long bone fractures are common as well, spine injuries, and then visceral organ injury, and the liver and the spleen are often implicated with people who have pelvic trauma. So by contrast, low energy pelvic injuries, this is our classic kind of trip over a rug, or the dog knocked somebody over, they fell in a parking lot and landed on the side of their hip, and then they have a pelvic fracture on the x-rays. And so typically this is a fragility fracture found in those with low bone density, and the most common demographic there will be the elderly patient. Frequently these occur in isolation, so we don't usually see a lot of associated trauma with these, although it certainly can happen. And usually it's a lateral compression pattern. So this is someone who falls on the side of their hip, and the femur just kind of crunches the pelvis inward. And in someone with normal bone density, this would not be expected to cause a fracture. In someone with some weaker bones, that can be what happens. And this is X-ray kind of shows that a little bit. It's subtle, but so there's like a little crack right there in the front of the ramus there near the pubic root, or near the pubic body, and then usually the sacrum has a little crunch in it as well. So some low-energy pelvic fractures can be unstable enough to warrant surgery, though often in this patient population, when we do surgery, it's not necessarily because it's super unstable. We do it because it makes them feel better, helps them get up and walk faster. But life-threatening hemorrhage or hemodynamic instability is really pretty uncommon because there's just not enough energy to impart to the pelvic structures that causes disruption of them in any meaningful way. So with that introduction behind us, we can kind of get onto some kind of clinical side of stuff, right? What we need to do for these people. So the goals of care in someone who has a pelvic fracture, right? We want to first identify it because it isn't always readily apparent that someone has an unstable pelvic fracture. We want to control hemorrhage and stabilize any kind of bleeding that's going on internally. Resuscitation is, of course, important. Stabilize other injuries and then move on to definitive management of the patient. So as I mentioned earlier, it's really important to consider the mechanism, right? If there's a high energy blunt trauma, we got to think about the possibility of there being a pelvic ring injury. Subjectively speaking, about 2/3 of patients with unstable pelvic fractures will report pelvic pain. And so that seems like, okay, that's pretty good, that's over half, but that also means that 1/3 of all patients with an unstable pelvic fracture will not report pain around their pelvis in the field or in the ER initially, right? So we have to have a really high index of suspicion. And this probably the same third of patients are the same people that probably aren't even going to report pain when you examine them there. You could push on it, poke on it, pull on it, and they're not even going to say they hurt. And I've definitely seen patients who have horrible looking x-rays and who say, oh, I don't really hurt that much there at all. I mean, it's pretty impressive sometimes that people somehow don't feel pain there. Direct manipulation of the pelvis is to assess for instability, right, which would be our thought, like how can we have an objective measure to figure this out? Well, this is also unreliable. There's been some studies shown on actually examining the pelvis and how the inter-observer reliability is actually pretty poor when it comes to examining the pelvis in general. So it's not necessarily a reliable indicator. And in general, when someone's out in the field, EMS is involved picking up these patients, we don't really want to be putting our hands on someone's pelvis and rocking and rolling it around to see just how unstable it is. It's not really the best thing to do to somebody. But even in the ER, we're going to probably check it, and that's going to be part of the C for circulation portion of the primary survey. That will typically be where someone will put their hands on the pelvis and just check it to see how unstable or if it is unstable. So exam findings to look for, right? So there could be bruising, and this is a big indicator, right? Bruising around the pelvis, around the genitalia in particular, is often a good sign that there's something wrong going on in there. Looking for rectal, urethral, or vaginal bleeding is very important because if there is any of that and there's pelvic trauma present, that's basically an open fracture until proven otherwise, and that's a very important thing to note. Any kind of deformity of the pelvis would, of course, be a solid indicator, but what's more common than that is a rotational lower extremity deformity. So a lot of times people will come in, they'll have an open book pelvis, for example, and the legs will just be opened out, they'll be frogged open. You'll look at that and be like, that looks really kind of funky. That doesn't look like someone's leg should be rotated in that direction. And the first thought usually is, oh, they must have broken femurs or something like that, but it actually often is a broken pelvis when that happens. Or, for example, a limb length discrepancy in someone with the vertical shear injury where half the pelvis is shoved upwards towards the rib cage. The legs will look like they're a different length. And in general, an unresponsive victim. So if someone's unconscious, they can't tell you what's going on, and they've had a high energy mechanism, we should probably assume they have a pelvic fracture. That's a good thing to bet on, because even if you're wrong, it's better to bet wrong in the field and protect the pelvis than it is to bet wrong and they actually have one. So this is how a pelvic exam is done with respect to the pelvic ring. So there's two modes. There's the compression and there's the distraction. So for compression, we have the hands on the outside of the greater trochanters of the femur and the outer part of the pelvis, and then kind of pushing inward to see if the pelvis moves inward. For distraction, the thumbs there are right within that recess medial to the anterior superior iliac spines, kind of right there inside of the hip pointers, and then kind of trying to basically open the pelvis up like a book. So I wanted to spend a little bit of time here. This is a great picture here, this diagram that I found online. So the pelvis thankfully, the pelvis is a symmetric structure, at least it should be in most people, right? And so we have the benefit of being able to compare one side to the other when we look at how things are supposed to look. And there's a few things to key in on. The first thing I'll mention in this x-ray is that the spinous processes are in the midline of the vertebral bodies. That's probably the most important thing that we need to start with, because if someone is crooked on the x-ray table or on the x-ray beam is coming through them, the pelvis is going to look crooked too. So as long as we have a decent midline lumbar spine, anterior posterior view here, we know that when we're looking at the pelvis, it should be symmetric as well. So the things we're going to look at, we're going to look at the sacroiliac joints. We're going to look at the ring. This is the ring, right? So we're going to look and see, is it symmetric? Is there any irregularity or incongruity from side to side? We can look at the obturator foramen as well and look for the same thing. There's this thing called the Shenton's line, which you can see right here, and that just refers to the general curvature of following that curvature of the femoral neck to the obturator foramen there, and just making sure that it looks like it matches up. Looking at the iliac wings, the acetabulum, the iliac spines, all these things are really important things to look at, because fractures can occur in any of these areas. And so this is an example of, we've looked at this x-ray a couple times, but where this has been disrupted. And so the part that's obvious, right, is where the arrows are pointing, but there's some other subtle features too, and this may be hard to pick up because of the shading, but this iliac wing is externally rotated compared to this iliac wing. There's more of it. You can see more of it. It's kicked out a little bit. There's also, this is really hard to see, but the ischial spine, which is this triangular structure right here, is way more visible here than it is over here. And so in the absence of something obvious like arrows pointing at something like that, those are keys that we can look at. So moving on to our next goal of care, we want to talk about controlling hemorrhage. So any significant pelvic trauma will result in at least some internal bleeding. Right? And the problem is that an unstable open book pelvic ring injury in particular allows for so much more volume of blood to accumulate. So this is a horrible looking x-ray, right? This is a life-threatening injury that this patient has sustained. And so we're looking at this and we say, okay, yeah, the pelvis is opened up in the front, but you see the pelvis is actually opened up in the back as well. There's been a lot of tension that's occurred there. And so this venous plexus that we looked at earlier has just had this happen to it, right? So there's been this huge tension for it that's come across, and it's basically started to rip these vessels wide open. And the same thing can happen to the arteries, right? But the veins have the weaker walls. The veins are much more sensitive to this type of thing. And the pelvis can hold over 4 liters of blood in it, and that's even without it opening up. So you can imagine if we have a pelvis that's opened up, a patient can get their entire circulating blood volume dumped into the pelvis without too much time going by. So one of the initial goals for hemorrhage control in a pelvic ring injury is to normalize the pelvic volume, close that space down, and then perform vascular intervention if needed. So we want to turn something like this into something like this. And that's going to make it a lot better for this patient to survive and have a much better chance at that happening. So in order to accomplish that, we have these, our friends, the pelvic binders, right? Many of us have probably seen these things before, and we're going to talk a bit about kind of how these things work and why they're important. So for a pelvic binder, right, the goal of a binder is to decrease the pelvic volume and normalize it, right? And I'm going to hammer this point home like maybe 50 times over the next 5 minutes. The application should be centered over the greater trochanters of the femur, right? So even though it's called a pelvic binder, it's actually functioning by driving the heads of the femurs inward and using that to cause the pelvic volume to close down. I know this is not a pelvic binder that we would put on a patient in the ER, but I have this slide up here to show how it's not supposed to look, but how it often does when it's applied. So we can see that the belly button's totally invisible here. The greater trochanters are down here, right, the widest part of the hips, and this thing is centered kind of more over the iliac wings, right? So this is not how this is supposed to look. We want this to be moved downward and kind of more over the greater trochanters. And so we should be able to see the umbilicus, right? If we can't see the belly button when a binder is on, it means it's been placed too high. So this is an x-ray. We can see our little circles for the T-pod here, and we can see the bottom of the circles are kind of like right around here, right? So this binder is centered directly over the iliac wings, and we ideally want that center to be down here. It's not that it doesn't help, because it can help. The problem is that in a lot of people, they may actually have some cracks going through the iliac wing as well, and it's not a very reliable place to put the binder. You really want to try to be lower. And it's important, because putting the binder on correctly can truly save somebody's life. So, steps to applying the binder. We're going to want to expose the patient. That's pretty typical. We're going to be doing that anyway in the trauma bay. We don't want to be putting the binder on over a bunch of clothes. Slide the binder under the hips while avoiding rolling the patient. So log rolling the patient with an unstable pelvis can cause a lot of sloshing around, and it can disrupt a lot of clot in the pelvis. And so we want to try to find a way to get that binder underneath them, underneath the butt area, without having to roll them around. We want to ensure the center of the binder is centered at the greater trochanters of the femurs. And then internally rotating the lower extremities can be a really helpful thing. So as I mentioned, a lot of these patients are gonna look like their legs are rotated out. And in surgery, anyone who's kind of seen me position a patient for surgery, this kind of thing, I take the legs and I rotate them inward, and I duct tape the feet together, and I hold them inward like this before I prep and drape them for surgery, because just doing that alone usually gets you halfway there at least. And so rotating those legs inward will help drive the pelvis together. And then once you've done that, you can cinch down the binder. And don't be shy, because it's very difficult to hurt a patient by cinching down a binder. And it only usually is helpful to them by tightening it. So this is a video, and we'll see if we can get this to play, that I will kind of narrate. And this just kind of shows the application steps, and it's a kind of a useful thing to see kind of how to do this. So, we have a patient, right? They're going to be down to skin level, right? We're not necessarily totally naked, but we want to get the bulky clothing off. And then we're going to slide the binder underneath those hollows in the knee. You can also go behind the lumbar spine potentially if there's access there. And then we're avoiding log rolling here. Again, this is a really great picture of where those greater trochanters are. Kind of go to that widest part of the hips, right? And then we're gonna aim for that area. Move on here. So kind of lift the butt a little bit up, right? Not log rolling, but just kind of vertically lifting them up in the air. And then we get the binder going across. And again, we're over the trochanters here, and then cinching it down. This is a really powerful thing, right? As long as the femurs aren't broken, and even if they are, it doesn't matter, you can still do it. But if they, assuming that there's some integrity there, the femoral heads are incredibly good at pushing the pelvis inward. So that's how that looks there. So what if there's no binder? And I've done this myself on a handful of occasions. So you don't need a binder. If you don't have a binder, you can use a sheet. The one thing I want to highlight, in case anyone ever does end up doing this, is that this is really important. There's no knot in the sheet. These are clamps. And so what I think is the intuitive thing that people think is they're going to take a sheet, wrap it around the pelvis, kind of pull it really tight, then tie it like a bow, right? That makes a lot of sense. It made sense to me when I was first starting out in orthopedics, and then I was told not to do that. So it doesn't work very well, because you lose a lot of that tension on the sheet when you're trying to tie a knot in it. And so what works best is kind of a three-person job. You can imagine having the sheet wrapped around, one going this way, one end going this way, and people kind of just pulling really hard. It's kind of a three-person job. One person pulling this way, one person pulling this way, and then a third person comes in with clamps, just clamps down the sheet ends to each other. That's how you're going to actually keep the tension on the sheet correctly. And I've actually done surgery through a sheet. Sometimes I've had pelvic ring injuries that are so unstable that I take off a sheet or a binder and the pelvis goes into a different zip code. You can put a sheet on there and just dump betadine all over it and cut holes in the sheet and use that to put screws and plates through. So it's a really useful tool, especially if the binder is not gonna work for whatever reason, or if there's not one available. So moving on to endovascular intervention, right? This is our secondary measure after the binder's on. So angioembolization, right, is going to interventional radiology and using catheter-based intervention to stop bleeding. And this is a really safe and effective method to control arterial bleeding, right, from arteries. The problem, of course, is that, as we talked about, the venous system is often in play and usually the much bigger culprit when it comes to bleeding inside the pelvis. So the veins aren't really able to be readily targeted by this method. But for the arteries, it's a great method. The complications are relatively low, and when they do occur, they're certainly preferable to ongoing hemorrhage and death. So we're going to think about sending someone to IR to get embolization done if there's a contrast blush seen on CT. These arrows are kind of pointing to small areas of blush. In addition to the presence of blush, there are some risk factors that are associated with benefiting from embolization. These include large hematomas, an elderly patient who has a higher energy mechanism, and of course a widely displaced pelvic ring injury is going to be at higher risk of needing embolization versus one that hasn't gone out of place very far. So let's talk about REBOA. This is a little bit different, right? So REBOA, REBOA is an acronym. It stands for Resuscitative Endovascular Balloon Occlusion of the Aorta. So this is what this thing looks like. This is the kind of thing you don't want to have to utilize very often, but when you want to use it, it's really good to know what it is. So this catheter gets fed up into the artery, into the femoral arteries, and snaked up into the aorta. And it basically functions as the same thing as if you crack somebody's chest and cross-clamp the aorta. It basically totally blocks the aortic blood flow. And there's different zones to the aorta. There's zone 1, which is everything from the kind of the takeoffs of the subclavians from the descending aortic arch down to kind of the mesenteric zone. There's zone 2, which is where the mesenteric arteries are and the renal arteries, and then zone 3 is below that. And so this balloon can be placed and can be inflated in different areas depending on what's needed. And so, generally speaking, these are the indications for REBOA, and these are actually quotes from our pelvic fracture protocol that we have here at BCH. So if someone has a pelvic fracture, they have a binder on, they're being resuscitated, and they're still crumping, they're still doing very poorly because of ongoing hemorrhage, we can consider putting the REBOA in zone 3, which is basically below the abdominal stuff takes off, but above where the vessels go into the pelvis. And so this basically cuts off all blood flow to the pelvis and the lower extremities when the REBOA is put up there. Of course, it's going to be a temporary thing. And then a zone 1, which would be higher up, would be in the setting of massive intra-abdominal hemorrhage in association with a pelvic fracture. That's going to be where there's a lot of bleeding into the abdominal area, and we need to stop the bleeding to the area. And generally speaking, if someone has a REBOA put up, their next stop is the operating room, because this is meant to be a temporary thing. Obviously, this cannot stay up for any significant length of time because there's going to be pretty significant problems to the lower half of the body if there's no blood going to it. And so the OR is the next stop for these people. All right, so we've controlled hemorrhage, and now moving on to resuscitation. And usually this is an ongoing thing that's happening at the same time that hemorrhage control is occurring. We're all kind of familiar with the idea of resuscitation, right? We're giving fluids, we're giving blood products. And so for fluids, we're talking about crystalloid infusion. Dr. Sovendal at this conference last year gave a really great talk that talked a bit about permissive hypotension, right? About allowing these people, as long as they're safe enough to tolerate it, having their systolic blood pressure be a little bit low. And that's allowed as long as this patient is awake, they're able to converse with us, they're making adequate urine, they're not showing any signs of any end organ hypoperfusion, right? Because if we're diluting these patients' blood volumes with crystalloid, all we're doing is giving them lower and lower and lower blood counts, right? We're just making them watered down, and that's not necessarily a good thing at all. The contraindications to this permissive hypotension approach, though, are basically a central nervous system insult. So we have a brain injury or a spinal cord injury. And then, of course, is blood product replacement, which is going to form a very important mainstay of resuscitation for a patient that's having a lot of internal hemorrhage, right? And that's certainly what pelvic renal injury is going to have. So we're going to utilize our massive transfusion protocol. We're going to give blood products in a 1-to-1-to-1 ratio for the platelets, the FFP, and the packed red blood cells. So in terms of stabilizing other injuries, pretty straightforward, right? Once we get through our life-threatening needs, we're going to look at everything else. It's pretty common for someone with a pelvic ring injury to have other injuries, including orthopedic injuries, right? We're going to splint, we're going to brace things. People are maybe going to get chest tubes placed for chest trauma, and other things like that. But usually the pelvis, if there's a big unstable pelvic fracture, usually the focus first needs to be on getting that situation figured out, and then everything else will happen as well. Admitting the patient to the hospital generally occurs once we have our initial efforts completed. And in terms of criteria for ICU admission, anybody with that's unstable hemodynamically, obviously that makes sense, and they may have other metabolic problems going on a laboratory basis. Anyone who's gone to IR or gone to the OR for hemorrhage control really needs to be in an ICU bed, because that intervention may have been successful, but then things may change. Any kind of vascular compromise to the extremities would, of course, qualify here. And then really anybody, even if they're clinically stable, if they have an unstable pelvic fracture that requires a binder or something along those lines, they really should be in the ICU, because I have personally seen people look good for a couple hours with a pelvic injury, and then suddenly they start to go bad fast. So close monitoring is very important. So, and after all this, then we think about definitive management, right? So, and this is what I do. So, this is a patient who came into our ER a little bit over a year ago, actually. This is his injury, AP pelvis, and this is a, I think this X-ray really kind of belies just how severe this was. I'm not sure exactly. Maybe this is just a good moment for the X-ray to be taken. But when I took the binder off this patient in the OR, his pelvis probably opened up 5 times wider than it looks like right now. And unfortunately, the X-ray tech deleted the C-arm image that I saved, so I can't put it up there. But so this is an open book pelvic injury, and there's widening of the symphysis pubis. Here we can really see what I talked about with that ischial spine before. Right here, this kind of pointed part of the bone is way more visible here than it is over here. And we can see that the iliac wing is way more kind of in profile. It's wider out than this one is. And so we know that the right side of the pelvis is opening up. It's externally rotating. There's some irregularity of the sacroiliac joint over here. There's a shadow running through the sacrum. So it's hard to see like what's going on with the sacrum here, right? And this is really typical for an AP pelvis. Maybe there's something going on there. We can assume, right, because we know the pelvis always breaks in 2 places, that if there's an injury in the front, there's got to be an injury in the back somewhere. And so we know that something's not quite right. So we look at this 3D rendering of this patient's CT scan, and we can see this is actually a really complicated sacrum injury. It's a really rare pattern. It's an L shape, so it kind of cuts down like this and then heads horizontally across like that. And then this was taken with the binder on, so we can see that that's almost, you can call it almost overcompressed, right? Because normally the pelvis wouldn't be totally closed down like that, but that's fine. That's great for this patient, right? This is a life-saving thing that he has on here with this binder. And so when we're talking about restoring the pelvic ring, the general goals, surgically speaking, are, well, we have a break in 2 places. It's usually nice to put instrumentation in 2 places too, right? And so we want to take care of the front and the back. And so that's what happened to this guy. This was an X-ray that was taken about a month after surgery, actually. So he ends up with a few plates and a whole bunch of screws holding everything together. And at least for this patient, I have the benefit of long-term follow-up on him. I just recently saw him for his 1-year follow-up. He actually has no pain in his pelvis and walks around without any crutches, cane, or a limp or anything like that. Actually, one of his biggest issues came about more from the injuries higher up in his chest and abdominal area that continue to give him problems. But pelvic-wise, he's actually doing rather well. So thanks a lot for your attention. Appreciate your time, and I'm happy to answer any questions.
Can you repeat questions into your microphone so they can get it remotely when folks ask you questions?
Sounds great. Yeah, go ahead.
When you put a binder on to help control injuries, etc., how does that help control bleeding?
Yeah, that's a great question. So the question was, how does the binder itself help control bleeding? And so, yeah, venous in particular, right? So there's 2 main mechanisms for it. The first is kind of closing down that pelvic volume, which means there's less blood that can get into the pelvis, right? So that's helpful right there, just because there's going to be an outflow restriction to the internal hemorrhage. But what it actually does is it's kind of like a splint for the pelvis, so it stabilizes clot. And I didn't really talk a lot about that, but it's a very good point. there's a mantra in orthopedic pelvic trauma, which is the first clot is the best clot, okay? And so we don't want to have a binder coming off and on, because every time that happens, the internal clot is being disrupted and the bleeding starts again. But when we stabilize it and hold it together, the bleeding in the pelvis will clot off, and that will actually help stem the flow of the bleeding that's ongoing in the area. So those are the two ways that the binder helps. Yeah.
Does the top of the binder sit at the greater trochanter, or do you center it over the greater trochanter?
Yeah, so the question is about where the center of the binder, the top of the binder, where it sits. It really depends on how wide your binder is, but the center of the binder should be over the greater trochanters, right? That way you can even have like a narrow little seatbelt one like it was in that video, or you can have a nice big T-pod one. But in general, you want it to be centered over the trochanters. And that's important because you can actually, especially with these big T-pod ones, they're kind of a lot, higher, wider, whatever you want to think about it, than they need to be, truthfully, because you can do it with a seatbelt type of thing or a sheet. But what you can do is if someone needs to go to IR with one of those T-pods on, you got this whole area, you can cut the inferior part of the binder away, and you're still fine. They can get access that way. Someone can go to the OR and have an abdominal or thoracic procedure done, and that binder can actually stay on if it needs to. You can just maybe trim the upper part of it down. It kind of just depends on what the needs of the patient are. But by centering over the trochanters, you're not only mechanically optimizing the function of the binder, you're also making it easier to take care of everything else wrong with the patient. Yeah. Yeah, good question. I wondered if that might come up. There's a facility in Denver Health that became kind of the international leaders in advocating for pelvic packing, pre-peritoneal packing at one point. They don't do it as much anymore. So it's a really useful adjunct if someone cannot have bleeding controlled any other way. I think that in general now, when you look at trauma centers around the country and mostly around the world, we're biasing way more towards closed means or percutaneous means of bleeding control versus the packing. But if someone has a Reboa placed and then they're going to the OR, they're probably going to have packing placed, maybe in their abdomen in addition to the pelvic area as well. And it can be a useful adjunct. The primary problem that we're seeing is there's a significantly higher risk of infection when people get fixed surgically if they've had a bunch of sponges sitting inside their pelvis for a while. And so unless it's really necessary, generally speaking, most places are not rushing to do that. Yeah, right there.
Concerns about placement of Foley catheter.
Yeah, that's a great question. And actually our protocol kind of touches on that a little bit. The question was about placement of a Foley catheter in someone with pelvic trauma. So someone can have a torn urethra, right, or something like that. That's absolutely the case. And so generally speaking, we're going to try to put a Foley in these people, and if it passes easily and you get urine back, well then I think we know we're in good shape. If you can't pass a Foley, then the right move is to not keep on trying to shove it into somewhere you don't even know where it's going, right? So you can get a retrograde urethrogram, and that can be done under X-ray. And I wouldn't be the one personally who would do that, so I guess I don't have all the details on exactly how it works. But that would be the test to do, is to get a retrograde urethrogram, or just look at the CAT scan, figure out a way to kind of figure this out, and then know if there's a problem. And so generally speaking, if someone has a problem like that where a catheter can't be placed, a suprapubic catheter will need to be placed, surgically.
But that would all be done.
Say that again. I'm sorry.
That would all be done.
Yeah, that wouldn't be. That would come later. But yeah, it's an important thing to be aware of, because you don't want to put the catheter in and then it ends up running up to the diaphragm because you've shoved it in so far and it's not going to the bladder. Yeah, please.
About compressing with fractures, and this showed a picture of so much vasculature of parts. Not a concern. Better for the patient to just go ahead and close that space and be concerned about something like if you have a femur fracture, you're worried about pulling apart rather than.
Sure. Yeah, and that's a great question, and that's come up before. I think it's a really common concern, right, is that, well, we don't know what's going on. what if we make something worse? And so the question was about, is there a concern about maybe hurting things? You put a binder on, is there a concern we have to think about these other things? And the reality is that when you look at the data on this, or even people's clinical experience, it is very, very difficult to make something worse by putting on a binder, at least if you put it on correctly. If you displace a femur fracture more, oh well. It'll probably be a bit more painful for the patient, but they're not going to die from that, right? Whereas they will die from an open book pelvis that's not closed down, right? Even a lateral compression pelvic injury where legitimately, but the binder will actually displace the fracture worse. It will actually shove the pelvis inward where it's not supposed to be. That's also been shown to actually be pretty safe. I mean, we don't necessarily leave the binder on forever like that, but you're not going to really be realistically at risk of causing a major damage to anything on the inside by putting on a binder. So generally speaking, what I always advocate for is it's far better to put, in almost all cases, it's far better to put one on, not knowing exactly whether or not you need it, than to not put it on and have the patient die. Yeah.
If, most agencies have pelvic bindings, but some don't. You're talking about sheets. If you take a sheet and you cut, like, instead of having 2 pieces to tie, you cut them and you have 4 and you tie them diagonally. Do you have any familiarity with that?
It probably wouldn't work very well, I would think. So the pelvis it's like a ring, right? It's like a big donut, and you want to have that big circumferential hug. You know, the question was about whether or not you can use a kind of a combination of sheets as opposed to just one sheet or something like that. So you really want to have that circle, that ring, right, that kind of rings around the pelvis. And so that's why it's so helpful. And actually, it's a good point. You know, binders and or sheets are actually way more effective at closing down pelvic volume than an X-fix is in a lot of cases, because an X-fix only controls the front half of the pelvis, whereas the sheet wraps circumferentially around it and closes the back as well.
Dr. Gross, will you talk just a little bit about when we put on pelvic binders, maybe we leave them on for a little while, and the risk-benefit of using a pelvic binder for 24 to 48 hours?
Sure, yeah, absolutely. And it's a great question, and it comes up because with anything on the body, you know, we think about, are we going to cause pressure sores or anything along those lines? And that's an important consideration. Basically, the pelvic binder can be thought of as a splint. And if someone has a dislocated ankle and we put a splint on their ankle, we don't take the splint off every day to check to make sure the skin's okay. We usually just kind of leave it on. Now, the pelvic binder has a lot more force on it, and it can, if it's left on for an extended period of time, it can cause skin issues. Typically nothing that's full thickness or anything overly dangerous. Generally speaking, when the binder goes on, we start to think about a plan to get the patient into the operating room to get things fixed. But sometimes there may be situations, either logistically or medically, clinically, where the patient can't go to surgery, you know, within 24 hours. And leaving that binder on is the right thing to do. We don't just want to ignore it, right? And kind of what I was taught by my mentors is you manage it like you manage anything else. You kind of check the margins of it. You know, there can be nursing skin checks periodically and check on that stuff. And of course, we want to make plans to get the binder off, but it would be potentially very dangerous to take the binder off before there's something else ready to go. So in other words, usually the binder, when it comes off, is when we're in the operating room, and then we have something else ready to go. Because like that case that I showed, his pelvis was all closed down. I took off his binder, and I was just curious, like, how unstable was it really? Because again, we had only had that initial AP pelvis X-ray to show me, and it was horrifying how much it opened up. And so, like, yeah, it can be a very dangerous thing to take it off too soon.
Can you still turn patients when they have a binder?
Yeah, the question is about turning the patient, and actually that actually makes it a lot safer to turn them, because, and you kind of need to, I mean, to take care of a patient and kind of check their skin or do, you know, kind of hygiene for the patient's backside. You know, when that binder is on, it's really helping to splint everything really, really well, and so they can be rolled. I mean, again, you don't want to necessarily do it rapidly over and over again, but yeah, it's very, very, by comparison, much safer to roll a patient once the binder's in place. Yes. Yeah.
For your patients that you've decided they're not going to require surgical intervention, but are on the floor, and they have a lot of pain when they move, do you ever recommend a binder, like a downward binder, but lower?
The question was, would I recommend some kind of binder situation for someone who's non-surgical, but still having pain when walking? I don't know that a binder would necessarily be helpful. I suppose that some kind of support, maybe for coughing, maybe that would be helpful. But typically, if someone has a stable pelvis, it means that it's truly stable, where it's not really experiencing any kind of major displacement. And in particular, if someone's pelvis is having any element of opening up while they're moving, they need to be fixed. So mechanically speaking, I guess I'm not even aware that anyone's ever really tried to throw some kind of binder construct on someone who's non-surgical and just kind of have it lightly there for support. It might be useful, but I probably doing the whole, go over the trocaners and yank on it and really tighten it down. I mean, that's not like the idea of someone's good time, like as a patient. Like they're not going to feel like really great with this tourniquet around their hips. But I suppose that it wouldn't really hurt, right? If someone has a stable pelvis and they want to have some additional support there, and they get some other kind of brace construct on there, it'll be fine. It'll be safe to do for sure. Yeah.
Okay, thanks,
Cool.
Dr. Gross.
Thanks, everyone.
Okay, thanks for coming back. Next up, we have Dr. Shapiro, who is a cardiologist and an interventional cardiologist. You may be wondering, what is a cardiologist and interventional cardiologist doing at a trauma symposium? If you ask Dr. Gross, he is in charge of the ANSEF pump. But also, like Dr. Vissers mentioned today, our patients, it's really about the whole patient and total body. And patients, trauma patients come in with hearts, and sometimes they need Dr. Shapiro. So let me tell you a little bit about Dr. Shapiro. He is practicing at Boulder Community Health at the Foothills Hospital, as well as in Erie and in Longmont. He's board certified in cardiovascular disease and interventional cardiology. After medical school, he attended the Medical University of South Carolina and then completed his residency at University of Virginia. He did his fellowship and interventional fellowship at Washington University in St. Louis. I Google stalked you also last night, and he does like fly fishing. Perfect. Welcome, Dr. Shapiro, please.
Excellent. All right, thank you. It's really a pleasure to be here today speaking with you, and hopefully I can bring some interesting cardiology perspective to trauma. So just to start with, I wanted to think about the idea of whether cardiac pathology is a chicken or an egg. And so I want to go over this just a little bit. And the debate, I think, is still ongoing despite the cartoon. Let's see if I can get this to play. So this is Hank Gathers, and this is a classic video that where really we changed the idea of syncope in sports. But the issue is that cardiac syncope, which is a profound loss of consciousness, can be the cause of trauma in some patients. So I think when we're first evaluating patients, obviously, you have all your trauma algorithms, but one of the things as a cardiologist we want to think about is whether the root cause was something specifically cardiac, because that could be life-threatening for the patient as we're resuscitating the patient, or during their hospital course, or in their future life. So the things that we really consider are things like the ventricular dysrhythmia, so ventricular tachycardia, so a more organized, fast heart rhythm from the ventricle, as demonstrated in the top ECG, ventricular fibrillation, which is a disorganized heart rhythm from the bottom chambers of the heart. And so those can be not infrequent causes of cardiac syncope. Obviously, there are other non-cardiac reasons for syncope, so we have to kind of discriminate that. Some potential risk factors, so if we know about specific patients, if they have cardiomyopathy, so the video I showed you just before, Hank Gathers had hypertrophic cardiomyopathy, which was a known diagnosis. He was being treated maybe he wasn't taking his medications as prescribed, and then had that profound syncope on national TV. Other cardiomyopathies, both non-ischemic, dilated cardiomyopathy. So patients with heart failure are definitely at an increased risk of both ventricular arrhythmias or just syncope related to heart failure. In younger patients, the inherited arrhythmia syndrome, so things like Brugada or long QT syndrome, and then also patients who are having a heart attack would be at potential risk for cardiac syncope. So clearly something to consider if a patient has a sudden unexplained loss of consciousness as a potential cause for the trauma, if we're able to figure that out by people who saw the actual event, that may be something to consider and try to do some further diagnostic testing, for the long-term safety of the patient. Let's see. So to talk specifically about acute myocardial infarction, sometimes it's not as easy as the snake to tell. So I wanted to present a case. So very clearly, when we talk about acute myocardial infarction, obviously there's a spectrum of disease, but sometimes we see more profound ST elevation myocardial infarction. We want to diagnose that as early as possible because our treatment is generally rapid revascularization through the cardiac catheterization lab if it's safe. And so this patient presented not with trauma, but with chest pain. But I wanted to just give you kind of an idea of what we do in the interventional lab. So when we took pictures of the right coronary artery, we see that this should come around and look like a C in this picture. And we see this area of staining in the mid portion of the right coronary artery, and there's no more flow. So this is, a cholesterol plaque that has ruptured open and formed blood clot there, and then this patient is having the large inferior myocardial infarction that we saw based on the ECG. So what we do in the interventional lab is that we put a wire across the blockage, and then we balloon open the area. So we see that cholesterol deposit in the mid portion where there was previously no flow, and we see there's a little bit of thrombus still in there. And then we implant a stent. So a stent is a wire mesh device mounted on a balloon. And on the left, the stent is mounted on the balloon. Then we inflate the balloon. The stent gets crushed into the wall, and then crushes the residual clot as well as cholesterol into the wall to stabilize the plaque. And so here's our final results. And now we see we have a huge vessel that's widely paid. And there's some distal disease, but that's a small vessel. So the importance is that, if we were to leave that closed, then that large territory of the myocardium would not be having good blood flow. And so the patient could have significant residual disease, could have heart failure because of that, could also be at risk for heart rhythm issues. And so specifically with regards to trauma, what I wanted to talk to you about was the rates of bleeding as well as thrombosis. So procedurally for those procedures, we generally use anticoagulation to reasonably high levels with heparin or bivalirudin. Sometimes we use 2B3As, which are IV antiplatelet medications. And so all of these medications significantly increase risk of bleeding. And then when we place stents, we use dual antiplatelet therapy as standard of care to prevent blood clots from forming in a new stent. And so aspirin in combination with one of the other medications such as clopidogrel, prasugrel, or ticagrelor. So the issue specifically is that, obviously if patients have had significant trauma and then we're giving them lots of medications which increase the risk of bleeding, then, if there's a nidus for bleeding because of the trauma, then they can have, life-threatening bleeding as a result of our procedures. And also patients who are on our medication, so aspirin and clopidogrel, and then have trauma, they would have higher rates of bleeding as well. So we want to keep a close eye out for that. But the challenge is this balance because, if we were to leave these patients alone and they continued to infarct, they could have lifelong detriment to their cardiac function. So just key points from kind of the idea of cardiac disease as a cause of trauma. I'd like people to think, consider whether there may have been a cardiac condition as the reason for unexplained trauma. And then as the patient progresses through the healthcare system, monitor for decompensation suggestive of acute cardiac pathology and decompensation. But I think a key point, obviously, is that we should assume hemorrhagic shock in our shock trauma patients with hypotension, and then keep the cardiac reasons on the back burner if they're not responding to treatment for hemorrhagic shock. So moving on with regards to cardiac injury due to trauma. So obviously, depending on where someone is traumatically injured, there can be acute cardiac or vascular injury. This can vary from benign findings on ECG or on blood testing to acutely life-threatening. And some injuries may be obvious. So if someone comes with a knife wound to the chest wall in the area where the heart is, obviously that might suggest that there is a penetrating trauma to the heart. But with specifically with blunt trauma, things may be more difficult to diagnose. So I think this is, it might project okay. So this is a nice table kind of highlighting some of the conditions that blunt cardiac injury can encompass. So, with rapid deceleration injuries, cardiac contusion, so bruising of the heart muscle, is a not uncommon finding. There can be acute valvular injuries. So we'll go through all of these in more detail in a minute. Coronary artery dissection, so tearing of the heart artery, aortic dissection, tearing of the major blood vessel, rupture of the walls or the septum of the heart, blood into the pericardial space or hemopericardium, and then also pericardial rupture. And then finally, arrhythmias, which again vary in severity between the more severe ones like ventricular tachycardia, ventricular fibrillation, to benign findings like PVCs. So I'm sure this video is a little bit more contemporary, so I'm sure people recognize this more recent syncope. So just kind of focusing on the idea that this was caused by the trauma as opposed to causing the trauma. So commotio cordis is a condition where the heart is struck at a specific vulnerable part in the heart cycle. So effectively, this is like an R on T phenomenon, but being caused by trauma as opposed to a PVC. So most commonly, this occurs in pediatric patients because their chest wall is thinner, and generally speaking, it's a hard, small circular object like a baseball, hockey puck that hits the heart at a specific time, and then they go into ventricular fibrillation as a result. So just kind of most of the things that I've already commented on. The other key points, though, that some patients can have this with impact into the steering wheel, especially if they're unrestrained, although airbags may help lessen the likelihood of this. And then in people who are wearing body armor or Kevlar, gunshot wounds to Kevlar vest could cause this as well, or people who have been shot by less lethal crowd control measures. And the key thing is identifying this immediately with an ECG and then defibrillating patients. So, we see in pediatric sports that having AEDs in schools, even for young kids, because that really is a life-saving measure and can save patients from any further detriment in their life. More frequently, we talk about blunt cardiac injury related to motor vehicle collisions, as motor vehicle collisions are obviously very common in the U.S., and so that would be kind of the most common cause of this type of injury. Less common, but in Boulder, we have people falling off of mountains, and crush injuries can be a cause. The specific mechanism is a rapid deceleration or a direct blow to the precordium. If we think about the thorax, there can be compression of the heart between the sternum and the spine, and that can cause injury. We can have shearing injuries and also blast injuries depending on the mechanism of specific trauma. We'll talk a little bit about the anatomy, but the right heart is injured most frequently because of its position anteriorly. High pressure injuries to the ventricles are most common on autopsy studies. The issue there is that most of these large ventricular injuries just don't survive to the ER to have definitive care. But atrial injuries can occur. And we'll talk more about valvular tear, rupture, as well as septal tear, and then the coronary artery abnormalities. So one algorithm to kind of think about in trauma patients who are at high risk for cardiac injury, if the patient is unstable, then we proceed just down the road of resuscitation and surgery. And so, the trauma surgeons in the room are the experts at this. But if they're more stable, then I think a reasonable pathway is to consider further imaging. So if there's evidence of penetrating injury, then proceeding with a fast scan, looking for pericardial fluid. And if there is, then proceeding with surgery. If there's not, considering proceeding with a CT scan. And then we get down the blunt cardiac injury CT scan pathway, where if we see cardiac injury, if the diagnosis is confident based on our radiologists and the CT scan, then we proceed directly to treating the specific cardiac injury. If it's equivocal, then considering proceeding with emergent echocardiogram for further information. And then if there's no evidence of cardiac injury on the CT scan, if there's a low suspicion, then we're done with the algorithm. And if there's a very high suspicion based on clinical characteristics, then proceeding with an echocardiogram. I put this in here. This is going to be hard to read, but there is a American Association for basically the Trauma Surgery Society does have an injury scale that can be used by emergency room physicians and trauma surgeons, ranging from grade 1 to grade 5 and going up in severity. I just kind of bring that out so that we can think about the idea of kind of grading the severity of our patients with regards to cardiac injury. I think a key thing with regards to trauma is understanding the relationships of the structures in the chest and mediastinum. Obviously, for penetrating trauma, if we're within 1/3 of the right side of the sternum and 2/3 of the left side of the sternum, we could be at risk for direct heart injury. But we have multiple other structures, vascular structures, including the major arteries and veins, and then obviously the lungs and other structures of the chest. So I think it's key to kind of think about that when we're looking at the idea of especially penetrating trauma, but but also if there's evidence of blunt trauma, and specifically we see evidence that a certain part of the precordium has been injured, then we may want to consider injury to specific parts of the heart itself. So I think we're all in agreement that there's 4 chambers to the heart in most patients. So I kind of put in a little bit of anatomy, and I'm not going to go into full detail, but I think the key points to realize with regards to anatomy, the top frame is kind of looking more anteriorly. So we see the right-sided structures more anteriorly. So the right atrium and the right ventricle, and then the pulmonic valve there. And then as we look at the bottom frame, then we see, we still see some portion of the right ventricle more posteriorly, but then the left ventricle is again more posteriorly, as well as the aorta. And the importance here is that kind of the frequency of traumatic injury increases as things are more anteriorly, because of just the sternum and the rib cage is thinner than posteriorly. And so as we're kind of looking at specific cardiac trauma, we should consider the anatomy specifically. So myocardial rupture is a life-threatening event. So most patients with uncontained rupture don't survive to the emergency room. If it's a smaller rupture and they make it to the emergency room in time for axial imaging, we can see hemopericardium on the CT scan. We may be able to see actual loss of continuity of the heart muscle, such that we see the portion of heart muscle which has ruptured. The other issue is that some patients can develop necrosis of the myocardium from trauma. And so if a patient, into their hospital stay acutely decompensates, one thing to consider would be that we could have delayed rupture. And that's kind of similar to what we see historically when we had myocardial infarctions that were treated conservatively, as opposed to with early revascularization, where heart muscle over time becomes weakened, and then because of the pressure of the chambers, especially the ventricle, can rupture because of that. Generally speaking, atrial rupture, because the atria are generally more compliant, is only about 10% of all ruptures. And all of these may present with tamponade, so we'll talk a little bit about tamponade here. So the heart obviously sits in the pericardium, and normally it requires some amount of fluid to allow the heart to easily move within that sac. The issue is that the sac is a contained space, and fluid is incompressible. So when fluid rapidly accumulates into the pericardial space, then the only thing that can give is the heart. And so what happens is that the increased pressure in the pericardial space then compresses the heart. So on physical exam, the things to look out for are things like muffled heart sounds with significant hypotension and significant distended jugular veins. Patients may be very short of breath. They may feel better sitting upright. And so specifically what we look for on echocardiogram in this representative picture is the idea that the right-sided chambers, the right ventricle and the right atrium, are being significantly compressed. If we were to leave this alone, then the patient would be unlikely to survive. So rapidly removing that fluid, either in a surgical manner in the ER or in the OR, or from a less invasive approach, placing a pericardial drain, is key in helping save these patients with acute tamponade. Moving on a little bit to septal and valvular injury. Fortunately, the septum is between the chambers in the heart, so injury to this is rare. In literature, we do see reports of acute septal injury, and so we can see that clearly on echocardiogram, where we see profound color flow between the ventricles in the middle diagram here, and we see a discontinuity in the septum on the leftmost picture. And then there's a CT scan which correlates with these findings in this patient. And then here specifically is the surgical picture of this injury that was repaired. These can be insignificant, a small little tear that doesn't make any clinical difference to the patient, but frank rupture can be life-threatening for patients. They can occur in isolation or also with valvular injury. And I think the key thing to look for in these types of injuries is signs of acute heart failure. So acute hypoxemia, acute shortness of breath, orthopnea, P&D, swelling in the legs. These types of findings may suggest that looking at an echocardiogram, or I should say also a new murmur, especially a murmur throughout the cardiac cycle, would be suggestive of a septal injury. And finding this early and then talking to surgeons to fix it. Depending on the tear, sometimes these can be fixed percutaneously if it's deemed that the patient would not survive surgical repair. So we do have septal occluders that can be placed in the cath lab as well. So that would be an option for some patients. And so specifically about the signs and symptoms of acute heart failure. So low blood pressure, cold, clammy skin, shortness of breath, orthopnea, meaning that the patient feels much worse when they lay flat and better when they're sitting up, low oxygen saturations, crackles on exam, and then elevation of the jugular veins. And specifically, we're talking about left-sided heart failure here. Again, valvular injury is not a common traumatic injury to the heart, and specifically isolated valve injury is rare. Most commonly, this is the aortic valve, and then followed by the mitral and then tricuspid valve. They can be a tear of the leaflet, partial or full thickness tear of the papillary muscle, which helps keep the mitral and tricuspid leaflets from flailing back into the atria. And so it depends on which side or which valve specifically is injured as to what signs or symptoms we should watch out for. But so if it's a left-sided valve, we would worry about left-sided heart failure symptoms. If it's a right-sided valve, more right-sided symptoms. But the things that we may see as signs, specifically with aortic valve pathology, is a very wide pulse pressure. So, if the systolic blood pressure is 150 and the diastolic is 30, we need to think about whether there may be some valvular insufficiency at the aortic position. So, again, not to teach everyone reviewing echocardiograms, but we see profound turbulence in the aortic position, which is all this yellow to orange color in this aortic valve, which has been ruptured acutely in a traumatic patient. And so these, again, the heart does not tolerate acute aortic regurgitation well. It does very well with chronic aortic regurgitation, and it takes a long time for people to require repair. But if these types of things occur acutely, people decompensate very quickly, and if we can't fix that urgently or emergently, then patients are unlikely to survive for very long. And I want to show a case that we saw recently here. So this patient is one of our patients locally who was in a motor vehicle collision and was treated at another hospital. and then started having worsening of a murmur and worsening symptoms. And so what we see kind of flapping is a portion of the subchordal structure of the mitral valve. So on the right side, you see that structure that's flapping into the atria. The atria is the top part of this picture. The left ventricle is the bottom part of this picture. And we see this kind of very eccentric color flow wrapping around the left atrium. And so this, and then in 3 dimensions, kind of the bottom part, we're looking at this, the surgeon's view is kind of a fish mouth view of the mitral valve. And at the bottom part, we see that structure that's discontinuous, kind of flapping up into the atrium. So this, classically, this looks like bad mitral valve prolapse disease, but this is a more acute process that the patient developed because of a motor vehicle collision. So kind of keeping an eye out for new murmurs in patients who have had trauma can be important because they can have changes to their valves that require surgical intervention. He did end up going on to have surgical intervention and has done great with that. Finally, I just want to talk a little bit about myocardial infarction caused by trauma. So we can see specifically occlusion of vessels related to, compressing coronary arteries. So the artery could be lacerated, it could be dissected or torn, or we can have a thrombus formation in the artery itself caused by trauma. And depending on the mechanism, either taking the patient for bypass or bringing them to the heart catheterization lab like I showed earlier and trying to open it up and put a stent in may be beneficial. And then because of the anterior position of the left anterior descending artery, based on the name, you would expect that. That's going to be the most commonly injured vessel in trauma. But obviously, we want to keep an eye out for that. If patients are having symptoms, ongoing symptoms that are out of proportion to what we would expect based on the trauma, again, an ECG is an easy test to screen for these types of things, and then we can offer life-saving therapies and also reduce morbidity if we identify this early. There's this other idea of kind of cardiac contusion and cardiac dysfunction. The challenge with this in trauma is that there's really no clear definition. So, part of the issue is that if we track sensitive biomarkers like troponins in patients after traumatic injury, sometimes those are abnormal and that may or may not be clinically meaningful. If they clearly have signs of heart dysfunction, then a screening echocardiogram is important to try to make sure we're not missing some more major injury to the heart. And then there's also this idea of stress cardiomyopathy. So we see patients sometimes who present with signs and symptoms which would be suggestive of an acute heart attack. And so they can have ST elevation on their ECG. When we look at their echocardiogram, they have wall motion abnormalities, most commonly in what would appear to be an LAD territory, so in the mid to apical anterior wall, and can also wrap around the apex. And elevated troponin, they have chest pain, shortness of breath. And so, most commonly this is thought to be caused by a profound sympathetic outflow. So emotional stress, but also physical stress can be a cause of this syndrome. And some patients can be so sick that they require advanced support, even mechanical support to their heart to recover from this process. The vast majority, though, recover with full recovery of their heart function and do well. So some risk factors to think about. This is more prevalent in women versus men, postmenopausal women specifically, patients with schizophrenia, anxiety, depression, asthma, diabetes, and then substance abuse disorders. We see this more frequently. So something to consider, especially if a patient is decompensating and we don't have a clear reason, at least screening with an echocardiogram may be reasonable. and just finally, some heart rhythm abnormalities that we see in cardiac trauma. So most commonly, we see sinus tachycardia. This is the heart's response to stress, and specifically, if we're worried about things like hemorrhage causing hypovolemia, that would be a primary consideration in trauma patients. Now, that being said, if this persists for long periods of time after adequate resuscitation, or if there are other issues such as new bundle branch block or minor heart rhythm abnormalities like PVCs, we might want to be concerned that there may be blunt cardiac injury. And so at the very least, I would recommend admitting the patients for monitoring on telemetry. But few patients will require specific treatments. It's mostly just supportive care. But getting a formal ECG, considering looking at troponins just to make sure we don't see evidence of specific injury, and then an echocardiogram is a very safe test to look for major abnormalities. So in conclusion, cardiac disease can be a cause of trauma. So if we don't think about it, we may miss that. So I just kind of bring that up. It can vary. So once traumatic injury to the heart occurs, it can vary from very mild to life-threatening. And consider blunt cardiac injury, especially in our patients who have persistent symptoms despite aggressive resuscitation from their other injuries. And for patients with symptoms of heart failure, acute valvular abnormalities, significant arrhythmias, cardiology consultation and/or echocardiogram may help identify other therapies which could be life-saving. And so with that, I'll take any questions. Yes. That's a good question. I mean, I looked briefly at some of the notes from the other hospital. I didn't see a record of anyone noting, a heart murmur. I think clearly listening to the heart and making sure we don't hear something that's abnormal. The challenge with that specific injury, again, like I talked about, there can be delayed rupture. And so it's possible that, maybe it wasn't present in the emergency room when they did their workup at that time. So I think the key thing is kind of keeping an eye out for changes, or especially if the physical exam changes. So, if someone doesn't have a murmur and suddenly they do, I think it's important to think about that. What is the reason? And but yeah, it's hard to say. Yes. Yeah, and again, I'm not a cardiac surgeon, so but we try to repair valves as best we can. The issue is that the native valves last, for many people they last a lifetime without any issues. And when we put prosthetic valves in, generally they have a lifespan which is not a human lifespan. And so if we can repair valves, we prefer to do that. So we have a lot of experience, in the mitral space that if we repair the valves as opposed to replacing it, that's a better option. Now, the challenge is that it depends on the mechanism of the injury and whether the surgeon thinks that they can repair it or whether it needs to be replaced. And so that's an important decision that surgeons make. And, they try their best to repair things. Sometimes things aren't repairable. And either, the reality is that the patient would probably not survive if they didn't have some intervention. And so we need to do whatever intervention we think is right. And so kind of move forward that way.
Thank you, Dr. Shapiro.
Thank you.
always love coming to this conference because I think about things that as a trauma surgeon I wouldn't necessarily think about in our trauma patients. We so appreciate your contribution. Next up, we have Dr. Kaiden. Dr. Kaiden is an internal medicine doctor by training. He's also the chief medical officer here at Boulder Community Health and my boss. You know, Dr. Kaiden is such a great partner for trauma and has supported us in our growth and really is one of our biggest cheerleaders. So we really appreciate his contribution to our practice here.
Thanks, Laura, and thanks, Robert, for that great presentation. You know, reflecting about the presentations we've seen so far from Dr. Vissers, Dr. Goldman, Dr. Gross, and Dr. Shapiro, I'm an internist, so I'm just like overwhelmed at the expertise we have in this room. And then I'm looking around and I see like paramedics, nurses, multi-specialty physicians, PAs, NPs, administrators, therapists. You know, it's really amazing. So I'm so proud of this team and, you know, whatever limited involvement I get to have. And I also think it's important, you know, when Laura and I were talking about what we want to accomplish at this symposium, you know, it reminded me that trauma is hard. Like, this is hard work. Seeing some of those pictures that we've been seeing, fortunately, some of them had really amazing outcomes, but they don't all. And so I just wanted to take a moment to reflect on that and thank all of you, because all of you who are caring for these folks from the beginning, pre-hospital to post-hospital, you know, it takes a toll. So I think it's really important just to thank you. So I just wanted to sort of give you a little appreciation. And so as Laura said, I'm an internist. And so you may be wondering, like, what do I have involved in trauma? Like, why would you know, need an internal medicine doc? And I felt the same way when I started going to the trauma meetings about 7 years ago. And when you go to these trauma meetings once a month, you get a group of multi-specialty surgeons, general surgeons, orthopedic surgeons, neurosurgeons, paramedics, emergency medicine, radiology, anesthesia. I mean, it goes on. It is one of the biggest multi-specialty teams I've been privileged to be a part of. And they really work like a high-functioning team, and a lot of that has to do with the trauma team who's in the back, who sort of coordinates it all and gets us data and allows us to do interventions, quality improvement. And so that's where, you know, as an internist, I've done a lot of primary care, hospital medicine, quality improvement, substance abuse, and palliative care. And so you'll see that there's two real main things the way I look at trauma. One is this multi-specialty expertise, acute care. It's so important, and we crush it. I think you can see that. And so much that we're only having like a handful of our experts talk because, you know, there's always next year. There's just so many amazing people that aren't all getting an opportunity to talk. But you also need this system of care. And I think I'll show you there's a little bit more involved than just the acute trauma. So we're trying to do both, and we're just trying to do them really well. And so I wanted to kind of just go through like how we got there and where we're going, just from like the bird's eye perspective. And I promise you I won't show any gross pictures, and there won't be any like major medical facts you'll have to learn. You can see the hospital started just about 100 years ago as like a small little hospital, 15 beds. At the time, a few physicians and nurses and caring for a small group of patients. Over time that grew. You can see that in 25 we had this larger hospital, 45 beds. Then you can see the Broadway and Balsam, the one that I was at when I first moved here 20 years ago. And a couple things I'll point out. In the 60s, that's when trauma programs first emerged. This idea that you need a system of care and that communication across huge teams is really important, and that improves outcomes became more apparent. In the 70s, I just looked this up because I was like, did they even have ER docs back then? And you know, in the 70s is when ER became a specialty. So you went from this community of general practitioners, general surgeons, nurses, to this like more specialized care, which is, I think, more of like an example of how medicine has gone over the last 100 years, particularly in the last 20 years. In '96, we became our first trauma designation at BCH. And then we moved to Foothills in '03. First, it was a 60-bed kind of OB hospital, peds. And then in '14, we moved out of Broadway and we got our level 2 trauma designation. And so I think most of you know this, but there's level 1, 2, 3, and 4. Level 1 is the highest, and that's really for academic research organizations. That's really part of the mission, so you can't really become level 1 unless you have that. Level 2 is the highest you can get at our size community hospital. And then there's 2 designations for level 2. There's the state, which is a little bit easier to attain, a little less resource intensive, and then there's the American College of Surgeons, which is like the elite of trauma programs. And it took us a while to become ACS certified because it required a lot of investment in resources, which we did eventually get. In 2021, we became American College of Surgeon designated. Why does that matter? Because the American College of Surgeons, as the leaders in this field, they have all these rules and requirements, and as an administrator, they sometimes seem expensive, sorry, Rob, and frustrating, but looking back, they've greatly improved the care. So a couple things, they require 24-hour in-house trauma surgeons. That, I apologize to the trauma surgeons because that is disruptive and difficult, but it greatly improves the care of our patients. We also had to bring anesthesia in-house 24/7, which also improves care of like our OB patients and our other patients in the hospital. And then we brought in a traumatologist. Dr. Harmon is our first general surgeon traumatologist, so specialty trained in trauma. And then you saw Dr. Gross, and what you get when you get an orthopedic traumatologist, really an expert in orthopedic trauma, to partner with the rest of his team. And then in 2023, we added a geriatric trauma medical director. I saw her, there she is waving, Liz. She's gonna talk to you later. And you're gonna be like, why are you having a geriatrician? But I think you'll see why in a minute. She's gonna talk later, and I think you'll like that. And then in 24, we're looking at bringing in palliative care trauma surgery and expanding vascular. So see, these are some of the things we're doing. So we're responding to this specialization of medicine, which it's sort of overwhelming when you see this facial trauma and cardiac trauma and all this stuff. And so I thought, before I went further, I would just sort of maybe take a little audience participation, because we've seen a lot of the examples of trauma. And so I just wanted to ask, what is a trauma patient? Like, maybe just yell out. What type of patients do we see? Cyclists, yes. In Boulder, we see a lot of cyclists. Let's see, Tyler's gonna help me out here. So we have a lot of cyclists. I'll get to those stats today. And those are the competitive cyclists, but you see a lot of like casual cyclists like me, and I worry about every time I ride my bike to work that I'm gonna be on the trauma team, not as a provider. What else? Climbers. In Boulder, we've got quite a bit of climbers. There you go. What else? Say again? Skiers. We don't have a skier, but yes, we have all sorts of athletes, especially in Boulder. We have all these like outdoor athletes. What else? Car accidents. Is that what I thought? I thought that was going to be first, car accidents. We see a lot of car accidents. What else? Okay, motorcycle. Why is Liz Lysette here? Does anyone know? Why do we see geriatrics in trauma? Falls, right. That's 5, Tyler. And what about, people sometimes notice in Boulder that we have a lot of disproportionate, we have some wealthy and we have homeless, et cetera. Do we see homeless patients in trauma? And then, I can't remember what 2 is. No, Tyler, help me out here. Oh, there we go. We see elite athletes, football players. In fact, we had a few this year. And I think it's interesting because I think we often forget the geriatric trauma and the homeless patients. And I'm not trying to lump them all together, but substance-related issues, alcohol and drug. And I think those of you who take care of these patients, you don't forget that. You know this. But those are actually the biggest proportions of the patients that we see. And so when you start seeing that, you start thinking about trauma a little differently. And I think I put some stats here. So more than half of our trauma patients at BCH are geriatric. The majority are falls, not all. Some are motor vehicle accidents and other things. And I was shocked to see that almost 3/4 have some component of substance abuse or alcohol. And then I wasn't sure, but 15% are, I guess you could call it recidivism. They're returning trauma. And I once read about trauma. It's sort of like, I think obesity can be seen like this. It's sort of infectious, like people that have trauma tend to get it again. I thought it might be higher. And so I'm a population health quality person, that's my background. And so I start thinking about trauma a little more broadly. When you look at this, you start to think, what could we do to prevent trauma? Geriatrics, maybe there's fall prevention, maybe there's changes in meds, reducing high-risk meds. Liz is going to tell us more about that. And when you think about substance abuse, you think about prevention and treatment. And one of the most obvious things is people that with trauma, with substance abuse, in the past would just sort of languish in the hospital in withdrawal. And now we have new treatments like medical-assisted treatment for opioid addiction. And so you can really take an angry, uncooperative, difficult patient and make them this sort of a compliant patient by putting them on treatment. And so we started doing that, 5 or 7 years ago, and offering, for example, people that are addicted to opioids medical-assisted treatment while they're in the hospital, both to take care of them acutely and then to hand them off to our partners that do long-term substance abuse treatment. So we're trying to think about this a little bit more broadly from a quality improvement perspective. And so I just put a little plug for a couple of our programs. Where's Amanda? I saw her earlier. There she is. There's Amanda Werblowski. She's our pillar manager. This is a grant-funded program initially through the city of Boulder, now through our foundation, and then BCH funds this. But this is a program we have to help navigate, provide access to treatment and prevention for people that have substance abuse, so that when we do have trauma patients, we're not expecting the trauma surgeon or the ENT to be an expert in this. But fortunately, one of the things we learned really early, was that we have a lot of people that are experts, and I think there's some of them in this room, that are willing to treat these patients, and they're great at it. And so we started working with these patients and making sure if they wanted it, they had access to treatment. I'm glad we're not in COVID times and not all wearing masks. And then the Trauma Survivors Network. This is cool, and before I get to it, I'm just going to tell a story. I visited a trauma patient the other day. I'll just call her Jill. She's 27. Some of you were involved taking care of her. It's pretty traumatic. She was biking with her husband to the rock climbing gym. Pretty healthy woman, never really had medical problems from what I could tell. And she got hit and run and dragged about 100 feet by a car. And she had some significant injuries, multiple orthopedic injuries, multiple neurosurgical injuries, a lost tooth. She was pretty messy. So I went and saw her first in the ICU, and she couldn't really talk, and her husband and I chatted a little bit, and she was just recovering. And then I saw her yesterday, and she's getting a lot better. And the first thing, I introduced myself, and I just asked how she was doing and how the care would, and she started to cry. And she said to me, "I can't believe this happened to me. Like, how did this happen? And when am I going to get my life back?" Like, she's talking like she's going to go to long-term acute care and then rehab. She might be months until she gets home. And I felt proud that over the last year, where's Sadie? Sadie's here, right? Yeah. Sadie's one of our trauma team members who's spearheaded this Trauma Survivors Network, because I think, as Dr. Goldman was talking about, trauma has external injuries, it has internal injuries, and it has emotional injuries. And we're trying to make sure that, when you look at some of these patients, you can only imagine how traumatic that must be emotionally. And so this is one way that we get, I think now there's 10 patients in a room, and they get to sort of talk about the trauma that they're experiencing, what's worked and what hasn't, and there's a little bit of a support for them. So I think this is just one way we're trying to treat trauma more as a system and more, end to end. And then the last thing I want to do is recognize, and then I'm going to turn over to Jackie Atlas-Priest, she's the chief nursing officer, I'm the chief medical officer, together with the administrative support for the trauma team. And as you've seen, trauma is a team sport. I'm going to focus a little bit on the physicians, and Jackie's going to talk about the nursing and the rest of the team. But the together is crucial. You can't do one without the other. And this team is pretty darn amazing, and I like to say any one of these medical directors or nursing leaders could go anywhere, a level 1 or level 2 trauma center in the country, and they would get hired, be program director if they wanted. In fact, they're often trying to steal them. We have a really amazing team. I think you've seen that. I wanted to just call out some past leaders. Dr. Jones, Charlie Jones, all of you know him probably, was our trauma director for many years and still on the trauma team providing care. My predecessor, Dr. Paul Lewis, was the chief medical officer and an ER doc and really dedicated to trauma and helping us get to level 2 trauma and really had a passion for trauma. And then 2 of our key nursing leaders, I think Jackie's going to talk about, so I don't want to steal her thunder, but Holly Peterson, who was our trauma nursing director until recently, and Joan Palin, who really kind of, I would say, got me involved in trauma and started telling me what I needed to do and helped me learn how to manage trauma. And then our current program, you've seen Dr. Harmon. She's in the way back. Obviously, she's done an amazing job in getting this group together, getting this symposium together, bringing all the right players. The best thing I can ever do is just hire good people, and that's a great example of that. Dr. Marthaler, is he still here? I saw him. He's our Associate Trauma Medical Director. Lisa Allen is one of our nursing directors. I don't think I saw her. And Josh Rabinski, who is the trauma manager. And Jackie will talk more about them. I don't want to leave them out because they're pretty amazing. And then we have many trauma medical directors, and we have many people I'm leaving out, so I can't acknowledge everyone, but I wanted to acknowledge some key folks. Steve Gross, you saw him speak earlier, really upped our game in orthopedic trauma management. And these pelvic fractures was like sort of was really like a bugaboo. Like we didn't really have a great way to manage those until Steve got here. And that, amongst many other things, has really helped us manage orthopedic trauma. Dr. Lysette, I mentioned already. And then Dr. Savendel spoke last year. He did a great job last year. I wish he was speaking again. He is a pretty amazing ER liaison, and he also manages a lot of the pre-hospital paramedic groups. He's their medical director. An amazing asset. I think many of you know him. And with that, I'm going to turn it over to my partner in crime, Jackie Atlasey-Priest, who's our Chief Nursing Officer.
Thanks, Ben. And Ben is a great partner as well and has done a lot to advocate for and support the trauma team. So give Ben a hand as well. So I really appreciated Ben's summary of the trauma program, and it is a rich history here at BCH, and many of you have been a part of that program for many years. I would say that as you look at the areas where we see the different types of trauma patients, I am sure I will someday be in here as an elite athlete who has, done some high-risk thing. Anybody that knows me knows that that is a little levity in the room. I'll be the one that comes in and needs to see Dr. Lysette because I broke my hip, I'm sure, by a fall. I do want to just take a minute to recognize really the backbone of the trauma program. And before I do that, I need to acknowledge a broader team as well. So again, I want to tell you that behind all of the great clinical team, so that is our physicians, so not only our leaders, but all of the physicians who work with our trauma patients, all of our nursing staff, all of the techs and technologists that take care of our trauma patients, all of the variety of specialty of therapists that take care of it, our pharmacists. It is really a team sport. And behind all that team is also a team of support staff, our lab, our EVS staff, our chaplains that deal with the trauma patients and their families each and every day. And of course, even our food and nutrition and our dietitians, all of them have to come together to create healing for our trauma patients. But again, going back to the backbone of this trauma team is a really highly skilled, highly trained group of nurses who spend hundreds of hours each and every month to assure that every patient encounter was perfect, and if it wasn't, what we can do to make it perfect next time. They help us look at metrics and look at our quality and assure that all the protocols are being followed. We are following the standards across the nation that are considered of the highest quality. And not only do they meet those standards, but they make sure we exceed those standards so that we can care for this community. So first, I'm going to start with 2 retirees, and I don't believe either one of them are here, but we call them our Jones. So we used to have 2 Jones in our trauma program. So first, Joan Palin, as Ben acknowledged, was our trauma program manager for many decades, for actually a decade, over a decade. And before that, she was in the infancy of that trauma program way back when. And before that, she was one of our ED nurses and was an excellent clinician herself. She retired earlier this year, and Dr. Harmon got to see her over the weekend, and she's doing well. She was not able to get here today. She's about ready to celebrate her daughter's graduation from medical school. So we are very proud of Alec as well. And we want to just publicly acknowledge the huge amount of work that Joan gave to this program. The second Joan is Joan Depew. Again, a long-term, excellent clinician at BCH. She worked for many years as well in our emergency department and then has had many different roles. And including when she retired earlier this year, she was our trauma outreach and injury prevention coordinator. Again, she did a beautiful job of building connections in our community, did a lot of prevention work in our community, whether that was bike helmets or whether that was fall prevention with our elderly. So again, we really acknowledge Joan's work to make Boulder County safer for everybody. And again, I don't think Joan is here, right? Joan is not here. Okay. All right, so next I'm going to move to our current team, and Ben already mentioned Josh Robinski. Josh, back in the back, is now our new trauma manager. He has been our trauma coordinator for many years. Prior to that, Josh worked and was, again, another excellent clinician in our ICU. He was a clinical team lead. Recently, he has been working full-time and working and has accomplished and has gotten his bachelor's degree in nursing as well. So we look forward to all of the great work that Josh is going to do as he leads as our trauma manager. So thank you, Josh, for all of your work. Next, Terry Olson. I think I saw Terry. Yep, Terry's back there as well. Terry Olson has been with the trauma program for about 3 years. But he's not new to trauma patients. Again, Terry has been with BCH for many years. He worked in our ICU. He worked in, more recently, in the last part of his career, has been with our quality team. He has really helped us improve quality across many different populations, and now he is applying that knowledge and his skill to our trauma program. So thank you, Terry, for all of your work to create such a high-quality program. And then another new member is Sadie Malthaler. I think she was introduced as well. Sadie's back there someplace as well. Sadie now is one of the Jones. She took over as our new injury prevention and outreach coordinator. And as you heard, Sadie has led the efforts to really create this trauma survivorships network. And so we really thank Sadie for taking on that work. And she will continue the work in our community and injury prevention as well as she continues in this role. So thank you, Sadie, for your work there. And then finally, I'm going to acknowledge one of our directors of nursing, Lisa Allen. Lisa is fairly new to the trauma program. She has been a director of nursing for a while. She has been working with our Family Birth Center. And then when Ms. Holly Peterson retired, she took on the emergency room, emergency departments, as well as our trauma program. And she has been a great partner with Laura to really, again, move that trauma program forward. Any of you that know her know that Lisa is very compassionate, and she has a lot of kindness, not only for all of us, so her colleagues, her staff, as well as the patients and the families she serves. So again, thank you, Lisa, for all of your work in the trauma program. So again, we have some great talent, as Ben said, in all of our programs. And I want to thank all of you for attending this program to learn from each other and to keep expanding and improving our trauma program at BCH. So now it is my very big honor to introduce through video the amazing story of Erik Erikson.
So I've been doing stuff like cycling pretty much forever. Played sports in college, did a lot of stuff after college, and an Ironman finisher and the whole stuff like that. The reason I was on a longer bike ride, I hadn't been on a 70-mile ride in a number of years, my brother and I had planned a trip to go to France in July. And so just getting ready for that. So that day I had planned to ride my bike, we live in South Boulder, planned to ride my bike to the Carter Lake Marina and back, which I've done 50 times over the last 30 years, maybe 150 times, I don't know, a lot. When on the way back, I always stop at the, if I stop at the same store. There's only one store in Hygiene, a little Hygiene market. I remember looking at the woman and ordering my burrito, and I remember riding south on 75th Street, eating my burrito, and that was the last thing I remembered until, 7 days later, Friday.
My dad, oh man, he's incredibly positive all the time. He's encouraging, yet holds a high standard for my brother and I. I don't know why this is hard to talk about.
Yes, our kids are 24 and 25 this month. Yeah, they've always done all the stuff. They've been easy for us. Everyone has challenges in life. Our kids were never that challenge for us. You know, we've done a lot of stuff with them, of course, as parents do over time, and put the idea in their head when they were 8 and 9 that they wanted to play college sports, whatever that may be. And they both ended up playing college baseball.
I didn't think of myself as somebody who was the caliber to play Division I baseball at an Ivy League school. I just knew that my parents were the caliber to raise somebody who could play Division I baseball at an Ivy League school.
You know, I was proud of them when they were 2 and 3, hitting a wiffle ball in the backyard. You know, they've always been a lot of fun. And certainly the highlight of my life is those kids.
I was about having 2 boys, wanting them to know how to talk about their feelings. And so I would do icebreaker questions at the dinner table.
It would go with my mom trying to ask an intentional question or identify a feeling on the feeling wheel.
I even had a feelings chart where they had to point to a feeling and tell what that feeling was and why they had that feeling that day.
And my brother and I, at like the age of like 8, are like, do we really have to do this? Like, can't we just watch baseball or something?
I'd like to think that they were grateful, so.
Just so grateful for how they raised my brother and I, and just what they did, just on a day-to-day basis to love my brother and I. My parents were amazing.
So I believe it was a Saturday, driving into Boulder on Highway 119.
I was driving my daughter to softball. So we were on the diagonal road and
there was a triathlon going on. And so they had closed down one lane of traffic. So we were all going very slow, maybe 10 miles an hour in the traffic lane.
You know, we were sitting there and I kind of out of the corner of my eye saw this guy riding and I kind of saw Erik go down.
One cyclist riding along just fell over. Didn't crash, didn't run anything, just fell over.
But it looked really weird because it didn't look like he hit anything or whatever. So in the back of my mind, real quick, I was like, is that a medical event that caused that? Or did he hit something? You know, it was up a ways, right?
And I just kept thinking, somebody stop, somebody stop.
And then I saw a guy pull over real quick and run over to him.
Nobody stopped. So I pulled over into the median and jumped out and got there, and Eric was just non-responsive on the ground. Some other cyclists started to stop then. Someone verified that they had called 911.
It was early in the afternoon and we got a telephone call from the paramedics that they were inbound with a gentleman who was observed to have a crash on his bicycle. We were already thinking there's sort of two big possibilities we need to be concerned about: cardiac issue and also trauma issue. So we actually initiated a cardiac alert and a trauma alert on this patient based upon the information we had.
Bill rolled up and said, "Have you started CPR?" And I said, "No, he's breathing." And turns out, because I'm not all that educated, it was agonal breathing.
And I noticed he had agonal respiration. I noticed he was not breathing.
I guess that's actually the throes of death.
Every time I've seen near death or a death-like experience, I've noticed somebody going into that agonal breathing episode. And so I checked for a pulse, and he did not have a pulse. So I directed the other bystander and said, "Hey, we need to start CPR."
He was actually having a massive cardiac event. And thankfully, because of that triathlon, the motorcycle medics showed up pretty soon thereafter.
And a medical crew that was close by was able to come by and actually put him on an AED device and found out that he had ventricular fibrillation.
And ended up defibbing him a couple times, if I remember right.
And was actually shocked back into a normal rhythm.
And then you continue CPR. So Bill was amazing, kept asking for meds and kind of instructing and leading the way.
They ended up intubating him, got a line, and they pushed epinephrine on him.
Even though he was on a ventilator, and it wasn't because he wasn't able to breathe on his own, but it was because he was so active and feisty.
We've all heard the term fighting for your life. I think that's a great example of that.
I feel like this was 10 minutes in at least when ambulance arrived.
And at that point, it was time to load him on the stretcher.
He was brought to the emergency department emergently for further evaluation.
I was out back cleaning our shed, and so I didn't hear the phone. And the emergency room had tried to call, the sheriff had tried calling. Sheriff knocked on the door, and when I didn't respond, he came around the back gate. He shared that Eric had had a bike crash and a heart attack and was in the ER.
The patient showed up, was brought into our resuscitation room where he presented with obvious signs of a head injury. He was combative, not making sense, nonverbal, and had no idea what had happened to him. He was seen by myself as well as Dr. Leibowitz from the trauma surgery and Dr. Shapiro from the cardiology service right away.
So when I met him in the emergency room, unfortunately, he was not able to respond to questions. So I had kind of limited information about what happened.
We did an EKG on him quickly and did see that he had evidence of an ongoing heart attack. He was taken over for a complete set of trauma scans
to try to help us make sure that he didn't sustain any life-threatening injuries in his fall.
Fortunately, those scans showed no evidence of an obvious injury. The patient was taken up to the cardiac catheterization lab fairly quickly by Dr. Shapiro and his team.
When we brought him to the heart catheterization lab, we found 100% occlusion of his front artery. So when people talk about the widowmaker, that's what they're talking about. We're looking at Eric's arteries in the cath lab. And so what we see right here is that the dye is kind of hanging up, you see there at the end. And so there should be continuation of blood flow down a big vessel here. And so that's the area where the acute blockage is that's causing his heart attack. He had cholesterol in that artery, and then the cholesterol plaque had broken open, and then he formed blood clot on that artery as well. And so there was no blood flow going down that artery. That caused his heart to go into a dangerous heart rhythm, so he didn't have any blood flow to his brain. What we see is we actually put a wire across that, and then we try to suck some of the clot out with a special device. And we still don't have blood flow down that vessel. So then next what we do is deploy a balloon into that artery, and we balloon and crushed the plaque and the clot into the vessel. And we're starting to get some blood flow down the vessel. So we see the vessel coming in 2 different branches. And then what we'll do is place a stent. During the procedure, he got very sick. His blood pressure went down substantially, and we had to put him on some medications to help keep his blood pressure up high enough to sustain life, and then transferred him to our intensive care unit.
Drove myself here to Boulder Community, and on the way used Siri to call Eric's mom, my dad, our kids, his brother, his sister, I think our prayer chain at church.
She just said, "Hi, I'm on my way to the hospital. Your dad had a heart attack while he was riding his bike." So I bought a flight the next morning. I flew out at like 6 a.m., got to Colorado, and then just went right to the hospital.
Eric had already been in surgery, and they put a stent in, and he was recovering in the ICU.
He was a 2-to-1 from what I remember. That means 2 nurses taking care of 1 patient.
I was her second. She was primary.
Mass transfusion protocol, got multiple units of blood.
So he was on 3 vasopressors to maintain his blood pressure. There was hanging blood. Plus he was on the ventilator, so suctioning.
Patients are pretty sick when they have 2 nurses for just 1 patient. So.
There were 2 seasoned nurses that had about, 50 years of experience between the 2 of them. They've both been here for many years.
We always joke that Krista and I probably have like 60 years between us, nursing.
Both of us have each have 33, 35 years each.
Part of ICU nursing is not, just taking care of the patient, but explaining to the family, what are we doing,
So we don't just have 1 patient, we have multiple. We have the son, we have the wife.
It's part of being an ICU nurse. It's great.
I remember walking in. My mom was there with some of her close friends. I saw my dad. He didn't look like my dad. He had tubes everywhere. He didn't have the same color to his face. He was beat up.
That was the hardest day and the most difficult, I think, and the most critical for him.
My brother showed up a few hours later. He saw my dad. He came to realize what was really going on.
Thank you so much for praying for everybody. We've been friends forever. Hope you're well. I miss you. I'm going to be good.
After that, he did not improve as people thought he would from that procedure. And so a second procedure was done to augment the pumping of blood from the heart.
When you have an Impella device placed,
It actually can supply the amount of blood flow that your heart would supply normally.
you're on blood thinners. And so he was on heparin, which would thin his blood out, which contributed to him bleeding.
And he required multiple blood transfusions and medication to keep his blood pressure in a safe range overnight.
They had to take the Impella out because he was bleeding so much.
So when Eric was getting the Impella pump out, they didn't wait to take him to another room. I was in the room. This was a very serious situation, and I held Eric's hand and I prayed, and I pictured what I learned as a kid, the 23rd Psalm, and going through the valley of the shadow of death. And I was just saying those words, and I don't know if it was all night, but it was a long time. And that helped me.
And then thereafter, unfortunately, he continued to have issues with blood loss.
I couldn't figure out where all this blood had gone. We had already looked at his chest x-ray and there was no blood in his chest. And Dr. Mahan said he'd lost a couple hundred cc's, but that didn't account for 10 units of blood that were transfused overnight.
Despite the fact that the imaging in the emergency room didn't demonstrate any bleeding,
we decided to repeat the CAT scan of his torso, and what we found was the explanation for where this blood had gone. He had a liver laceration as well as a spleen laceration, and that changed our direction, and we took him to interventional radiology,
where Dr. Farbach was able to embolize the artery leading to the bleeding.
Through a technique where they go in with a catheter through the groin artery and find the bleeding in the liver and put little coils into the arteries to make them stop. Otherwise, surgery would have been necessary. And that day, he stabilized, and I think the following day is when we extubated him and he started the road to recovery.
Throughout the next few days, like, things start to turn around slowly but surely. Like, machines start leaving his hospital room, and then instead of the tube down his throat, he gets the tube out, and then they finally start taking him off of sedation, and he's slowly starting to come back into consciousness, and then he can start to drink water, and then he starts talking.
When I was waking up during that week, I always thought once you're in the hospital, you know, you're under care. You have as much chance as you ever could possibly ask for.
The whole experience really opened my eyes to just the extensiveness of the hospital care system, from machines to the people. And
the doctors are huge, right? I'm not here without many qualified and exceptional doctors who happen to be great human beings. You know, it doesn't work without great nurses who are great people, and I experienced that. But everybody else matters too.
The people bring my dad food, and the people who are like filling the printer with ink.
And none of this works if the lights don't work, you know, if we don't have power. I mean, there's so many people going to the business of healthcare, and all of those people matter. All of them matter. The person who checked me in, the person who welcomed my family, friends and family, the people who coordinated that, you being here.
It's just everybody at the hospital, whatever they did, they just responded to whatever was necessary.
And not only caring for me, caring for my family, and caring for all of the other people who are here at the same time, coordinating all of that. It's not just me. You have halls and halls and halls of people who have something going on, and they need that expert care and attention too. And that's what you guys do, and you're fantastic at it.
People ask, "Oh, how's your dad doing? Like, what's he been up to? Is he recovering?" And I just say, like, no, like, he's recovered. Like, he's participating in life and doing it at an exceptional level, like he was doing it before the accident.
When Eric and I were talking about the question on how his life was changed, he felt like, I can't answer that question. My life hasn't really changed. And I said, that's the point. Your life was restored.
Yep.
The team of professionals here, the support of our friends, the love of our neighbors, our faith in God. And at the top of that list is Boulder Community Hospital, and we have them to thank.
Yeah, forever. Yeah, it's not just today, it's, you know, for as long as we live.
I'm glad when people ask, like, how your dad's doing, like, I can say he's doing really well. So, and that's, yeah, it's because of Boulder Community Hospital. So, yeah, thank you. Yeah.
Join me in welcoming the Erickson family to the stage. We're going to adjust a little bit. Can our screen go up? And all the Erickson family, please come in and sit down. I think we'll start with introductions. Do you want to start on your end and tell us who you are and how you belong to this guy? going. It'll come.
All right. How's it going, everyone? Thanks, first off, for everyone being here. My name is Jeff Erickson. I'm Eric's youngest son.
Hi, it's good to be here. My name is Matt Erickson, and I also belong to this wonderful family.
I'm Sue Erickson. Thank you for being here.
My name's Eric. I am the one who gets to say thank you, thank you, thank you.
Hey everybody, it's nice to see you. So I'm with the chaplain department. My name's Ark. Many of you know me, many of you don't, but to those who don't, it's well met. Glad to be here with the Erickson family. So my role at the hospital is to tether to families' needs and support needs during times of trauma, during times of hardship. And I had the privilege of being with the Erickson family from the moment they came in, really throughout a lot of their time there. I didn't see Eric a lot until after he woke up, but yeah, I was mainly supporting family. We're so moved. I think I'll speak for everybody in the audience. That was a really, really touching movie. And yeah, I'm just curious to hear about what your thoughts are about, or what landed with you about that, or if there's anything more that you wanted to share.
You know, when I first saw that movie last week, my first thought was, wow, that movie was really good. That was incredible. When you see Jess, she just had a baby a few days ago. When you see her back at the office, drop by, what a professional, just a representation of the kind of professional that works here. It's absolutely amazing. You know, the next thing I saw when I saw that movie, you know, my brother's here too, and we've ridden our bikes all over the country, especially when we were younger. But I think of all of the places I've been, and I've been a lot of places, and I've been on a lot of back roads around the world. And just to see that, where I call it when I got dropped, right? I got dropped at a half Ironman triathlon. I was not in that event, but I think of all the places that I've been, and that happened to be probably the most optimal place that I've ever been in 60 years in the entire world. So I want to give credit to God. Thank you, God, thank you, God, thank you, God, that I get a chance to speak to you today. There's no other way that this thing happens. This is all part of the huge plan that God has for all of us and for each of us individually. So I just want to acknowledge that first. And then you think of all of the stuff that happens, right? I'm probably the highlight of this movie for 12 seconds, really, until Kevin gets there, and then Bill right behind him. And then after that, it's all about you and every single person in here. And so many people from our community are in here too. And our community is throughout Boulder County, throughout Colorado, throughout our country. We have communities that supported my mom. My mom came out. She hadn't flown since before COVID. You know, community that supports my sons, the community of multi-decade community that supports my wife, and a lot of those folks are here from 30 to 40 years ago. And you know, of course, my friends and family, and my brother's here, my sister's here. Yeah, it goes on, and this doesn't really work without that community.
Do you feel like Matt and Jeff, you want to weigh in, or Sue?
Yeah, I thought that video was incredible. I remember watching it for the first time a few days ago, and I was just getting emotional because it's hard when you get a phone call that your dad's crashed and that he had a heart attack. It's hard to kind of wrap your mind around it, and kind of like what Matt was saying in the video is like I didn't really understand the severity of the issue until I kind of got there and I saw the tubes and I saw his face was yellow and all the surgeons there, and it's I really broke down. I remember it was very emotional for me then, and just kind of like reliving it now is crazy. So definitely credit to Boulder community. So grateful that everything kind of came together. All the pieces kind of fit in, and it's just really amazing that we're even here today. And yeah, that's what I got to say. So thank you guys.
Yeah, walking in today and seeing everybody here and hearing about what the hospital's been doing for decades and the effort that's been put in and the coordination to move up certain levels and all these different treatments and cares and people is just so amazing. Like, my dad's story is an incredible one, but Boulder Community Hospital has been doing this for years, and it will continue to save lives for years to come. And it's just, we're up here speaking, but it's not about us. It's about the people lives that will continue to be saved in the future, and the lives in the past that have been saved.
Yeah, what struck me in the video was when Kevin, the owner of the Boulder Rock Gym, talked about cars just going by, and are they going to stop? Are they going to stop? And then he stopped. And Bill, the firefighter who saved Eric's life, is here, and he stopped. And I want to be the kind of person that stops. And that's what struck me. So,
Thank you all for sharing about that. I think that there's one piece of this story that was present with the interview that we conducted at first when we were starting to get some footage for the documentary that we made, but I didn't see that coming through in the video. And I'm just curious to hear more about, you know, the cancer story, and that you're a survivor of cancer, and I know that you brought that up to me a number of times, and you know, what more would you want to say about that?
Yeah, you almost kind of forget about that. But you're reminded about 13 seconds later. You know, I think, in a way, I mean, I did the whole cancer thing, and you know, if you haven't been through it yourself, you will have friends or family members that go through it. That's just a crazy thing. But cancer was so different because that was such a long lead up. And there were so many great things that happened actually around having cancer, and many of you people went through that journey with me. And I think of my brother Mark, who was there all the time, Pastor Mark, who was there all the time, Warner, who was there all the time. And I really appreciate you guys for just, you know, walking alongside me during that difficult cancer adventure. Yeah. But, you know, one of my friends who's here today, Charlie, was going, you know, gosh, you had a heart attack. You know, if you had a heart attack, what about us? Right? And so this was, his add to this was extremely helpful, and something I've reflected on since last July when he came by. And, you know, it was 600 hours of chemo. You know, my oncologist said that was the strongest chemo by far that he'd ever given anybody. And, you know, of course, we all look to the internet now for medical advice. And you know, Charlie said that, you know, after that kind of intense chemo, you know, stuff breaks. And you guys are medical professionals, you can add more to it than that, but that made sense to me. And so this heart attack resulting 4.5 years after I finished chemo, thank you God, you know, that was just a downstream effect of going through that cancer adventure. And, you know, I've met a lot of great doctors, a tremendous amount of great nurses, healthcare professionals over the last 5.5 years that is just astounding. I don't have any better words than it's just astounding, and I'm so thankful, grateful, and blessed by the great people that I have come into contact who have helped me, helped my family get through these adventures. You know, so much so that when I left Boulder Community Hospital last June, after being here for 10 days or so, you know, it kind of made me think, did I choose the right career? Right? If I knew I had a chance to go to work with all of these phenomenal people every single day for my career, maybe I would have made a different choice. Because to be around all these great human beings who happen to be doctors, who happen to be nurses, who happen to be orderlies, who happen to bring the food, it really made me think about it and be so appreciative that you are here, that the A team is here. And I was just thinking about this on the way over, so let me add this. I was thinking, you know, when there's a job opening at Boulder Community Health, right? How many applications do you think they possibly get for being a trauma surgeon, for being a receptionist, for being a busboy? Thousands, right? So they get to choose whoever's in charge of that, chief medical officer, however they do that, the business person, the CEO, whoever. They are choosing the best of the best of the best. This is like going to Top Gun. For you as medical professionals, this is your Top Gun. This is Boulder. And for us as, you know, the patients, we couldn't get better care anywhere else in the world because of the kind of team that's been put together here. And I was just reflecting on that when we were driving down Cherryvale on the way over. So there's so many reasons to be thankful, so many ways to be thankful, and I'm just thankful I have a couple of minutes to share that. So
I think maybe the audience at this point is probably having a good taste of your optimism, and and hopefully also feeling your appreciation of them. And you know, speaking on that point of the optimism, I'm just curious more about the mindset that you were in as you were going through the treatments for cancer, and what that quality that you bring is.
I think one of the I don't know, everyone has a superpower or something, or we'd like to think we do anyway. I'd like to think that my gift, the gift that I was given, was to be optimistic and funny. That's up for debate. See? In difficult situations. And when I was going through the cancer treatment and you have to sit there and get your chemo, and if you don't know about it, you'll find out about it. And if you've been through it, you know. And I know we have some retired nurses in the audience too who are personal friends of ours. And so they know what this is like. And I tried to be a really good patient. My doctor, once he found out I was going to live, turned out to be a really great guy. We had a super relationship. And we just finished 5 years a few months ago, so done with that. But he was a super guy, and I really got a good chance to touch base with him every 6 months or so over the last 5 years. And but you know, I tried to be a good patient, and I told him that at the end, and we were both sharing, you know, a guy tear, you know. So we both did a little of that for our last appointment. And I mean that honestly, and I think he did too. And I tried to be the best patient I could, and it worked out. You know, when he was telling me, I had 2 cancer diagnoses. One was the kind of cancer you die with, and the other one, re-diagnosed a month later, was the kind of cancer you die of. So when I was re-diagnosed, and he said, well, this is the kind of, you know, long story short, this is the kind of cancer you die of, and it's pretty serious. You know, this is a Tuesday, can you start chemo on Thursday? And I said, no, we have some plans to see Jeff and Matt at Parents Weekend. And he goes, well, you'll definitely have to come in Monday morning at 9 o'clock. And I'm like, okay, got it. But, you know, when he left, and I tried to be funny, but he wasn't taking it. And I said, Doc, you did a great presentation. You know, I'm going to give you a 5-star Google review. And I reminded him of that story when we met in February for the last time. And I got a little smile anyway. So, I don't know. When I was in the hospital too, you know, I guess I was pretty funny during that week that I recall as being unconscious. And I know there's a story about Bud Light, among other things. And that's for a different time. But I remember being super thankful too. You know, I remember looking at my leg, and my left leg, I must have fallen on my left side. And Bill and Kevin saw that because my leg was killing me and had a huge black and blue on it. And the first thing I thought of, well, I'm alive. That's a win. I'm under care. And I always thought when I was going through cancer is once you're under care, you have a chance. And so when I was here and I was kind of starting to process thoughts, I'm like, I'm under care. I got a chance. And oh, thank you, God, my leg's not broken. Because this would really be a pain in the ass if my leg was broken. because it hurt. It hurt like that. My shoulders were killing me. But there's so much to be thankful for. As well you know, hospitals are open 24/7, and they let you know that. So there's always people dropping by to say hi, or you're hooked up to whatever 20-something machines, but they still want to take your vitals. I mean, I don't know how that works. And there'll be more on that later. But there was so much to be thankful for throughout the whole process of going through that. I mean, my family's here, my kids are here, my mother's here, you guys are here. You have friends coming by to support my wife, to support my kids, to support me. And it's just how you poopy when you're surrounded by all these great people. You just can't be. You can't be. And I don't think I was, and you can't be.
You've talked about kind of your experience and how grateful you are for the care that our team was able to provide, which I think is so important because our team often doesn't hear that and they don't get to meet people after they have left the hospital. As perpetual learners, are there opportunities that we could have done things differently that would make us better for the next patient?
Only one thing. And for a show of hands, does anyone spend a night in the hospital? Okay, about a third of you. So you're all familiar with 2:30 a.m. I mean, they just saw you at 11:30 p.m. They will see you at 6:30 a.m. And for some reason, they want to see you at 2:30 a.m. So the one thing you can do better is when you're checking on people at 2:30 a.m. is bring them vanilla pudding. That would kind of lighten the mood a little bit. Oh, we're here to take your vitals, and here's your vanilla pudding. There you go.
I believe that Eric actually requested the vanilla pudding and then got vanilla pudding every night at 2:30 a.m.
So I know you have vanilla pudding back there. I know you do, because I asked for it and I got it.
Sue, is there anything that kind of stood out to you during this time?
Wow. Well, Eric mentioned the team, and I can't help but acknowledge Eric as well as Buzz and the chaplain team, because we had so many people, friends and our neighbors that are here today, many of them, that were there in the waiting room, because it wasn't just Eric in the hospital. We were there 14 hours a day, got there at 7, left at 9 at night. And I remember Eric just coming and being present, talking, inviting people to pray if we wanted to, or to just have a conversation. So that was a huge piece of it as well. So want to thank you for your support. And then, I mentioned the community of people. Our son Matt started a caring bridge, and last I looked, there were, I think, 3,500 visits to
3,700 now.
He's a math guy. 3,700, goodness. And one time we found out, it hasn't been mentioned, Eric broke his ribs. I don't know how many, 6, 8, a lot. And they said, you'll need a recliner. Well, we don't have a recliner. We put it out in Caring Bridge, and we got 5 requests for a recliner. I see one of the people who mentioned we've got a recliner. And then someone brought by, we had 2 different walkers, the mountain bike kind and the regular kind. We had the shower chair, and things just showed up. And that first night, one of our neighbors just didn't even ask, she just said, I'm bringing you chicken enchiladas. We have another neighbor that's a chef, and he brought us 2 different French meals. And then Matt started a DoorDash too, and because we ate all of our meals there and often had our extended family there too, And we were able to use that DoorDash to pay for dinner for everyone. So that's just another piece that I would say, of course, the Boulder Community Health team, but we were just so supported by our neighbors and friends in the community and our church, and just so incredibly grateful. We truly could not have gotten through this without that extended network, so.
Yeah, people want to help. People want to be helpful, and I remember that first few days we needed to eat, and people were wanting to bring meals, and it just wasn't the right time. We had a lot going on, and so then I decided, hey, just send money for DoorDash, and like that's how you can help right now. We're gonna be fine. You don't need to come at the moment, but if you want to help, send money for DoorDash. And then within 12 hours, there was $500 in there, and people just continue to help. And I was like, well, I don't need to eat DoorDash for the next 2 months. We'll start the Caring Bridge and allow people to help. And through that's where we started updating people on my dad's condition, and just allowing people to be in your life and allowing people to help with whatever they can. I think that's something that I struggle with, is letting people help. Like at the end of the day, it's okay to not be able to do it all on your own. And this story of my dad is just it's apparent how many people are involved and how many people want to help, and we wouldn't be up here telling this story without the people helping today.
I think that's such a profound message, especially talking to a room of caregivers, because we often ourselves are not willing to accept that care. So thank you for sharing that, because I think we can all take a piece of that.
It's amazing to hear about the community that you have. It's amazing to hear about just the general support across the spectrum that you've had. And to me, it's something that's not to be underestimated during times of care. As to echo what Laura was saying, it's very important. It's absolutely huge. Yeah. Just curious if there's anything else that you're feeling like you want to share in the space. This is your time.
I just want to at least finish my little spot going. You know, I just want to thank all the members of this community, the healthcare community, our community, our friends and family, my family who's up here, my family who's in the audience, my brother and sister are here. It's what I was thinking of the other day, it is a force multiplier. If you're familiar with that, you get all of these things, you get great health care, you go home, you have a recliner. Thank you, God. Right? You have a great view from your hotel room, your hospital room. It's almost like a hotel. It is. It's because once you're feeling better, and I felt better pretty quick, once you're feeling better, it almost is like a hotel. And don't try this at home. But someone comes into your room with a meal that you selected off the menu. Again, don't try this at home. You give them your birthday, and they give you this awesome meal. You won't get a laugh at home, by the way. But it's really great. You should see the view from the room that I was in. Stunning. Stunning. How can you not get better? How can your mood not be elevated? How can this not work? You have, for me, hundreds of people who are reaching out to you going, how you doing? Or they're praying for you. That matters massively, right? My kids are here. My mother is here. I knew I was in trouble when I saw my mother, but there you go, right? You know, your wife is here. You have all of these great people surrounding you. It really multiplies all of the efforts together for good. And I just want to thank each and every one of you that's involved. If you weren't involved with me, you're involved with others. And I can only say thank you. But the community, for me, that's what did it. We were our friends on our street. We've been getting together for, barbecue, a grill out every summer night for the last 15 or so years. And some of those folks are here today. You know, friends from church for the last 30 years. The first person I ever met at church, Marty, he's here. He turned around 30 years ago this month and said, "Hi, my name is Marty." I'm like, oh my heavens. And he's been like that ever since. So, and I know he's here, and there he is. And I just want to thank him for being the kind of person he is. And you know, and you have Craig, and you have Warner, and my brother Mark is here with his wife Heidi. And it's just an amazing number of people that contribute to recovery and contribute to our lives and contribute to each other's lives. And thank you so much for being part of my life. You guys are absolutely amazing people, and I'm more than thankful, grateful, and blessed by all of you.
What would you all share to other individuals or families undergoing this kind of circumstance?
I can start. One thing that I did after I got back to San Diego, where I live, is I got certified by the Red Cross for CPR, and I did. And I was inspired by Bill, the off-duty firefighter that saved my dad's life, and I was inspired because I want to be the guy that is able to pull the car over and save somebody's life, and I know now I'll be ready for that if that ever happens. So that's one thing I would encourage is both like the skill set's important, but also like the confidence to know that you can be there if that situation ever comes up. So that's what I have, and that's what I'd share.
Wow. Yeah, for me, I think it comes down to being prepared to ask for help and allow others to help. And then what my brother was saying, be ready to answer the call when help is called upon. My mom called me on a Saturday afternoon, and I answered the phone. My dad crashed. The call will come where your help will be needed. And for those who are working in the hospital, that call comes almost every day. Boulder Community Hospital was our home for 2 weeks. We got up, we went to the hospital, we hung out, we ate our meals there, we walked around the creek path there. I was able to nap in the couches there. It was our home for 2 weeks, but for those who work, it's your home for years. And that call will come, and it comes every day, and I encourage those to keep doing what they're doing. And it's been an amazing experience.
Wow. Yeah, I think sometimes it takes a humbling place to ask for help, but I think that that's important for us to do. And then to respond and to, as I mentioned before, be that person that even though it may be inconvenient or like Bill was going to his daughter's softball game, and I don't know if he got there by the first inning or not, but he pulled over, and just realizing that we could be that person ourselves, and so we want to do unto others as we would want them to do unto us. So.
And thanks to Bill and his colleagues at North Metro Denver Fire, we're going to be starting a CPR class for our community at our church right down the street from here, and that's going to be May 18th, and we're going to look forward to doing that 2 to 3 times a year going forward. So hopefully we'll train other people to be like a Kevin, who owns a rock gym, to be that person who can help until professionals like Bill show up and can like lead the charge from there. But you know, like Matt and Jeff said, I wouldn't want to be that person, especially now. Oh my heavens, especially now who sees someone fall on the side of the road and I don't know what to do. I do never, ever want to be in that situation. So I'll be taking the CPR class May 18th, and hopefully many others in our South Boulder community will as well. So thanks to Bill and his team, and thanks to all you do for all of us. Appreciate it.
If you were involved in the care of Mr. Erickson, could you please stand? I just want to say that I'm so grateful that I get to be part of the team, and we are really excited to continue to do this every day. I also want to say, as a new boy mom, Sue, thank you so much for the feelings wheel. It's worked with your boys, and I can't wait to do it with my boy. We're going to move into the lunch period, but I'd really like to encourage everyone to please, if you cared for Mr. Erickson and his family, come up and say hello and shake his hand and give him an opportunity to say hello as well.
We are so glad you're here with us and so glad you made it through, and continue to be that positive optimism for all the people that you meet. Yeah, you have such a gift to give.
Thank you.
Thank
Round of
you.
applause.
Thank you.
Welcome back. Thanks for coming back from lunch. We're going to get started again. Our next speaker is Dr. Diane Daly. Dr. Daly is a board-certified pediatric anesthesiologist and is currently a practicing partner with Boulder Valley Anesthesia Group here at Boulder Community Health. Dr. Daly is also the founder and CEO of Predict, Align, and Prevent, a nonprofit organization that employs location-based data science and binds it to a community organizers and aligns efforts. Dr. Daly is focused on the commitment to open science, objective metrics, and child-centric outcomes, and is my very good friend and one of the smartest people I know. So please welcome Dr. Daly.
Thank you so much for inviting me, Laura. Hey, so this is going to start out a little bit sad, and I know that it's going to sound like I'm going to talk only about children, but this really connects with the work that we do in any sort of trauma. So, and you'll see what I mean as we get into it. So the reason I wanted to open with this picture is that about 7 years into my practice as a pediatric anesthesiologist, I had a boy that looked just about like this come into my operating room one night and bleed to death from getting drop-kicked by his father. And that night, when that baby was dying, I promised him that if there was something that I could do to help other babies like him, to try to get in between whoever was trying to hurt them and them, that I would do it. And it's taken me on 10 years of work for child abuse prevention, and that's what I'm going to talk about today. So starting out, after that event occurred, as an anesthesiologist, I didn't have a lot of knowledge about child abuse, just the things that you learn in the books about head trauma or which fractures to look out for, that sort of thing. But I didn't know, for example, the most common causes of death in children that are abused or neglected. So in red here, I have the things that are the most common with physical abuse, which is the beating deaths, which cause abuse of head trauma or blunt abdominal trauma. You also run into firearm deaths and burns and things like that. So there's definitely a connection to trauma, even though we don't take care of pediatric trauma patients in the ORs here. They do come through the ER occasionally. Other things that I didn't know at the time were that in the United States, there are about 600,000 victims of child maltreatment each year. And in 2022, which was the most current year of reporting, there were about 1,990 child abuse-related deaths in the United States. And that number is actually up from where it was in the 1990s. The total number of victims is down, but the number of fatalities has gone up since the 1990s. Now, the way that child maltreatment connects to all of the people that we take care of in our clinics and in the hospital and in the operating room is through adverse childhood experiences. Can I see a show of hands? How many people have heard of adverse childhood experiences? Oh, good. That's more than it used to be. About half of you. So adverse childhood experiences are things that if people experience before the age of 18, increase their risk of a wide variety of health and social and educational and economic problems later in their life. So if someone has experienced physical, emotional, or sexual abuse, neglect, or if they have household dysfunction that includes mental illness, domestic violence in the home, divorce, substance abuse, or having an incarcerated relative. If you have 4 or more of those before the age of 18, you have a much greater risk of developing these problems. And the way that this happens is that if you have the adverse childhood experiences, which is the second green band, you end up with disrupted neurodevelopment because your brain is cycling over and over on practicing being in a very stressed out fight or flight or freeze type state, which alters the way that your brain grows. You end up with social, emotional, and cognitive impairment, adoption of health risky behavior, diseases and disability, social problems, and you have an increased risk of early death. So people that have 4 or more ACEs are more likely than others to die about 20 years prematurely. And the types of behavior and physical and mental health problems that are associated with having 4 or more adverse childhood experiences, some of them are listed here. So you can see here things like lack of physical activity and severe obesity, smoking, alcoholism, drug use, missed work, diabetes, depression, suicide attempts, sexually transmitted infections, heart disease, cancer, stroke, COPD, and broken bones, and also all types of traumatic events or being involved in things like shootings go up if you have these experiences as well. So if you look at this list, you can see here a lot of the population that we deal with that have suicide attempts, or the homeless population you can see in this list as well. So these are the adults that have experienced child maltreatment as a child, or these other problems inside their home. So about 1 in 7 children in the United States experiences abuse or neglect per year, and the total lifetime economic burden of child abuse, this was from 2018, is estimated to be at about $592 billion. So this is a very expensive problem that affects our pediatric and adult populations. And with my emotional experience with that child, what I wanted to focus on was prevention. How do you get ahead of this? How do you prevent this from happening? So the first question is, how do you find at-risk families before a child is harmed? And an important statistic here is that about half of children who die from child abuse and neglect are not known to child welfare at the time of their death. So half of them, nobody has seen them before or reported them to child welfare, so they are just in the wild, and the first time you see them is when they come in with a serious or fatal injury. So I looked first to predictive analytics. And there are 2 types of predictive analytics. You've got person-based and place-based. So person-based predictive analytics would try to figure out, who is this guy right here? Can we predict who this guy is going to be before he attacks this woman? But the problem with person-based predictive analytics is that you can give someone the same 10 characteristics that makes them more likely to have a certain behavior, but it's very hard to predict what an individual is going to do. So you could have all of the high-risk problems and not be someone that's going to go on to rape someone or harm someone. Or you could have few of the risk factors and go on to be a perpetrator of these types of things. So it's difficult to predict who is going to do which particular thing. But you can also look at where certain behaviors are likely to occur. So in this case, what we're looking at here is if we were looking at where would we find children that are exhibiting the behavior of playing, we all know that we would look at a playground. And let me ask you the question, why is that? What are the features of this environment that increase the likelihood that you're going to find a child playing at a playground? You've got the playground equipment, you've got the padding on the ground, you've got a bathroom nearby, maybe you have a parking lot, you have a fence around the playground. All of these things are features of this environment that increase the likelihood that you're going to find a child exhibiting the behavior of playing there. So you can make predictions based on this as well, and this is the basis of the predict part of predict, align, prevent. So what you look at really when you're looking at place-based predictions is in the center here where it says 6717 Chew Avenue. If you were going to place a playground there, you would want to look at the features surrounding that area to see, is this a place where a playground is going to be successful? So you're going to look at things like, are there other tennis courts? Are there places where adults are going to be playing? Are you close to the green dot where it has a bunch of shops where people can go to get something to eat? Are you near a main road, which is the blue dot? And are you in a residential area, which would be represented by the orange dot? So each of these dots represents a feature of the environment that supports the success of a playground in this area. And what you can do statistically is measure the distance between the different dots and how many of those dots exist and how close they are to the thing that you're trying to find, which in this case would be a playground. And you can do the same thing with child maltreatment. So the features of the environment, though, are going to be different. So one thing I want to point out is that when you're doing the feature engineering, or if you're trying to figure out place-based predictive analytics for child maltreatment, you have to be able to put everything on a map, like the picture that I just showed you. So you have to be able to have an address of where the feature of the environment is, just like a residential household or a tennis court, something like that. So I want to take you through what the features of the environment would be, what you would be looking for if you're trying to predict where child maltreatment is likely to occur. So you've got child risk factors for child maltreatment, and that includes just a child below the age of 1 and their regular behavior. Children, the more vulnerable they are, the more likely they are to be abused or neglected. So any newborns or infants during their crying periods or when they're going through their colicky periods, they have an increased risk of experiencing child maltreatment. During developmental milestones like potty training, they are also at an increased risk of child maltreatment, especially if the parent doesn't have knowledge of normal child behavior and development. If you have a child that was born prematurely, or if they have high medical needs, that increases their risk of child maltreatment, and so does having multiples. And if you think about the thing that is common across all of these, is all of these different things make having a child in your life, it makes your life a lot harder, right? And so anything that is going to increase the stress in your life is going to increase the risk of that child being victimized. Then you can look, I wanted to mention that when you're trying to figure out how to put this type of thing on a map, you have to think about where the data comes from. So if you're looking at, how many children are born in a certain area, you're looking at census data. If you're looking at, stages of life, you'd probably also be looking at census data. But if you're looking for children with disabilities or children that were born prematurely, you're going to be looking to hospital data, to insurance data, or even to Health and Human Services data. So to be able to get this information, to put it on a map, you have to work with a lot of different agencies and organizations to be able to do that. Now, if you're looking at perpetrator risk factors, you're looking for young mothers. The data for them is probably going to come through public health if you're looking at teen birth. You're looking at alcohol and drug abuse and domestic violence. This type of data would come from the police. You're going to be looking for poverty data. This would come primarily from census. You're going to be looking at the way that people perceive normal parenting or healthy parenting. Some people, the more authoritarian styles of parenting are going to be more likely to engage in abusive behaviors. And you may be able to get ideas about people's perception of certain types of parenting from nonprofit organizations. Mental illness data is going to come from the healthcare system or health insurance again. Another risk for child maltreatment is having low education, especially if you have babies when you're very young. And so this type of data would come from the Department of Education. And then you're also going to be looking at social isolation as a risk factor. And this information would probably also come from nonprofit organization type surveys. So these are perpetrator risk factors. Then we already talked about adverse childhood experiences. So if you wanted to see in a community where domestic violence or divorce or substance abuse, those types of things were occurring, you look to police data or Health and Human Services data. And if you want to look at the outcomes associated with adverse childhood experiences and child maltreatment, you're going to be looking again to hospital and health insurance data. So the reason that I showed all of that to you is that you want to be able to put on a map the features that are likely to increase the risk of child maltreatment, so things like substance abuse and domestic violence. And to put them on a map, to be able to make map layers, you have to have an address. So you have to put all of those different data points in different layers on a map. And what you end up with at the end is a map like this that is a risk map. So the first time that I did this was in the city of Fort Worth, Texas, so that's what you're looking at here. And the purple areas are the highest risk places for child maltreatment based on our analysis. The pink areas are the areas that are the second highest risk. So this was in 2012, and we were using a system called risk terrain modeling, which was a proprietary for-profit software. But what we got out of it after we looked at the data from the next year at where child maltreatment actually occurred, we were able, the green dots here represent where child maltreatment actually occurred in the following year. So we were able to predict where child maltreatment was likely to occur in the future. And we did this with a guy named Michael Bachman at Texas Christian University. But I really didn't like that the methodology, even though successful, was proprietary and for-profit. Like Laura said, I'm really into open science. And so we worked with a guy out of Penn Design that was also really into open science and developed another methodology, which is now free open source on GitHub that anybody can use to do the same types of predictions. So in this case, this is Richmond, Virginia. This was, I think, the following year or the year after. And the yellow areas are the areas where we predicted child maltreatment would occur in the following year. And the black dots on this are where child maltreatment actually occurred in the following year. I'm going to back up one slide because one other thing that is that we get out of this type of prediction is a list of, in order of importance, of the features of the environment that were the most predictive. So this was from Fort Worth, but what we found is that if you had in one of the little areas a high density of domestic violence, teenage runaways, aggravated assault, murder, gang violence, and drugs, that's the cell or the area on the map where the majority of child maltreatment was going to happen. Now, if you're only looking at crime data, this was pretty consistent across multiple sites. Over time, after I started the nonprofit Predict, Align, Prevent and continued this work in 6 states, we found these things to be true with domestic violence and runaways being at the top the majority of the time. So essentially what we found, without going into more sites, is that if you look at the highest risk places on the maps in these cities, so in this case in the yellow areas, you find more than half of the maltreatment. In Richmond, it was close to 70% of maltreatment occurred in the highest risk places. More than half of the child abuse fatalities, and about a little more than 60% of the children removed into foster care. So what this does is it gives you an opportunity to know exactly where to focus your resources in the following year to prevent these things from happening. But we also wanted to see, based on the idea that there could be too much bias in the data that would be pointing at minority communities and that could just be, we could have certain communities overrepresented in the data where maybe child maltreatment wasn't actually happening. We wanted to correct for that. And so to look at that, we actually used the ACEs outcomes, so the outcomes associated with child maltreatment and adverse childhood experiences, to see if we could predict where child maltreatment would occur based on those things. And we could. So this is rural New Hampshire. And what we found was that if you look at again, at a ranking of the things that occurred around child maltreatment, that what you found was that you had diabetes, lead exposure in children, drug abuse, overdose, sale, and manufacturing, drug abuse during pregnancy, assault and community violence, neonatal abstinence syndrome, urinary tract infections, and asthma or chronic obstructive pulmonary disease. So this is adult and child data included in this. So if you had an area where you had a lot of these things occurring, and this is all hospital data, that is also where child maltreatment is likely to occur. So you can predict it with different types of data depending on what you have. And the takeaway message from the entire predictive part of this is that in about 5% of the total geographic area and about a little bit less than 10% of the population, you're going to have more than half, for the entire community, more than half of child and elder abuse, preventable injury and death, violent crimes, teenage runaways, diabetes complications, neonatal abstinence syndrome, lead poisoning in children, respiratory disorders of children and adults, premature birth, and child psychiatric conditions in just the yellow areas. So if there is an organization that's really trying to make a dent in these types of problems in a community, now you know you need to be focused on this 5% of the population and in this 5% of the geographic area. And just to look at the causes of death, this is Little Rock, Arkansas. In this case, you also have the highest risk places are the little yellow squares. But what we found is that if you look at the 4 types of death, suicide, homicide, accident, and natural causes of death, that the majority of all causes of death occur in the highest risk places, including natural. And the reason for that is the 20-year loss of life, the early death, 20 years earlier than you're supposed to die in these areas. You have more babies being born prematurely and dying in these areas. So not only are you dealing with the accidents, which is going to be, falls and burns and drowning and suffocation and things like that, but you're also going to have the homicides, which is usually firearm related, or, the stabbings and the shootings. The suicide is a little bit more even across the different areas, but you have all of these deaths occurring. And if you look at this on a map like this, here the highest risk places are in blue. This map shows the dots of where all of these different types of deaths occurred. So it's not just child maltreatment that we're seeing in these places. We're seeing the problems that we're trying to prevent across a whole spectrum of issues that are related to social determinants of health and child maltreatment. And what we're talking about are areas that are this small. So here, the red squares are the squares that are the highest risk places. And I want you to think for a minute about what the people in these environments are really experiencing, because they have the majority of the crime, the majority of the poverty, they have their children dying, their elders are dying earlier. That's where the child maltreatment is occurring, it's where the shootings are occurring. So this is in an environment of immense trauma and stress that a very small proportion of the population is experiencing, and that's why we see them in our healthcare systems with a lot of these problems that are difficult to solve, because we try to solve the problems as if they exist alone, as if the diabetes is just a problem of itself and we just need to treat that diabetes, but we need to also think about the environment that this is coming from. And so this came from an elder abuse article, but it talks about the boundaries of resilience theory, because people in this space talk a lot about resilience of people that live in environments like this. But the experiences of vulnerable residents of high crime neighborhoods suggest the existence of a tipping point, or a point beyond which an individual's strength and plasticity can no longer withstand the cascading host of external and compounding stressors. So that's what we're really dealing with in these areas. So now that we know where the problem is, we know exactly which houses, which businesses, we know which streets, we have a very clear map of where the problems are. How do we recruit or engage the people that live in the high-risk areas to participate in programs, services, and education? Anyone here that has tried to work in community outreach knows that this is always a problem. So that's the reason that I started looking into this piece, and we figured out a way that you can use market segmentation to do this. So market segmentation is something that we're all familiar with, even if we don't realize we're familiar with it. It's the way in which companies collect data from all of us and then break us into segments of the population. This graph just shows how the population is broken into, I can't remember how many segments it is now, I think it's about 80 segments, based on income and preferences by a company called Buxton that we've worked with before. So what this really is you have data out there about you that is connected back to the address where you live. So things like what you watch on the news or the magazines that you read, your interests and hobbies, wearables and implantables, anything that has a connection through either your credit card or through some other mechanism back to the address where you live. anything your shopping, your mail ordering, your property and utilities, your finances, insurance products, your email, where you travel, what you give to charity, your cars, the demographics, what you watch on television, YouTube, social media, location, all of this is collected about all of us all the time. And what they do with it is they create profiles of certain households. And if you're looking at it in a way that is place-based, you could look at a census tract, which is about this big. And you can look at all of the group of houses together and start to break it down by the zip code +4 into even smaller groupings. And this is how they look at all of our interests and data and determine what about us is similar based on where we live. So for example, if you live in the blue dot house here, you're likely to be a 45 to 54-year-old college graduate with 2 children that are 13 and 15. You like to watch Law and Order, you dine out 3 times a month, you lease your vehicles, and you shop at Sam's Club. Now, I'm not saying this isn't creepy, but this is the data that they use to sell us everything that we buy. And there are companies that have this information. And so my thought was, if the information like this exists to sell us a computer or a new phone or whatever it is that we're interested in, why can't we use the same type of information to sell prevention to people that are living in these high-risk communities? So what we did is we took the addresses from inside the red squares here and fed them through a market segmentation generator with one of these companies. And what we learned, this was in Little Rock in particular, it's different in every city we've modeled, but you learn things about the people. So you learn that they're very low income, that they may be high school graduates, that you have single females, that they rent, they listen to the radio, they are unlikely to have dental insurance, for example. They like to rent videos from convenience stores and they shop at the Dollar General. This is just an example. And so what you can do with that is you can figure out how to partner with dentists to provide discounted dental services, for example. You can promote job training and low-cost financial planning. You can recruit people from the lower risk areas to do that. You can educate at Walmart pharmacy services because that's where people are. Or you can offer promotions to incentivize behaviors, like, for example, using Redbox coupons to get people to come to a particular type of training. So there's ways that you can use the consumer analytics data to actually engage the people where they are and doing the things that they're doing, like which they're on radio and television, in this case in Little Rock, Arkansas, but in other places they're going to be on YouTube all the time. So it's going to help you to figure out where to put your marketing. One example of how we use this in Oregon was adoption agencies completely changed the way they were marketing to likely parents based on, and foster care agencies based on how the previous foster families engaged with the media. So there are ways that you can, and they increased the number of families that they recruited by 10% every month until they met their goal. So this is a way that you can really improve your marketing depending on what message you're trying to get out there. So at this point, what we know, if we're trying to prevent child maltreatment, is we know exactly where we need to be focusing our efforts. We have an idea based on the ranking of the risk features, what we need to be focusing on, and we know who we're trying to reach based on market segmentation. This is really all the information you should need to be able to mount a successful prevention program. At least that's what I thought. So then we got into the align phase of this, the predict, align, prevent. And what we've done in all of these places is we tried to get everybody together to get on the same page towards the same prevention goals using collective impact initiatives, if anyone has ever heard that term. That's the term that people use. And so the idea was to standardize across all of these different agencies, to work in the same direction, and get everybody together and really have a collaborative effort where we're using the resources that were already present in the community in the most effective way possible. And I thought what would happen once you got all of these groups of people together, which we did, and explained to them how all of their problems were connected by adverse childhood experiences, connected by child maltreatment, and why we needed to be working on these particular things, I thought that we would all kind of naturally, out of this maze of services and problems, form, a straight line to prevention, but it failed. It failed over and over again to be able to achieve the kind of large-scale prevention that I was shooting for. We did achieve smaller programs that did amazing things for infant mortality reduction, or helping with lead poisoning in children, or physical abuse reduction, but not the overall decreasing child maltreatment at a population scale over a period of 2 to 5 years, which is what I was going for. And what I realized was that all of these different organizations that harbor the data that you need to be able to do this type of analysis and work, they don't share data with each other. They don't really work together. They don't really see how they connect, even if they do know about ACEs. And the issue is that each one of them has the thing that they're focused on, right? So child and adult protective services, they're mostly focused on the treatment of whatever the problem is. So, investigating the issue and then providing services for that. And prevention is just this tiny little offshoot that they do. They don't really share data with public health, believe it or not, they really don't. And public health is focused on, whatever their issue is. Let's say it's sexually transmitted infection prevention. They're focused on that, and prevention is a tiny little offshoot. And so each one of the agencies is like this. And it's not their fault that it's like this, because the treatment of whatever the problem is what they're tasked with doing. And so what I really ultimately came to realize in trying to get all of these people to work together is that no one is really responsible for prevention. Not really. Not of the adverse childhood experiences as a whole, if you look at where it all occurs in space and how it all occurs together. And the types of treatments that we're doing, if you look at adverse childhood experiences, which is at the top of this tree, or if you look at community adverse experiences, which is at the root of this tree, we're trying to treat things once they're already in fruition, once they're already a problem. We're not trying to get to the root cause. And so I almost gave up. I came really close to giving up, because how do you overcome an issue like this where the system itself is designed to not be focused on prevention, to not work together? How do you get around that? And then I started thinking about it like this. So we have these high-risk places where all of the data and all of the problems occur. Above that, you have city governments, county governments that have they're the ones that extract the data and the ones that hold the most granular data, the most important things that we need to be able to figure out where the people need help. That information then goes up to the state agencies, that then goes up to the federal government that has all of the money. And the foundations, I would say, are in that area as well. So the way I think about this now is that the data really belongs to the city or the county, and it gets smaller as it goes up toward the federal government. But the money, and of course the high-risk places don't have any of the data, because no one shares the data that's relevant to the community with the community. And the money is all with the federal government and kind of trickles down. And the community also doesn't get any of the money, because all of the money goes to these agencies that are in the middle. So we've got these high-risk places where the people are actually experiencing all of these terrible problems that don't have any of the money or any of the data. So how do we get the money and the data to the high-risk places? And so what I think that we need to do at this point, if we want to prevent child abuse and neglect, is to shift the focus of aligning services to a governor's office. Now, the reason that I think a governor's office is the place for this is that the governor is the only entity that can actually get the data from all of the different places to be able to do the analysis. And I think that we should do all of the analysis that I showed you guys, the place-based risk modeling and prevention strategy there, have outcomes that we're tracking from there, and also centralize all of the funding for prevention programs in that agency so that we can get the data and the money to the community itself. And the types of prevention that we need to be working on are things that will address the child risk factors and the perpetrator risk factors and the adverse childhood experiences. So I've come up with a list of 10 programs that I think would do this. Now, I want to point out that the focus would be to get these services to all of the people that would be eligible inside the highest risk areas, and it would be entirely voluntary. So people would be able to sign up for these things if they wanted to, but it would not be absolutely required, obviously. The first is nurse-family partnership. I'm just going to go through a couple of these, but the things that we know nurse-family partnership addresses are child abuse and neglect, pediatric chronic illness, emotional and behavioral difficulties. You guys see the list. Cure Violence is a program that treats violence like a communicable disease and seeks to stop the spread of violence from person to person. They've had incredible results in cities like Baltimore in reducing the number of shooting deaths by like 86% in the place where they've focused their treatment. This is a way to address domestic violence, social isolation if you're reducing the violence in the community, reducing incarceration if you have fewer violent incidents. Generation 1 and 2 crime prevention through environmental design. This is a program that looks at how you increase risk just based on the way that your environment is designed. So in this case, on the left-hand side, you see a house that's overgrown. So if you have a decreased line of sight or vision to a house, you're going to have a higher likelihood of having a robbery there because people can get away with it. So if you trim the bushes back, you can reduce the number of crimes occurring in that place just by doing that thing. And you can do this with all types of environments, with convenience stores that are usually attractors for things like aggravated assault, for example. So there are lots of different ways that you can engineer the environment to make it safer. Universal basic income, especially for women with small children that are living in extreme poverty in these high-risk environments, would very likely be helpful. This type of program is being piloted in different places across the country with good success. Free college education for people in high-risk places can help to decrease single parenthood because people are more likely to get married and stay married if they had to have an education. Girls are less likely to have children at a young age if they have a higher education. Of course, this is going to reduce poverty, and it also reduces things like unemployment. Free childcare would be one way to prevent child abuse and neglect if the mom isn't leaving the baby with a boyfriend, for example, if they have a place to take the child. And of course, Early Head Start is one of the best type of childcare programs that's out there. Pregnancy prevention, obviously, if you don't have unwanted children, and also very young mothers, your risk factors for child maltreatment will be reduced. Mobile medical clinics, taking mental health care and prenatal care, infant care, child care to the community to make it very convenient, especially in places where transportation is not reliable, has been effective. And doing things like crisis intervention teams with the police so that you have someone showing up and recommending services, psychiatric care, drug treatment care instead of incarceration is something that would be helpful. And then, if all of these things are being implemented in these very small areas, we should see a reduction in these types of things over time. So of course what we're looking for is a decrease in substantiated child maltreatment, but we also want to see a decrease in removals from the home for children, a decrease in preventable deaths for adult and children, traumatic deaths included, and also all of these other things. Now, these types of issues can be measured. You can measure, how many gunshot wounds did a hospital see in a 12-month period. That's something that you can look at, and you can also measure the cost of that. So the $547 billion cost that we talked about before, often people will look at things like, lifelong productivity and the loss of productivity as part of that number, but you could also look at very direct costs to a community like this to see, are the interventions that are being offered to this community actually reducing things that the community itself is paying for. And so over time, I think that all of these things would be reduced. This is a very new idea. I was very grateful again to Laura for letting me talk with you guys about this, and I look forward to hearing some comments and questions. But at this point, we're looking for a volunteer city, a governor, and funding. So very early in the process. And this is all of my contact information. I didn't bring any cards with me. So if anybody wants to talk with me, this is how to get in contact. So I want to hear, first of all, what you guys think about the process, the idea, and if you have any suggestions. Yes, sir.
As a military veteran, I didn't see
If we were ever, we haven't modeled a military base. I don't know if we would even be able to do that, but the domestic violence and the suicide attempts, things like that would be captured in the modeling, but I agree with you, yes, that would be, you probably, in an area where you have a lot of veterans, you probably would have increased risk, as you can see in increased rates of child abuse in some of those areas too. Okay. So I'll give you some examples. In Fort Worth, Texas, we were able to use that information to address another major problem that they had that spans infant mortality, which spans both maternal morbidity, just infant wellness and child maltreatment, because the most common cause of death in infants is suffocation in an unsafe sleeping environment. So we were able to use that information to focus attention on particular churches and community centers that were in the highest risk areas to provide things like education and pack and plays, and we went and changed all the policies in the hospitals so that the nurses were modeling safe sleep behaviors, that sort of thing. And we did see a reduction in suffocation-related infant mortality in the city over a couple of years. In New Hampshire, we found in Manchester, New Hampshire, we found that 98% of the child lead poisoning was occurring in like 2 apartment complexes. And the lead abatement people in the state had no idea. Because I know that this seems, when you look at this, you're like, well, doesn't everybody already do this? Like, don't we already know on maps where all this stuff is? No, we really don't. And so they started, letting people know, hey, you're at risk for lead poisoning here, and giving out water, things like that. And we've done, I was talking about the recruitment of foster families in Oregon. We worked on that. And there have been other smaller projects, but I could never get everyone to coalesce around violence prevention, which I think is probably the most important aspect that comes up in the predictive modeling, with violence and domestic violence being one of the main contributors. There needs to be a big population-based focus on violence prevention that changes social norms around violence, in parenting, but also in other types of relationships, and just society's acceptance of violence as normal, to begin to reduce violence. And but talking a group of people that are working on vastly different things into focusing their money and their efforts on that is very difficult, because if, let's say you're talking about a nonprofit that's focused on poverty prevention, their grant funding or the money that they're getting is tied to that particular outcome. So they can't really be flexible with what the data says to be able to shift over toward that thing, which is why I think that prevention needs to be something that is centralized and accountable. Some agency or group needs to be responsible for prevention, because if there isn't something like that, there is no one that's responsible for prevention. So we've done some amazing work that has helped a lot of kids, but we have not achieved the moving the needle on reducing child maltreatment rates in a population the way that I want to. Yes, ma'am. So the agencies are usually part of the analysis process because they have to provide the data. So every agency has a different set of data. So juvenile justice has some of it, and education has some of it, and healthcare has some of it, Health and Human Services. So depending on where you are, like in New Hampshire, all of that is under one umbrella. And so when you release the analysis to them and explain it to them, they're all at the table and then can start making plans based on what the data shows. When it comes to the communities themselves, what I've done before is literally just go to the community and be like, look at this. And it's been very interesting with churches, for example, in Little Rock. I remember one experience I had where I called a church and I said, you guys are smack dab in the middle of a high-risk area for child maltreatment. And they said to me, No, we don't have that problem here. That problem is on the other side of the freeway. And that's something that has been true in every city that we've modeled, is that you have the high-risk place that everyone thinks is the only place where there's problems in the entire city. But what our modeling always shows is that there are problems there, but the same problems exist all across the city in smaller areas. And so engaging people and getting them to even recognize that there's a problem is one thing. The next thing that I will mention is, I said at some point that the communities themselves have no data. The way that I know that is that people will say, well, you have to go to the community and get them to tell you what they need. But I went to the community and I asked them, in so many words, what is killing your children? And the way that I asked that is, how do you prevent the deaths of children in your area? And no one, not the community themselves, not the people the service workers that worked in those communities, they had no idea that suffocation was the leading cause of infant death in those areas. And if you don't know what is killing your children or how to prevent it, then you're not going to be able to come up with a plan to actually prevent that thing. And so one of the most important aspects is taking the data back to the community itself, and not just the people that work in the community, but to the people that live in the community. Let them know what's happening so that they can formulate plans for prevention amongst themselves. So it's a lot of communication. Yes, sir. So I have talked about this all over the world for the last 10 years in front of giant tech crowds of 10,000 people, or very small community meetings. I mean, I've talked with a lot of different people, including people from the government. And the CDC does have a project working on social determinants of health, but even an agency like the CDC doesn't have all of the different data points. And so one thing that's unique about what we have done here is everything that we work with when it comes to the analysis is at a point level. So we're looking at address level data to look at the associations between all of these different factors and child maltreatment in particular. And that level of data is something that's very hard to obtain. And like in some places, you'll call up the police department and say, hey, I need you to send me the addresses of all of the domestic violence arrests that you had in the last year. And some people, I mean, obviously you have an agreement in place and data security and all of that is already in place. And some people will just be like, oh, sure, and they'll send you an email 5 minutes later. And another group will start out with, that's unconstitutional, we can't do that. And so you really have a lot of different ideas on what data can be accessed and how it can be used. And I think that the discussion around that, especially if you include the potential for bias in a lot of this data, because it does include some crime data, juvenile justice data, people will get kind of edgy with that. And so they don't want to get the address level data. That's something I've been working on with the ACLU. Yes, ma'am. So I spoke with, I don't know, about a year ago, 2 years ago, with some people from the governor's office. But at that time, I had the up to the analysis, up to the align part, but I wasn't recommending programs yet. So the thing that's different in this new iteration that I'm here talking about today is that I think that the next time I go into a community with this work, I want to go in with the funding for the programs already intact, so that it's not something that you're expecting the service sector really to come up with, which is, I think, going to be a different proposal to a governor's office than going in with just the analysis phase would be. That's my hope. Thank you so much for listening to this. I know it's very different. I appreciate your time today. Thank you.
I lost my microphone, or I would have said words sooner. As you were talking, Sadie and I were talking about our injury prevention and outreach work that we do through trauma. And I think that there are so many things that we can learn from the work that you're doing, Dr. Daly. Next is Dr. Liz Lysette. Dr. Lysette is a board-certified gerontologist and the Geriatric Trauma Medical Director and the chair of the Department of Surgery, not surgery, that's me, Department of Geriatrics here at Boulder Community Health. Yeah, she said she's moving up fast. Dr. Lysette is passionate about providing evidence-based and patient-centric care and embraces a multidisciplinary approach to the care of seniors and their families. Dr. Lysette is originally from Vermont, and one time she saw Bernie Sanders in the airport.
Good afternoon. I'm just going to set a timer because I'm an internist at heart. I can talk all day. All right. I have 10 minutes today to give you, 10 minutes today to give you a snapshot of the things that are important in geriatrics. I'm going to give you one little clinical nugget. I'll do a little song and dance, and then we'll wrap up with some questions. So Last year, I was here for about 40 minutes, and we talked about the most common types of geriatric trauma. So just to start at the top of the funnel, as Ben Kyden mentioned earlier, 56% of our trauma patients are geriatric. 90% of that is fall from standing height. It's like the unsexiest kind of trauma. And a lot of that is osteoporotic fractures, so most of it. So I'm gonna focus a little bit on osteoporosis for about 5 minutes, and then we'll talk about geriatrics. So this slide is to remind us of how morbid and mortal and expensive this stuff is. So the National Osteoporosis Foundation suggests there's about 2 million osteoporotic fractures per year. That's a cost of about $26 billion a year. That's more than breast cancer. That is more than MIs. So this is a huge problem, and we all have a responsibility to work towards it. There's a lot of repetitive falls and fractures. So from Framingham, which was a longitudinal study, we know that a lot of recurrent offenders happen in the fracture realm. For those of us, I don't know how many are on the front lines, when we see a patient with a fall and a fracture, it is almost always osteoporosis. And the reason I'm hammering on that is because if we don't call it what it is, then we miss this opportunity to identify a problem and treat it, okay? So if you are the EMS that gets called to my house in January, this purple-haired hippie's on the ground, she fell coming out of the bathroom. This is my mother, she broke her hip. We talked about her hip fracture, her hip fracture, her hip fracture. We never said, you have osteoporosis. So this is a little catchy tune that some of us might have heard of. Does anyone know what NKOTB stands for? Thank you. I am 40, this is New Kids on the Block, and they have this catchy tune, what you gonna do about it, okay? So, give credit where credit is due. So I just wanna talk about the different places that care happens. So in the primary care setting, there are so many opportunities to identify and prevent problems. So it is our wheelhouse to think about how do we screen patients for fall risk. So this is something that is now done automatically on patients coming in. How do we review their medications and their medication side effects and risk profiles? Because falls so often are caused by medications and the things that we do to help people, okay? This might be thinking about exercise and prevention and counseling, thinking about healthy lifestyles. So there's a huge burden on primary care as the preventative aspect of things. I already mentioned when you're the frontline EMS people and you get called to those houses, my request of those people is maybe right before you push the fentanyl, you say, hey, that med list is 2 pages long. Maybe when all this is sorted, you could talk to your primary care doctor about limiting your drugs. If we all kind of comment on these things and think about it as a system, we all have a chance to help out. There's a data point for women. Most of these fractures are in women. Less than 1/4 of the patients that show up with an osteoporotic fracture get a DEXA scan or a treatment. And when I talked about $26 billion a year, that seems like a huge lost opportunity. So when I'm thinking about how do we as a system look at this stuff, identifying the problem and treating it, okay? Let me go, here we go. So if we think about the people in the hospital, this is the trauma team, this is orthopedics, this is physical therapy, nursing, social workers that are working on discharge. It really is the entire system's responsibility to call it what it is and follow it up, right? So we've put some little things in checkboxes, like checking a vitamin D level, which is helpful as a baseline to make sure that someone else can treat this later. I sort of jokingly talk about counsel about limiting joy. That means less alcohol, that means no smoking, that means less caffeine. There's a sweet spot about exercise, because we really want more exercise for people. But the funny thing is, there's a higher risk of repeat fractures in people that are highly active. So that seems not fair. Okay, so we need to think about the lifestyle stuff. Hopefully primary care is addressing it, but so should the hospital. When these patients come in for their 2-week follow-up or their physical therapy appointment, perhaps we should say, hey, did you know you have osteoporosis? Have you seen anyone for it? And there's a little plug down here on the bottom. There's so many people that can take care of osteoporosis. We just have to make sure it happens. We all do. This can be primary care, endocrine, rheumatology, geriatrics, because that's a new thing now, we'll talk. And then even orthopedics has a metabolic bone clinic. So it's all over the place. It's everyone's responsibility. I actually want to skip one slide just for funsies. I promise we'll come back to this. Those of us that are either of retirement age or thinking ahead about retirement, I want to do a show of hands. Does anyone worry about getting murdered? Oh, super, a couple. How about getting killed in a car accident? How about hip fractures? All right, okay. One more weird question. Has anyone heard of osteonecrosis of the jaw? A few. Okay, so here's why. This is the most fascinating thing I can come up with. This is a comparative diagram of the things that actually happen to people and how tiny osteonecrosis of the jaw is. And the reason this super obscure thing is on my slides is in primary care or anyone that has to treat osteoporosis, every single patient is so worried about having that side effect of the drugs. Which, where did they hear about this stuff? You're more likely to get struck by lightning and murdered, okay? So let me go back a second to treating osteoporosis. So if everyone in the system says osteoporosis is a problem and you should get treatment, the reason is because the return on investment is about 1 year. So if I put someone on Fosamax, it only takes about a year to start seeing benefit in fracture reduction, and it's about a 50% reduction in fractures. Not falls, but fractures. And that's huge because that might be the difference between independence or nursing home or assisted living. And when you hear that $26 billion, all those costs start to add up. Okay, so if anyone is worried about osteonecrosis of the jaw, stop and take your drugs, okay? Calcium and vitamin D are always important. I'll skip over the details, but those are things that we should think about. Here I am, like being pedantic to people that take 2 pages of medicines. Sometimes those medicines are calcium and vitamin D, so I have to be a little careful about reduction in meds. DEXA scans won't change whether we tell someone to take medicine or not. We still want them to get treated, but it kind of starts that conversation about ongoing care and management. The medications I've already talked about, it's a really important thing to talk about and act on because it's so preventable. It's not everyone, just like seatbelts don't prevent all death and demise from car accidents, but we sure as hell wear it every time, don't we? At least we better. It's about the same amount of reduction in harm if we wear a seatbelt as if we take a medicine for osteoporosis, okay? All right, back to my favorite slide ever. So I have 3 minutes left, and I want to give you a little bit of a snapshot on what geriatrics is within BCH. So I'm really happy to say we are officially launching a geriatric department. This started in February, and what that means is we are trying to build a little more resource for primary care and geriatrics. And that can be both consults, So let's say a patient that's been on the trauma service a few times, they've had 5 surgeries, their quality of life is diminishing, they're not quite sure what they want, but they need someone to have that talk with them. You could send that patient to us for a consult to think about what life looks like for them and where it's going. You could have them come to us for primary care. So if I have an old, frail person with geriatric syndromes, like high fall risk and dementia and too many drugs, medicines, that would be another person that we could see. And so we're trying to make ourselves as a resource for others so that we can get these patients the best care that they can have, and also help reduce some of the long-term bad outcomes that are expensive and difficult for all of us to take care of. Right now, I'm the medical director of myself and 1 nurse practitioner, but we have another doctor starting in July, and we have a 3rd physician starting, we hope, in the fall. He hasn't quite signed off on the line yet. So it's just to say this department is growing and it's important. It is not that everyone that is old, meaning older than 65, needs a geriatrician. They don't. But it is that when things get really complicated and it's not something that primary care is doing a great job handling, or you just need those complicated conversations where lifespan intersects with health span, those are the kinds of things that you might call us for, okay? I'm gonna stop there. I'll take questions if anyone has them. 10:21, sorry. Thank you, guys.
Okay, next up we have Dr. Barry Platnick. Dr. Platnick is a board-certified general surgeon, surgical critical care, surgical intensivist, and palliative care medicine physician. Dr. Platnick is the director of the surgical trauma ICU at Denver Health, where he puts his skills as a trauma surgeon and a palliative care doctor to work, taking a whole-body approach to the care of the injured patient. Dr. Platnick is also a Deadhead and has attended over 100 Grateful Dead concerts with Jerry Garcia.
All right, well, thank you for that. And you can infer from that that depending on the policy that you have at the hospital, I actually qualify as a geriatric trauma patient if I get injured. And I also want to say that, you know, when I'm older, if I'm not allowed to drink, smoke, or have caffeine, that is antithetical to my goals of care. Okay, so let's just be clear about that. So I'm going to see how this works. The title is Primary Palliative Care for Surgical Intensivists, and I think it said Pain and Palliative Care on the schedule, which sort of sounded like Pride and Prejudice, and I didn't really know what to do with that. So where you see surgical intensivist, insert yourself. Think of yourself, because I think what I'm going to talk about pertains to being a good provider, clinician, bedside practitioner. So first of all, who's here? By show of hands, pre-hospital? Great. Nursing? Providers? RT, recreational therapy, music therapy, physical therapy. Yeah, great. Okay, so another thing I want to do just by show of hands, because this is my public service piece, how many people here have a designated medical durable power of attorney written down on paper for everyone to see? Okay. And how many people here don't have that, but they have somebody who would make medical decisions for them if they lacked capacity? For all of you who don't have it written down here in the state of Colorado, anybody can come in and be considered an interested party and take place in the identification or becoming your proxy. So in the state of Colorado, there's no hierarchy. It's not like next of kin or anything like that. So if you don't have somebody written down, that disenfranchised sibling in California might just come back and either pull the plug or leave the plug in, depending on who you are. Disclosures, I have no financial disclosures. I am a trauma surgeon and have been for decades, and I'm also a palliative medicine physician. And so the reason I say that is because a lot of what I'm going to talk about is, for lack of a better term, touchy-feely, But the truth is, in the ICU, we are trying to save lives. And that's what I do. I take care of people who've been shot, I take car wrecks, all that. We are trying to save lives. And what I'm hoping to impress upon you is that that is not mutually exclusive from what I'm talking about today. Man, do I sound really loud to you? Okay, because I sound loud to me, which is unusual. I usually sound loud to you. Okay, so here's the objectives. I'm going to talk about primary palliative care, and hopefully you'll understand what I mean by that when we're done. I also want to talk about when is specialist palliative care beneficial, because we'll talk about the fact that there's a difference, and I think of palliative care as a skill we all have, and yet sometimes we have to call consultants for some of the work we're doing. The concept of total pain, which is not new, but maybe new to some of you, is something that I want to spend some time on. I also want to talk about the interdisciplinary team, and with such a large contingent of nursing, I'm hoping that a lot of you are already familiar with that. And I'm hoping that by the end of this, you'll agree that palliative care is fundamental, and it's fundamental in the treatment of trauma patients, critically injured patients, and all patients. The other disclosure I have to make is that I can't see the notes for my slides, and I tend to get very tangential, so I'm going to try to stay on track here. This is my dog Potter, okay? So insert in your mind anybody or any pet you love dearly, and imagine them imagining a beautiful vacation, and they're going to go on this lovely vacation, and they go to a travel agent, and that travel agent goes ahead and sets up the vacation, the destination, the itinerary, and everything. But they don't ask them where they want to go, what they want to eat, who they want to be with, what language they want spoken. Suddenly, that vacation is not so much fun, and they're afraid, and they're nervous, and they're anxious, and they're scared. Well, this is kind of what I think of for our patients who come in injured or critically ill in our ICU. This is what we do to them. I'm not saying that they come in expecting, the vacation in the tropics, but I'm pretty sure this is not what they're thinking about, okay? They're hoping to come in and be treated kindly and lovely and tenderly, and we tie them down and we drug them and we do what we do, right? And we do that in the interest of saving their lives, and a lot of what we do needs to be done, and I want to come back to that over and over again, that we are here to save people's lives. I like to go to this statement because I'm a surgeon, and the American College of Surgeons, nearly 20 years ago, called out palliative care by creating a statement of principles. And the reason I do this is because palliative care is not just an internal medicine or family medicine kind of thing. It is everybody's job. What I love about this is, we go through dignity on autonomy and the right to choose and communication, and these are the basic principles that we kind of embody in taking care of the whole patient. Psychological, social, spiritual issues. Two of the things that I really appreciate is the physician or provider's responsibility to discourage non-beneficial treatments. And I think for us in the ICU, especially when we're taking care of patients that are being taken care of by a number of different specialties, it's important for us who have the understanding, hopefully, of the goals of care of the patient to recognize whether treatments are goal concordant or not. And so the ability to encourage or discourage non-beneficial treatments is important. And lastly, I like number 10, because only the American College of Surgeons could say to surgeons, play nicely in the sandbox with others. And it's true. I think one of our jobs is to support that interprofessional communication. Come on, wrong button. So, what is palliative care? Some of you know, some of you think you know, some of you don't know. Is it the death squad? Is it just the morphine team? Is it just who we call when we want to get a DNR? I think many people think that's the case. Is it who we call to do nothing once we've done everything? A lot of people resonates with people. Is it all of the above? Well, no, it's obviously none of the above, right? Or I would be taken down by the palliative colleagues sitting in the chair in front of me. So I like this. Yeah, this is not what we do. It may be part of what we do, but it's not what we do. Okay, what palliative care is not, and let's start there. It's not a death sentence or the death squad. And in fact, when you consult palliative care for patients in the ICU, it either has no change on mortality or it actually decreases mortality. And I think that's one of the misconceptions. You call us in and we're gonna smoke your patients and that's gonna be the end of it. It's not just comfort care. It's not end-of-life care necessarily. And we're not the addiction medicine team, and I want to be clear about that. A lot of times people think palliative care, we've got somebody who's got a drug problem, let's call them in. We may be helpful in that setting, and we'll talk about that possibility, but that's not really the role of a palliative clinician. It's most definitely not mutually exclusive with life-prolonging care, okay? We deliver them side by side, and that's a take-home message from this, is that early palliative care consultation and aggressive treatment go together, and there's no reason they shouldn't. It's not just getting the DNR or the proxy or the POA, although it may be. For those of you who don't have an MD-POA and find yourself lacking capacity in our ICU, palliative care may help fend off that antagonistic sibling. And it's not the sequel to failed care, and I want to stress that as a second point. I think it's a common misconception that we call palliative at the end. The earlier we can get palliative care involved, the better the team gets to know the patient, the family, and the more help we can be. So what is palliative care? And I highlighted, obviously I put in yellow what I want you to remember. It's an approach to suffering. It's a multi-dimensional approach to suffering, not just pain as we think of it, and we'll talk about total pain, but suffering as a whole. It's an interdisciplinary field, and it uses multiple specialties, and we'll talk a little bit more about what I mean by interdisciplinary. We also think of the disease burden and the burden of treatment, and that's part of how we help patients understand what is goal concordant for them. In other words, what they may or may not want, and help them achieve that. And it can be delivered along life-prolonging care. For clarity, okay, because I think hospice and palliative care get mixed up a lot. Palliative care is a form, hospice is a form of palliative care. So the idea is still the same, the alleviation of suffering, decrease the burden of disease, but it's delivered with the intent of solely alleviating that suffering and without the intent for life-prolonging care. It's delivered typically to people who have 6 months or predicted prognosis of 6 months or less. It can be delivered in the home, it can be delivered in some hospitals, it can be delivered also in inpatient settings. Hospice care, comfort care, withdrawal of life-sustaining treatment, those are not doing nothing, and in fact, in many cases, that's doing more for the patient. So what is primary palliative care? What do I mean by that? Primary palliative care is what everybody here should be able to do a little of, okay? It should be able to be delivered by the intensivist, the trauma surgeon, the APP on the service, pretty much everybody who's involved in taking care of the patient. We should be able to have the basic goals of care conversations, right? That's not something that necessarily needs to be relegated to the specialist. We should be able to coordinate and conduct some family meetings. Identification of surrogate decision makers, again, the antagonistic sibling. Identification and understanding of advanced directives. It's important for us to know what they are, what they mean, what the value is of them, because that is the patient's wishes when the patient had capacity. It's the provision of appropriate interdisciplinary services. In other words, we don't necessarily provide the service, but we have it, we know where to get it for the person, and I'll show you more about that here in a little bit. And then symptom management. So I think all of us do some form of symptom management to varying degrees with different levels of expertise, from reassurance, which is a form of symptom management, to ketamine infusions. Wrong button. If I flash you in the eye with this laser beam, I'm sorry. So not to give short shrift to physical symptoms, I just want to point this out. This is the symptom burden of chronic critical illness. So for people who've been in the ICU for 7 days or more, you can see that about 2/3 of them experience and report unsatisfactory treatment of their symptoms, ranging from dry mouth to dyspnea. And in fact, nearly 2/3 of patients who are on a ventilator, okay, being rested on the ventilator. So why do we put them on the ventilator? We put them on the ventilator because they can't breathe. What do they feel when they're on a ventilator? They feel like they can't breathe. So clearly there's a lot of work for us to do, and sometimes the symptom burden is such that specialist palliative care or specialist symptom management, maybe it's anesthesia pain service that is involved in bringing in the people necessary to treat the symptoms. So I don't want to give short shrift to the symptom burden, the physical symptom burden. And in fact, for your patient in the ICU, it may be the nausea that's their most burdensome symptom. Okay? So when I ask what suffering means to you, what comes to mind? And you can either, if you're feeling bold, you can shout it out, or you can just have it come to mind. So no talk would be complete without a word cloud. Yes? Yeah, very much so. So again, that would be gold discordant. And we'll talk about that here in a little bit, but that can be a great source of burden or discomfort for the patient, the family, the treatment team, everybody, okay? The comment was one thing that could be suffering is when the family wants to keep the patient alive and the patient doesn't want to be kept alive. So you can see here when you look at this word cloud, suffering is a very multidimensional phenomenon, right? It's not just, stubbing your toe hurts, but you stub your toe and then you're angry at yourself and you wish you'd fixed the thing and you can't believe you did that and you tripped over your dog, whatever it is, it involves psychological, social, spiritual domains, and it is kind of where everything comes together for us. And again, the surgeons finally got it together and they put out a statement that the control of suffering is of equal importance to the cure of disease in some cases. And so I think that that's important for us all to recognize as we start, dragging people through things they may not want. So, which of these do you think might contribute to total pain? And I'm going to be embarrassed because one of them is, you'll see, it speaks to the... So, obviously, total big burn, total pain. Severe brain injury contributes to total pain. Rule out neck fash and ground level fall consults all night, so that's fine. For us as trauma surgeons, that's not what we live for. We take care of them and we do it well, but for us as trauma surgeons, the big bad is kind of what we like. Updates to the EMR, everybody, if there's total pain for anyone, that's it. You hear there's going to be an update tomorrow, you come in, it's got new colors and everything's in a different place. None of the above? Actually, no, all of the above, right? Depending on who you are, all of this contributes to the concept of total pain. This is not a new concept. It was developed really early on in the sort of creation of the concept of palliative care. And it's the intersection of the physical, psychological, spiritual, and social domains. The physical domain, I think we're all pretty comfortable with. We recognize, right, that the injury or the disease causes physical pain. We may be a little less recognizing that the interventions cause physical pain, and it doesn't have to be that we're doing surgery that causes physical pain. It just may be rolling the patient. It may be cleaning the patient. It may be putting an IV into the patient, right? The comorbid conditions that they come in with cause physical discomfort, certainly, whether it's congestive heart failure, COPD, rheumatoid arthritis. These cause physical pain. They may have dyspnea, nausea, vomiting, etc. And so this is the physical domain. And we treat this and we try to treat it well. Sometimes we don't understand why our treatments are not working. And that's kind of where total pain happens. The social pain, think about the financial concerns of this person who's in your ICU or critically injured or ill, the burden of the hospital bill, they're not able to work, they can't make their house payments, loss of role or social status. It's going to be a little bit difficult to get right back up on the slopes if you've lost a leg, for instance. It's going to be difficult maybe to be a public speaker if you're disfigured. You may lose your job, they may have lost their job, or they may be looking at losing their job. Worried about the family welfare for that person who's dying. What's going to happen to my family? How are they going to be taken care of? And legal concerns, right? Do I have my affairs in order? So now you've got somebody who's suffering physical pain, who's worrying, okay? And we've started to kind of, as you can see, they're starting to overlap. That same person who's having physical pain, who's worrying, who's losing potentially their job and doesn't know who's going to take care of their family, has the basic anxiety of what's going to happen next. Their fear of suffering, right? Maybe they're coming in to do the wound vac dressing change again, and the last time was just so much pain and they didn't treat my pain well, and so I'm worried about that. Underlying depression, I imagine that many of our patients have some level of situational depression associated with their injuries. Previous experience with trauma or illness. Now, I don't know about here in Boulder, but I can tell you in Denver, at Denver Health, a lot of our patients have been there before. You know, trauma is a chronic disease with a high recidivism rate. Loss, as we spoke to before, and then again, depending on what happens, you know, guilt, shame, and denial, right? A lot of the patients who come in for trauma especially, they may have been complicit in that trauma. It may be alcohol related, it may be texting related, maybe it's lung cancer and they've got the association of having smoked, alcoholic liver disease, and they're just trying to cope. So we've got a patient with severe illness and injury who's suffering massive physical pain, who's looking at losing their job and no one's going to take care of their family, and they fear of the person coming in and doing more to them, having had this before, and we're freaking out a little bit about the fact that they did this to themselves. And now there's a spiritual component as well, and it doesn't necessarily mean religious, right? What I mean by spiritual is simply that. It's that aspect that can be somewhat intangible, that sort of describes how we make meaning out of our existence. And that anger may be at the universe or at God, you know, however we might express that. Maybe if it is religious, there's a loss of faith. That struggle to find meaning, like how could this have possibly happened to me? You know, fear of the unknown. I'm facing death. I'm facing paralysis. And the fear of divine repercussion, which is not uncommon for people of faith, is that there may be, especially in the afterlife, there may be some repercussions, or even in this life, there may be repercussions for the actions that they've taken. And that simple loss of dignity. So again, when we start working with people who are who are suffering, and we are treating their pain, simply, you know, going in and upping the dose of Dilaudid may not be the right answer. And sometimes we have to spend a little time with them to figure out why is it that the medications aren't working? What is it that they need? And you can see as I talk about this is not just me going in and taking care of this patient. It's not just you going and taking care of this patient. It's us taking care of this patient. It's us as a group working together towards a common goal, and that's the definition of interdisciplinary. I forgot that swelled. So just a couple comparisons between primary palliative and specialty palliative, because there are times to call the specialist, right? I'm a trauma surgeon. I'm a surgical intensivist. I work in the ICU. I take care of people who have cardiac contusions and myocardial ischemia, and they have AFib, and we treat all that. But when I don't know what's going on, I call a cardiologist, right? When it gets to be beyond my scope. I take care of patients with decreased renal failure, decreased renal function, acute kidney injury, electrolyte or abnormalities. when I can't figure out what's going on, they need to go on dialysis, I call the nephrologist, right? That's what I do. And so the same thing is true for primary and specialty palliative medicine. Basic pain management, all of us. Basic pain, basic management of other physical symptoms, nausea, little Zofran, right? When the nausea is unrelenting and maybe there are some other medications necessary or non-medical integrative therapies, we need to call for specialist palliative care. When I say specialist palliative care, I'm referring to the skill set, not necessarily a person. We do the, we may be pretty good at converting between opioids, but for the complex patients with refractory pain, refractory symptoms, patients who are on methadone who maybe need transition between methadone and other opioids, depending on your hospital and who you have in your resource tool bag, it may be the palliative care team that helps with that. Sometimes patients with addiction problems and serious illness, so that's not an uncommon situation. So you've got somebody who has serious illness, who is a patient that may be seen by palliative care, who also has addiction issues, and that can be difficult to manage side by side. This is the, sort of the total pain piece. All of us should be able to manage basic depression and anxiety, and that's really may just be reassurance, right? Or maybe it's a little bit of medical therapy. Exploration of psychosocial suffering, that can be as easy as how you doing, okay? And then a little silence and we'll let them respond. What's your religion? Can I help you with that? Can I help you find somebody for that? It doesn't mean that I have to sit down and preach, although I stand up and preach, it appears. It doesn't mean that I need to pray with somebody, but I do need to know how to get the right people to the place to help with that. And that's part of my job as a primary palliative care skill set card-carrying physician. The specialty team, however, that's for managing more complex treatment. And that specialty team might be a psychologist, it might be the chaplain, it might be the social worker. It may be somebody actually that the patient formed a connection with previously that is none of those, but is the best person to be at the bedside for this patient. And then serious illness communication issues. I think all of us who've been in this for a period of time are reasonably good at helping the patient explore goals of care in terms of what's going on. What would you like me to do for you? But making recommendations about code status, and I want to stress that for the people who do make for the providers in the room. It's unfair to explain to somebody what's going on and say, hey, so what do you want me to do? I mean, sometimes you just have to make a recommendation. And the way to do that, at least the way I like to do that, is to ask for permission to make that recommendation with the patient. Because we do this not infrequently. We do it, we do it to kids a lot with PD. We explain everything to the parents and then say, well, what do you want us to do? Instead of making a recommendation, putting really a significant burden on either the patient or the family. So that was a side preach. Seeking consensus, whether it's among the treatment team or the family, we all do a little of that. But when the wheels start to come off the bus, or you think the wheels are going to come off the bus, it's time to get that's when you get a palliative care consult, right? When the family, you've got one family says, keep them alive, one family says, let them go, and then you've got the kid's 20 years old, and then there's the 4 other kids that he's been living with for the past 2 years who say, well, actually, no, we know him the best. So there's an opportunity there for some referee work, and that may be your palliative care specialist. Patients who want everything done, again, that's a sort of a classic difficult patient. Patients who invoke the miracle, right? I'm waiting for a miracle. That needs to be explored. That doesn't necessarily, it can be difficult for us. And so maybe we're not the best people for that. Maybe that's interdisciplinary. Maybe it's chaplain, social work, nursing. One of the things we have in Colorado is requests for assisted dying in terms of medical aid in dying, but we also get that elsewhere where the request for hastened death, whether that's voluntary cessation of eating and drinking or liberation from life-sustaining treatments like compassionate extubation. One of the things that I think palliative care does that goes unrecognized and certainly unreimbursed is helping the team deal with and work with the fact that patients make bad choices. And it's hard for us. It's hard for the whole team, whether it's the physicians, APPs, nursing, respiratory therapy, the physical therapists. Patients make bad choices, and it promotes moral distress, and I think some of what palliative care does is just help with that. So, remember this, we got the total pain thing here. And you can see, does this go backwards, we think? So you can see from this that this is a complex diagram, and it's a complex diagram because humans are complex. Suffering is multidimensional. And when we get a patient in the hospital, you know, we don't get a gallbladder, we don't get a femur fracture, we get, you know, a somewhat older trauma surgeon who was driving too quick to get to the talk this afternoon who wrecked his car, right? And so who's taking care of this person? There's really two teams. There's a multidisciplinary team whose function is to work independently to provide their expert skill set to achieve their specific goal in the treatment of this patient. And we need that, right? We need a neurosurgeon to take care of the brain injury, orthopedics to take care of the fractures, trauma surgeons to manage the whole patient, critical care intensivists to manage the patient in the ICU. The interdisciplinary team, however, is a group of professionals who all have their own background and training and their own specialties, who are working together towards a common goal. They're not working, the social worker's not just working towards necessarily the social goal or the religious goal for the chaplain. They're working towards this common goal of relieving suffering and the burden of disease. And so a team that works together, an interdisciplinary team, for the common goal of alleviating the suffering of the patient is an interdisciplinary team. And that is palliative care in a nutshell. It's that group of individuals who are providing that additional layer of support for the patient as they work through the serious illness or injury. So I just put this patient up here just to kind of walk through it and see if this makes sense. So you've got a 54-year-old male involved in two-car motor vehicle crash, and there was a single fatality in the other car. Do we start thinking that maybe this person's going to need more than an orthopedist? So who might they need? They might need a chaplain, they might need a social worker, they might need friends or family. And part of the job is to figure out what they need for that. This same person has multiple facial fractures. They ruptured their right globe. They don't have a brain injury, but they've lost an eye. Multiple rib fractures with hemopneumothorax and a chest tube, and a right upper extremity crush pending multiple operative interventions. So again, who might this person need? Other than they need an ophthalmologist, they need an orthopedist, they might need microvascular hand surgery for the work on that arm. So they need a multidisciplinary team to manage their injuries. However, if we look down further, this person lives in Colorado, so they may or may not be a hiker, but they're a high school history and social studies teacher. They are the baseball coach for their high school team. They're divorced, probably live alone. They have 2 adult children who don't live here, and he's a recovering Catholic. Okay, somebody might relate to that. So you've got a patient now who has this rich history and this rich life, who's potentially looking at being blind in one eye, who is currently in severe thoraco or thoracoabdominal pain, and who may or may not use their arm again. This is somebody who I would submit early involvement of an additional layer of support of an interdisciplinary team to help this person through their hospital course may be of greater value than a lot of what we think of traditionally when we take care of patients. Oh, and he has prostate cancer. So he came in already worried about dying or peeing, one of the two. So, again, I want to stress for the group that total pain is a real and multidimensional phenomenon. Interdisciplinary teams are in my mind, are the key to managing that level of suffering for a person who's injured. And if you look at in the middle, there's always somebody's loved one, okay? And it's important to remember that we're not just taking care of the broken femur, we're not just taking care of the head injury, we're taking care of the person. So, palliative care is not restricted to those at the end of life. It should be delivered alongside of life-sustaining treatment. Pain is not a unidimensional phenomenon, and it requires an interdisciplinary team to manage it. And we, the surgeons, I think, because we're at the forefront of trauma care, we need to create a fundamental culture change where inadequate treatment of this level of suffering for our injured patients is unacceptable. And it's unacceptable to, if somebody gets a pneumothorax from a central line, we jump up and down and scream and we review it, we send it to peer review and try to figure out what's going on. But if somebody suffers through their entire hospital course, we may not even know about it. So there you go, that's what I got. Questions? Any questions or comments? You thought it was that good, huh? Well, hopefully when you take care of people, you have some heart in that. One of the things that I like to say to the residents and my partners is if this job doesn't make you cry from time to time, you're either a bad person or you are not paying attention. So, thanks.
For our last talk, it is me. Thank you. That was nice. Featuring, because I am a rapper, Karen Brady, the speech-language pathologist. So I wanted to talk about trauma for primary care providers for a couple of reasons. This is a little bit of a gratuitous plug so you guys know what we're doing over in the trauma clinic. There's really two topics that I wanted to talk to you about. I want to talk about rib fractures and I want to talk about concussions because those are two of the most common things we see that people don't really know what to do with. So rib fractures, kind of the care of rib fractures has evolved over the years. I pulled this article from the Journal of Trauma and Acute Care Surgery because I thought it was really important to talk about what's currently happening and how we treat rib fractures. This paper is called Non-Surgical Management and Analgesia Strategies for Older Adults with Multiple Rib Fractures. I know that Dr. Kaiden mentioned, Dr. Lysette mentioned that 54% of our population here in Boulder are geriatric patients. Most of them are falls, and a lot of them have rib fractures. And so we were talking about how do we take care of these patients so that they make it out of the hospital and are successful afterwards. Rib fractures are the most serious injury. 55% of the patients over the age of 60 who die following a motor vehicle collision have rib fractures. Morbidity and mortality is due to pain induced by hypoventilation, pneumonia, and respiratory failure. When I chat with patients, I always tell them people don't die from rib fractures, they die from pneumonia. They can't get deep enough breaths, they get sick, and then they die. Nobody dies from rib fractures, they have a lot of pain from it. But really it's the side effects of the rib fractures that increases the morbidity and mortality. And then frailty screening in major trauma is now financially rewarded and should drive geriatric engagement with major trauma. I'm gonna say that again because that's what we're all about this year in trauma. Frailty screening in major trauma is financially rewarded and should drive geriatric engagement. In patients greater than 65, each additional rib fracture increases the risk of pneumonia by 27% and the risk of death by 20%. This doesn't really seem like a sexy topic, but when you're talking about mortalities of this magnitude, we can change how we treat these patients and really impact a lot of people. Rib fractures are a surrogate for major trauma, with 90% of patients having additional injuries. Geriatric patients with rib fractures have a 2 to 5% greater mortality compared with those patients under the age of 60. I found this on Amazon. They are still selling these. I will tell you that I have probably 2 to 3 patients a week come into the clinic and say, oh, I just wrapped up my ribs. We used to do that. Anybody around for the wrap up my rib days? Yeah, we don't wrap up our ribs anymore. Why? Because then people aren't taking big, deep breaths, they're not expanding their lungs, they're getting pneumonia, and they're dying, right? So I routinely have to either take these off of people and be like, oh no, don't do that, or tell them, don't buy this thing that they sell on Amazon for $13 because you have rib fractures. How many people have sprained a something and bought a something off of Amazon? Yeah, totally, I do it all the time. You know, if me as a physician am buying things off of Amazon because I sprained a something, the general population is buying stuff off of Amazon because they've got rib fractures and they hurt, and they're like, oh, I'll just bind them up. How many people know what an incentive spirometer is? Oh, good, everybody. So let's talk about the incentive spirometer because I really love it. It's one of my favorite tools. How many people have seen the little piece of paper in the incentive spirometry package? How many people throw that away when they hand the patient the incentive spirometer? Yeah, totally. This is a paper that was published in 2019. Using the incentive spirometer reduces pulmonary complications in patients with traumatic rib fractures. So the thesis of this, they looked at 50 patients with traumatic rib fractures. This was a prospective study. The patients were randomized to 2 groups. All the patients received the same analgesia. They got a chest x-ray and then checked their pulmonary function at day 5 and 7. 56% of all patients developed pulmonary complications, which was more prevalent in the control group. 80% pulmonary complications in the non-IS group compared to 29% complications in the IS group. PFTs showed decreased forced vital capacity and forced expiratory volume at 1 second in the control group. Comparing pre and post treatment FVC and FEV1, the study group had significant greater improvement. So IS does work. How many people see patients that have an IS sitting in their room and they don't know what to do with it? How many people see patients that have an IS sitting in their room and they have maybe 2 or 3 of them? How many people see the IS machine and the patient try to use it and the patient does this? Right. So we have this tool and we don't really know what to do with it. And then, do we have this tool at all in the pre-hospital setting? Not really, right? So the primary care doctors are not using this at all. I will tell you that I use IS on every rib fracture patient to make determinations on where they need to go in the hospital, on how well they are progressing, how well I'm doing at pain management and control for them. And so it's interesting to me that we have a tool that we know can improve outcomes, but we also are not really using it to gauge where our patients are improving or what we need to do to help them improve. Spirometry, not pain level, predicts outcomes in the geriatric patients with isolated rib fractures. I thought this was a nice study too. FVC has been shown to correlate with outcomes in patients with rib fractures. In this study, they had 86 patients greater than 60 with 3 or more isolated ribs. The patients were assessed on the happy face, sad face scale. Their grip strength, their FVC and FEV1, and their negative inspiratory force on hospital day 1, 2, and 3. Their primary outcome of the study, they looked at discharge disposition, length of stay, pneumonia, intubation, and unplanned ICU admission. FVC, FEV1, and negative inspiratory force and grip strength, which is one of the things that we use as a surrogate to assess frailty in patients, all predicted early discharge for the patient home. Change in pain did not predict outcomes, and pain level was not associated with respiratory volumes. FEV1 remains the significant predictor to discharge home and lower length of hospitalization. This is the paper that you throw away when you give the patient the IS. So if you will look on here, we can use me as an example. I'm age 45, and I am 62 inches tall. And so my expected IS level should be 1850. How many people are like, here's an IS, you should be doing 2,000 on it? Right? We just tell patients, oh, you should be at about 2,000. It's different for everybody, and it's different based upon your age and your height. So really, if I was your patient, you would say, I would expect you to be at 1850 for your IS volume. If a patient is not controlled on the above, I don't know where that slide came from. Disregard that first sentence because that doesn't go there. If the incentive spirometry is not greater than 70% of the predicted value, patient should be admitted to the hospital for pain control. So if my IS is not 1850 or 70% of 1850, there's math in there somewhere, then I should be admitted to the hospital for pain control. We use this technique when we come and see patients in the emergency department. It's really easy to say, oh, this guy really looks great. He's got 4 rib fractures, he's 82, but he is super happy and wants to go home. The first question I always ask is, well, what's his IS? Because inevitably, Pappy looks great, but then when you make him breathe into the breathing toy, he's like, I can't breathe, and that's our indication that he probably needs to come to the hospital for pain control. This is what goes with the sentence beforehand. We try a multimodal approach to pain management. So, there's lots of receptors that control pain. If we target just one receptor, we're missing a whole slew of opportunities for pain control. Tylenol, ibuprofen, oxycodone, or Robaxin. We typically don't prescribe both as a first line. How come? Gravity? Gravity, yeah, you're right. And lidoderm patches. We don't prescribe both because the combination of sedatives and opioids increases your risk of respiratory depression by 5-fold. So you have a 5 times higher risk of dying if you're taking oxycodone and a benzodiazepine at the same time. So what we do when we talk to patients before they leave, and everybody's a little bit different, we say, hey, which drug worked better for you? Okay, let's do that. But we do not send patients home on a benzodiazepine and a narcotic because the risk of respiratory depression is so high. Do we get chest x-rays on these patients? When do we get chest x-rays on these patients? Rib fractures? If their incentive spirometry is decreased, I'll repeat their chest x-ray. So I use IS as a functional tool every day. Hey, where is your IS at? Okay, you're in a good place today. We're making forward progress. If they're on anticoagulation, those patients will always get a follow-up x-ray because your risk of rebleed is a lot higher. Sometimes you break a rib, you tear one of those little intercostal vessels, it spasms so you don't have initial bleeding, but 24 hours later, you may have a hemothorax. And so if a patient's on anticoagulation, I'll typically repeat a chest x-ray. If they have multiple rib fractures, I don't want 1 point of time imaging. I want at least 2 points in time imaging. If they're hypoxic, that one's a little obvious, repeat your chest x-ray. If they're asymptomatic and don't have any of the above, and they have a rib fracture or 3, don't repeat the chest x-ray, they're fine. You don't need to continue to do repeat imaging. Should you always get a CT scan in patients that have x-ray findings of rib fractures? Yes, yeah. Christy's saying yes. I'm saying yes, Christy, you're right. Yeah, there are so many hidden things with rib fractures. Remember I was talking about the geriatric patient that 60% of them will have concomitant injuries that you likely will not catch if you're just getting a plain film chest x-ray. So anybody that's got plain film rib fractures, I will always get a CT scan in them to make sure that I'm not missing another injury. You have to think about more common splenic injury if you have rib fractures of like 8, 9, 10. on this side. Liver, but not so much. Spleen just kind of gets bonked more than liver. So you always are worried about if you have lower rib fractures, you want to make sure that the organ underneath is not also affected. What do you do with flail chest? I have like my own personal emoji right here. Christy just keeps making all the faces at me. She said, yes, that's what you do with flail chest. So a flail chest is 2 or more rib fractures of the same rib. So you have a rib that's broken in more than one segment. Dr. Platnick stepped out of the room, which is good, because he and I maybe don't agree on this. Stabilization or no stabilization is the question. Denver Health is one of the leading centers for rib fracture stabilization in the country, so he is very likely, you can ask him, very pro-rib stabilization. My opinion on it, after reviewing the literature, is that if you have significant chest wall deformity and it is impairing your mechanics, it might make some sense to do rib plating in order to liberate someone from a ventilator or to recontour their chest. So I will say over the years there's been, I don't know, probably 5 or 10 patients that I have said, yes, I think this patient would benefit from rib plating and have actually done rib plating. Denver Health does a lot more rib plating and early on. We'll see what the data shows in a few years, which modality is better. I would say generally most patients do better or get better without an intervention. This is a paper, Flail Chest Injury, Changing Managements and Outcomes. Oops, sorry, go back. The purpose of this study was to assess trends in the management of flail chest over time and to determine the impact on patient outcome. And what they concluded from this study of 720 patients was over the past decade, we've seen an increased rate in the use of regional anesthesia, so epidurals and junctional blocks, and surgical rib fixation in the management of flail chest. This has resulted in lower requirements for duration of invasive mechanical ventilation and intensive care stay, but has not impacted mortality on the patient cohort. I think in this study, the higher use of regional anesthesia was playing a role in that. Traumatic pneumothorax and the review of current diagnostic practices and evolving management. I really love this paper. It was presented, I think at the Eastern Trauma Association last year, looking at the management of pneumothorax. When I first started training, anybody that had a pneumothorax and maybe even a tiny little blip on the CT scan, we immediately were like, we have to put a chest tube in this patient. And so we did, we put chest tubes in everybody. I think the pendulum has swung a bit, and now we are really much more comfortable with saying, okay, this is a small pneumothorax that the patient is hemodynamically stable. We maybe don't need to put a chest tube in that. So in this paper, they practiced 3 centimeters or less was okay to observe, and their overall outcome for those patients were really good. In these patients that I'm going to manage without a chest tube, early follow-up, and strict return precautions. First rib fractures. What we need to think about in first rib fractures, the first rib is really, really a tough bone and very challenging to break. And so if you have the force that is going to break your first rib, there's a very high likelihood that you're going to have an injury to your carotid or vertebral vessels. So we have adopted here the screening for blunt cerebrovascular injury. So when you have a patient that shows up in your clinic and they have rib fractures and it's a first rib as well, just think, oh, I need to screen for BCVI too. I'll jump to the end and say, you can also call me and I'll help you with it. That's all I have on rib fractures. Questions, comments, feelings? Ma'am. Yeah, her question was, are there disadvantages to using like nerve blocks for pain control. I suppose if you hit something while you're putting in your nerve block that you didn't intend to hit, but I would say the likelihood of that is probably pretty low. If you're putting an epidural in, you just have to be mindful of timing for VTE prophylaxis as well, based upon the axial anesthesia guidelines. But I don't think that there's necessarily any disadvantages, and certainly pain control is the significant advantage. Yeah. What else? Ma'am. Thoughts about pillow splinting? Well, I know that people like to hold on to pillows when they cough. That doesn't really offend me. I don't think that, well, I was trying to think, like, would I wrap someone in pillows? And although that may be pleasant. No, I mean, I think that if you need to hold on to something while you're coughing, that's fine. We certainly don't want to restrict the dynamics of chest wall expansion. What else? That was a fun question. Okay, cool, let's talk about concussions. How many people see concussion patients and are like, what do I, Carla said me, what do I do with this? No? Okay. I will tell you, yeah, okay, I've got 3 people that are like, what do I do with this? I did not intend to be the concussion person when I came here. I didn't wake up in the morning and go, gosh, I'm really passionate about concussions. Let's dive into this thing, trauma surgeon. But what I found is that we have a huge need for guidance on what to do with concussions. And so I am, with the help of Brittany Hicks and Janina Corba, my left and right hand, clawing our way to becoming concussion specialists. And so I'm going to share with you a little bit of the knowledge that I've learned in the last year. Really today we're going to focus on the consensus statement on concussions, and this is the 6th International Conference on Concussions in Sport. They are in Amsterdam. This is the latest and greatest sports medicine guidelines for concussions. And it was published in 2023, first presented in 2022. In reviewing the literature, I have not really found great data for concussions when we're talking about trauma patients. There's really great data for concussions and sports medicine. And so a lot of the practices in the concussion and trauma arena are extrapolated from the concussion sports medicine arena. So these are sports medicine guidelines. So what is a concussion? It's a traumatic brain injury caused by a direct blow to the head, neck, or body, resulting in an impulsive force being transmitted to the brain. It's caused by neurotransmitters and a metabolic cascade with or without axonal injury, blood flow changes, and inflammation affecting the brain, which kind of is just things happen up there in the brain and we're not really sure what, but we know it's real. Symptoms may be present immediately, evolve over minutes or hours, or may resolve within a day or be prolonged. For strict definition of concussion, there is no structural abnormality seen on neuroimaging studies. So can a traumatic brain injury also be a concussion? Yeah, so I think one of the things that I have found in having this conversation is people come in and they're like, but do I have a TBI? And the answer is sure. I mean, yeah, you're right, you do. But do I have a concussion? Maybe. So concussion is really the symptoms, right? So traumatic brain injury is kind of the catch-all phrase that we use for you got bonked on the head and something is not right. Now, that could be something that's not right. You have a little bit of a headache. That could be you have a massive subdural hematoma and we need to do something emergently about it. When we talk about traumatic brain injury, classically in the hospital setting, really what we're talking about is a brain injury that has structural CT scan findings that go along with it. And so I think that we actually had a conversation with one of our trauma survivors the other day, and she said, I feel like as an industry, you all, trauma surgeons, don't really put enough thought into concussion just because we don't have something you can't see on a CT scan. Something you can see on a CT scan, right? And she's right. We see probably 5 to 10 patients a week who have a constellation of symptoms, but no blood in their brain per se. I would say the blood in the brain patients are a little bit easier to manage because you know exactly what you are going after and treating, whereas the no blood in the brain patients but have clinical symptoms, it's a little bit up in the air. So let me tell you what we do with these folks. Some of the symptoms: fatigue, dizziness, vertigo, nausea, vomiting, emotional lability, screen sensitivity, headaches, nothing at all. Dr. Fox sent me this one day. He said, I thought of you when I saw this. Be a little chicken tender. Historically, what we have done with medication management, or is to take a multimodal approach again to the concussion patients. So we start with medication management because that's a doing thing that we can navigate, and then we focus on symptom management. So some medications that we often use: histamine blockers, caffeine, antiemetics, NSAIDs, propranolol, and amitriptyline are kind of my third line. Something that I reach for if I can't get people symptom controlled with histamine blockers, caffeine, antiemetics, and NSAIDs. For symptom management, how many of you guys have seen the handout? I don't want to know. Have seen the handout that we hand out to patients in the hospital, we put on their room, and we say, you have a traumatic brain injury. You should not, Sadie's raising her hand. You should not have any screen time. You should keep the room dark. You should not have, yeah, okay, there's like 3 people, good job. 4 people, yeah. So those recommendations are kind of outdated, and we are working on updating those recommendations because the reality is that every concussion is a little bit different, right? I may hit my head and be nauseous and have headaches and nausea. You may hit your head and have sensitivity to screen time and emotional lability. So our approach has rather been not to say, don't do any of these things and sit in the dark and don't have any stimulation, but to say, hey, are you having sensitivity to screen time? Okay, do gradual return to screen time, or try it and then set it down and give yourself a break. Are you having nausea and vomiting? Great, here's some antiemetics. But it doesn't make sense to give somebody antiemetics if they're not having nausea and vomiting. So really, what we're trying to move towards is tailoring our approach to care to actually the symptoms the patient has, not just a blanket, don't do this statement. Does that make sense? Cool. Any Duolingoers out there? Did you guys notice last week that our Duolingo emoji got very angry? I was very sad. I have a new baby at home, and I told my husband I look like the Duolingo bird. But Duolingo bird is now happy again. So the point of the Duolingo bird is symptom management. So decrease noxious stimuli, brain rest when you need it, but that doesn't mean brain in the dark for 6 weeks. And then safety precautions, make good choices. You know, we always talk about, with our patients, emotional lability, and that's a really real thing. And so I think that it's super important just to tell patients, hey, these are the symptoms you might have, and you might find that your fuse is a little bit shorter than it has normally been, and that's okay. Tell the people around you that this is what's going on with you, and so they can respond appropriately too. What if that doesn't work? Our practice is if symptoms persist beyond 4 weeks, we recommend outpatient therapies. Consider speech-language pathology, PT, OT, physiatry, sports medicine, consult neurologist, and then time. I like this this logarithmic arc. And I actually kind of use this analogy with most patients that are trauma patients as they recover, that you're gonna have good days, and then you're gonna have bad days, and you're gonna have good days, and you're gonna have bad days. But you should, in general, be seeing that logarithmic arc or seeing an improvement in your symptom management. So if you are not, then we need to intervene. This is the return to learn strategy, which I think is super helpful. Again, 15 years ago in sports medicine concussions, they would tell patients, just no brain stimulation. And really what they're finding now is gradual tolerance of activities, and patients have better outcomes. The return to learn should be completed prior to considering return to play. So return to play is, again, gradual reintroduction of work or school. You start with light activity. If you do great with that, then the next day you do more activity. If you do great with that, the next day you do more activity until you're back to normal. You should not return to play until you have returned to learn. So if you have not accomplished the things on the first slide, return to your normal activities of daily living, then you should not return to contact football. Trauma patient, if you have not returned to your normal baseline self, you should probably not be out skiing again. Long-term effects of concussions. So there's been lots of studies that examine mental health and the outcome of former amateur athletes, and there's no risk for increased depression or suicidality in these patient populations, which I think is really important. This comes up more than you would think, and I think because there's so much press around chronic traumatic encephalopathy and the professional football players, patients always ask me, if I had one concussion, what does that mean if I get my next concussion? What does that mean if I get my next concussion? The good news is that for the most part, unless you are a professional athlete, your mental health and risk of depression and suicidality should not increase post-concussion. The last facet of the Amsterdam recommendations is the retire. When do we stop doing what we're doing? And we get this a lot too. When should my kids stop playing high school basketball because they've had 2 concussions? I wish there was a clear answer. I wish we could boop, 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 boop in our little calculator and say, this is what you should do. But really the reality is shared decision-making and analyzing the risk-benefit ratio for that person and the impacts of either continuing to play or not playing, and then making some choices together. Okay, now for the best part of the presentation, Karen Brady's gonna come talk to us about what they do in that magical place called outpatient therapy.
Did you put stuff in here for me? Ooh, cool. Okay, green button. So outpatient rehabilitation, we're out in Lafayette, the CMC Medical Building. For those of you who don't know where we are, we have an interdisciplinary team of physical, occupational, and speech therapy. In my experience, when it comes to concussions, one of us will evaluate pretty much every patient. Every once in a while, there might be only 2 or 1 of us involved, but for the most part, the patients tend to see all of us for varying amounts of time for varying reasons. So with PT, these are kind of our main modalities that we're looking at. So vestibular rehab, do people know what a vestibular injury means? And here, everyone knows what that means. I don't have to talk about that. Oh, okay, so it's when some of the crystals in our inner ear are disrupted, and that's what maintains our equilibrium. So we have a lot of, with impact, those can be knocked out of whack, so to speak. So vestibular rehab is all about kind of calming those down, getting them back in place so that your equilibrium comes back. People can have vertigo, people can have dizziness. They do tend to look a little bit different. Gaze instability is a really big one, and I'll talk a little bit more about that. Oh, I forgot to bring my paper up. That's okay. And then just general imbalance. So an example is we're treating a patient who has been wearing the same sneakers for a really long time. She keeps falling from standing, as Liz Lysette talked about. And so one of the PT's recommendations was, well, buy some new shoes, bring them in, let's see how you walk, right? Well, a lot of new running shoes, walking shoes are super cushy, like the Hokas and the big cushy soles. And so she bought some new ones and actually looked worse in those. So PT is really looking at what are some other environmental factors that are going to help your balance. Are you carrying too many things in your hand when you're walking through the house, and that's why you fall, because you lose your balance and you don't want to drop what's in your hand. Craniosacral therapy is another modality that we use. We tend to have patients come to this specifically when their nervous systems are still really, really activated. We might see this more often in people with traumatic injuries from motor vehicle accidents, assaults, just things that really emotionally this event has really done, have been really challenging for them. And so sometimes those people can't really tolerate some of the more traditional vestibular rehab yet. They're way too symptomatic. Their headaches might be 8 out of 10 every day, even with medications. And they're kind of still in fight or flight from what happened to them. And so we do see a lot of people like this. And craniosacral tends to look at this, the supportive structures around the brain and kind of normalizing some of the inflammation and kind of disruptive tightness around those to help people kind of calm down, have a little bit more generalized feeling of okayness so they're not so overwhelmed. And really, when we look at nervous system activation, regulation, our whole team is working on that. We've had the benefit of education from a previous occupational therapist we had who was part of the pain management program. Her name is Sally Thomas. I don't know if anyone knows Sally, but a lot of work around if your nervous system is activated, you're not thinking well, you're not balancing very well, and everything will just kind of go out the window. You're just in that survival mode. And when we have people in therapy that arrive that way, we have to try to get that nervous system to get calmed down. And one of our tools is craniosacral. So occupational therapy, one thing that I really want to drive home is our vision rehab program. It is amazing. Patients are going to complain of headaches while reading, difficulty tracking. Some of our patients will not be really, when they're driving, they're kind of turning their whole bodies when they're looking around because they can't really rely on peripheral vision. So there's convergence and divergence deficits, saccadic eye movement deficits, and some of these are a little bit hard to suss out without that full vision evaluation. And this is different, obviously, from visual acuity. So we're not telling people you just need new glasses. This is more of a visual perceptual problem and how the eyes are moving together and communicating with the brain. And so we have 2 fabulous OTs that are really well versed in this. So even if your patients are saying, well, no, I mean, I can kind of watch TV or I can kind of read. A lot of those symptoms tend to be difficulty reading, headaches with reading, again, not really feeling like they're using their visual, peripheral vision very well. And also what happens is the eyes tend to sort of overwork. So their eyes are always tired, always tired. The safe driver evaluation is a set of clinical tests and motor that look at cognitive, motor, perceptual tests that make sure people are still safe to be operating a vehicle. It is not an on-the-road test. A lot of times we will refer for an on-the-road after a safe driver eval if people perform sort of on the line. When it comes to concussion, some people tend to do this a little bit more as a, like, I would like to go through this to make sure everything's good. Maybe they have chosen not to drive because of their symptoms. They just want to do this to make sure that everything's looking good. Functional energy conservation, sort of like Laura was talking about, it's all about pacing. Gradual return. So yeah, we don't want people in a dark room for 6 weeks because that will lead to increased mental health symptoms and limited activity, so that's just not what we want anymore. But we do need people to pace themselves, and we do need people to understand that it's kind of like a hike up to the arc, right? Like you're going downhill sometimes, you're going uphill sometimes, but you're still gonna get to the top. And complex activities of daily living. So this might be, getting back to work, paying your bills, being able to look at a screen long enough to accomplish something. A lot of our vision rehab folks really can't tolerate screens very long, so it's all about, and also like kind of strategies for reading. We make reading windows where you just have a little sliver in a folder to help you just look at less text on a page. And my favorite, speech language therapy. These are just a few examples of what we work on. I think the one that I want to really point out is this whole idea of metacognition. So we all have this sense of thinking about our own thinking. How does my brain work best under different circumstances? How do I learn best? How do I remember best? How do I, run best? How do I do all the things that I do in the best way possible? And that really requires you to be thinking about, well, how does my brain work in that situation? And that's a big thing that I'm working with people on, is if they are having trouble with memory, well, what is it, how are you trying to remember things? And how, if the old way is not working, how can we help you create a way that will work? Because you're really aware and intentional with it. So metacognition is a really big thing that we talk about, and how that relates to executive function, so planning, organizing. People might say, I'm starting to feel better, but planning an activity with my friends, it just takes too much energy, right? So how do you work through that? People might be ready to go back to work, but not full time. And so we draft a lot of letters to a lot of employers saying, here's what we recommend. Let us know if you have any questions. And I will say personally, I've probably only had one employer come back and say we can't accommodate that. And I've probably written, I don't know, I've been here for 12 years, so lots of letters. So it's really interesting to see that a lot of employers will be supportive when they know how to support. Reading comprehension, generative thinking. So some of our students, I can't write a paper anymore, I can't form a cohesive argument. We try to work on strategies through that. And a lot of this really has to do with pacing and energy. So people who want to just dive back in, they will bomb. So they'll have peaks and valleys with their energy and with their performance, and we're trying to get them to rolling hills. That's where we're trying to get them to be. Energy allocation, it's like a budget. How much energy do you have today? How much can you spend on this task and that task? And then where is your scheduled rest? And scheduled rest is really important because it's taking rest before overload. And when you have overload, no one's thinking. You might be in fight or flight. You might be asleep, right? But we have to get people from a place of, oh, I get overloaded after 2 hours. We've got to help them get a little bit better with more tolerance, greater complex activities, and that kind of thing. So Dr. Harmon has sent us a lot of people. I think our concussion clinic is really strong. We're one of the only places in Boulder County that offers all 3 therapies in one place for neuro rehab. And if you're not sure what to do with someone, if it's been 2 weeks and they're still reporting cognitive problems, they're still reporting physical problems, please send them to us. Don't hesitate, just send them. Because most likely they will benefit from us even if they only see us 2 or 3 times. A lot of education that you guys may not always as providers or in the hospital have time to do. Also, when people are in the hospital, they're in a pretty controlled environment. When they come home, they're realizing, oh, I have to do this, but I got to do this, and I got to go here, and I got to go there. And in the hospital, it's a little bit more controlled, like, oh yeah, you can have therapy now, here's your food, right? So they go back into their normal life and they're really overwhelmed with, what am I gonna do next? What's the most important? So we can really help with that. And sometimes some of these deficits don't show up in the hospital as strongly as they do at home, because we have the signs up that say, please don't, and I'm not dissing the signs are there for a reason, but I think it's really important to always have an education follow-up around, well, what does this really look like in my home, in my real environment? Because it will always look different.
chance. She teed it up perfectly. So I want to tell you a little bit about what we do in Trauma Clinic. Trauma Clinic is a bi-weekly clinic over at the hospital. It's staffed by me and Brittany and Janina, and we see, I would say, 10 to 15 concussion patients a week. Primary care doctors, you don't have to send your concussions to us. You certainly can if that's something that you don't want to manage, or that patient, you've hit your limits of what you were able to manage with them. By all means, please send them over to us. We are happy to see them. Lots of patients we see once or twice, and they move on about their life, and they never need Karen and her team. I would say probably about 30% of patients do, and I would say about 10% of patients really have ongoing symptoms for several months. And so what we provide for them is just medication management and just that consistent follow-up with a provider over the course of their concussion. And I think from a mental health standpoint, our patients that have gone through this process with our clinic really appreciate not feeling like they were alone in trying to get through this on their own. We are also there for all of your trauma and general surgery needs. If you have rib fracture patients, if you have patients that have pain following a trauma, if you have minor trauma evaluations, just send them over to us. We're happy to see everything. We also do PTSD screening and concussion screening. We have access to social work and help really the transition from trauma to getting back to my normal life, managing my trauma, and then the Trauma Survivors Network, which you've heard about earlier today. This is our Trauma Survivors Network page. There's more stuff on it even since this morning, so take a look at it. We're linked in through BCH. Questions, comments, concerns, feelings? Ma'am. Oh, I don't know. I think the youngest we've seen is about 14. Yeah. Any age is the answer, although I would say that there are probably, for true pediatric patients, better folks out there that we can connect you with. So if you have questions about it, send them to us and we can get them in the right place. Ma'am?
So when they're discharged from the ICU, I don't think they're getting this information to go to the trauma clinic. They have follow-up in your office.
Yes.
And do you decide if they go to?
If we're going to send them to speech language pathology after that? Yeah. So used to, in the old days, I think like a month ago, Robin, we had a program where our in-hospital SLPs were calling all of these post-concussive patients that presented to the hospital in general. And I think Robin's predecessor, Allison, and I looked at it about a year ago and found that in 1 month we had 412 patients that screened for concussion that our therapist had reached out to and made contact with like 4 people. And so we thought, gosh, that's not really a great use of our efforts. So let's kind of restructure how we're doing this. So we are reworking our approach to concussions at BCH overall. You guys just got the first taste of it today. Robin's partnering with us on doing that as well. Yes, ma'am. Karen, do you have an opinion?
I think the term in and of itself can be a good term, but I think the question is, how are we educating the rest of the hospital around what it means, right? Is it sort of a blanket statement of don't go in there and don't talk to don't stimulate this patient in any way, or is it really that we're scheduling stimulation and scheduling rest? So I think, and I also think that term
like it. What else? Ma'am. Well, it's Laura Harmon. We are working on it, but the computer wizards were lower on the list. So yeah, if you want to send anything, just send it to Laura Harmon. It will get to me. Dr. Marthaler also is part of the trauma clinic too. So if I am not available, he is there and well versed. Okay, what else? Okay, thanks for coming. It's been a long day. You guys did great. We'll see you next year.